further evaluated. For each patient, total ischemic time was calculated, cardiobiomarkers evaluated, and the echocardiography was performed. And these patients were followed up until discharge, and again at 1 month, follow-up to evaluate mortality. A statistical analysis were performed, and correlation and association were analyzed, and p-value was found to be less than 0.05. That is considered statistically significant. Now coming to the baseline characteristics of this patient. So the mean age group of the patient was around 52 years, and 78% of the patients were men. And the most common cardiovascular risk factor associated with these patients were hypertension and diabetes. And the most common ECG finding was the acute anterior STEMI. Now moving towards the biomarkers and the total ischemic time. So increasing total ischemic time was associated with the extent of myocardial damage. So if it was found out that the patient with increasing total ischemic time, there was a positive correlation with the cardiac biomarkers that reflects the extent of myocardial damage. Moving to echocardiographic findings and the clinical outcome. Regarding regional wall motion abnormality, there was no difference in the total ischemic time. As we can see that the total ischemic time duration was around 12 hours. So there was no difference we can see in the regional wall motion abnormalities. And during hospital stay, there was a significant difference. As we can see that the p-value is 0.0164. Signifying that the patient with prolonged total ischemic time has higher mortality rate during hospital stay, and at 1 month follow-up there was no significant difference in the total ischemic time among those who survived. Now moving towards the discussion. So the prolonged total ischemic time was significantly associated with higher cardiac biomarkers. Total ischemic time didn't significantly differs between the patient with or without regional wall motion abnormalities. In hospital mortality, there was significant difference in those patients with prolonged total ischemic time, and there was no significant association was observed between the patient with total ischemic time and 1 month mortality. This finding reinforces the concept of time is muscle. So the conclusion of the overall thesis is the total ischemic time is very important predictor of myocardial injury and short-term clinical outcomes in STEMI patient. The goal is to reduce the total ischemic time, so to preserve the left ventricular ejection fraction and to improve survival. Early diagnosis and prompt referral is the keystone of the treatment of STEMI patient. So the take-home message is every minute's count. Reducing total ischemic time can reduce myocardial damage and improves clinical outcomes in STEMI patient. Thank you.
Study. So your finding was that total ischemic time or the time lag
Yes, sir.
correlated positively with the biomarkers being high and in hospital mortality too, but it didn't correlate with the regional wall motion abnormality.
Yes, sir.
Right? So if that doesn't lead to regional wall motion abnormality more, that is myocardial dysfunction is not reflected, so what was the cause of mortality? Was it heart failure or arrhythmogenic in these cases?
So the most common cause of mortality among these patients were cardiogenic shock followed by arrhythmia.
This is known fact that the early you intervene, the better are your outcomes.
Yes,
so what additional input you wanted to give with this your study?
I would say, sir, time is muscle, because most of the mortality is due to the pre-hospital delay, because most of the patient just ignore the chest pain. So as early we diagnose, we can improve the survival of the patient.
What do you understand by the term residual risk And tell me some factors which are responsible for residual risk.
Residual risk, I have no ideas.
Okay.
So, were the patients with diabetes also screened for cardiac autonomic neuropathy?
Yeah, it can, sir.
So, is it important in the context of your study?
Yeah, because it increases the risk of atherosclerotic plaque formation.
Beyond that, you were looking at time from onset of symptom to time of perfusion.
Yes, sir.
So, how does cardiac autonomic neuropathy in diabetes influence that?
It can delay because most of the patient cannot perceive the pain.
So, silent MI.
Silent MI, we can say.
And regarding the regional wall motion abnormality, the p-value was about 0.06.
So it was not significant.
So, if you increase the sample size, could it have been significant?
No, sir.
Was it a powered study? Did you look at the sample size calculation?
I don't think so because, sir, there may be regional wall motion abnormalities in the patient who present early, we say.
Thank you, well done. We can call up the next candidate. Dr. Pranay Srivastav.
Good morning, respected judges and delegates on and off dais. Myself, Dr. Pranay Srivastav from IQ City Medical College. I am going to present efficacy of saroglitazole 4 mg daily versus vitamin E and omega-3 fatty acid fixed dose combination twice daily in patient with metabolic associated steatotic liver disease, MASLD, a prospective pilot study. So, as we know, sir, saroglitazole is a dual peroxisome proliferator activator of alpha and gamma, approved for metabolic associated steatotic liver disease in India only. And we also use vitamin E and omega-3 fatty acid, though it is not approved, but it is used as off-label since ages. And very few head-to-head comparison of studies. A comparison of saroglitazole versus vitamin E and omega-3 fatty acid combinations are studied for effectiveness in MASLD. And so we conducted a prospective pilot study in patients treated with saroglitazole versus vitamin E and omega-3 fatty saroglitazole versus vitamin E and omega-3 fatty acid fixed dose combination to compare their efficacy. So we took various parameters like derived from the transient liver elastography, fibroscan like CAP and LSM. LSM measures liver stiffness, which suggests more advanced, higher the value, it is more advanced fibrosis or cirrhosis. And CAP measures liver fat, and higher the value, the higher fat content. So they are used together to diagnose MASLD and fibrosis. Considering efficacy of saroglitazole as 55% by previously conducted studies, we took 104 participants in each group, and we assuming 20% dropout rate, and we also took 20% required sample since it is a prospective pilot study. So we have a number of participants, 25 participants in each group. We use descriptive analysis, paired and unpaired t-test, Wilcoxon sign rank test, Mann-Whitney U-test, chi-square test to analyze the result. All the p-values less than 0.05 was considered as significant. So methodology, it was an observational prospective pilot study. Diagnosis was based on liver transient elastography. Patient who received saroglitazole 4 mg once daily were included in group A, and patient who received vitamin E plus omega-3 fatty acid fixed dose combination were included in group B. So there were 25 cases in each group. Also, apart from that, the patient received a standard treatment which includes the lifestyle modifications for their concurrent and other medication for their concurrent disease. Relevant socio-demographic and clinical parameters like age, gender, residence, body weight, serum triglyceride, CAP, LSM were compared at baseline and at a follow-up of 24 weeks For improvement in fibrosis outcome, ethical clearance was taken, approval was taken. So, coming to the result, we compare when baseline parameters were compared. So there were no significant changes in age, demographic parameter changes in age, gender, or residence in both group A and group B, and also in elastography result, we found no changes in CAP, body weight, triglyceride, LSM at baseline. But when we compared the within the group from baseline and up to 24 weeks follow-up, we find there was a significant change in both in body weight, triglyceride, LSM, and CAP in both the group A and B, the one which is taking saroglitazole, and another group which takes vitamin E plus omega-3 fatty acid fixed dose combination. And there was a significant difference in, from baseline up to 24-week follow-up. And this is very interesting when we compare the changes from between the groups. There was a significant difference found in body weight. For group A, we found that there was a change of 2.1 kg, average change of 2.1 kg from the baseline, while group B only 0.9 kg was the change was there, which is very significant. And likewise in triglyceride, there was change of average 125 milligram per deciliter in group A, which is taking saroglitazole, and there was only 54 milligram per deciliter change in group B. CAP also, there was 39 decibel per meter change in saroglitazole group, and in group B, it is close to 25 decibel per meter. And in LSM also, we found a significant change between the group. It was 2.1 kilopascal in saroglitazole group and 1.2 in. So, to summarize the result, we found no statistically significant difference in body weight, serum triglyceride, control attenuation parameter, LSM values at baseline between the groups. As per within the group analysis, we both groups A and B had significant reduction with p-value 0.001 for all comparison. However, average reductions in all these parameters were significantly higher for saroglitazole, that is group A, than vitamin E and omega-3 fatty acid fixed dose combined from baseline to follow-up. So the present study demonstrated that both saroglitazole and the fixed dose combination of vitamin E plus omega-3 fatty acids significantly improve body weight, serum triglyceride level, and non-invasive marker of liver fibrosis. However, the magnitude of improvement was significantly greater in the saroglitazole group. The superior efficacy can be contributed to its dual mechanism of action, acting on both alpha and gamma receptor, and activation of PPAR alpha enhances hepatic active acid oxidation, and PPAR gamma improves insulin sensitivity. There were no conflict of interest. The source of funding was we have self-funded and I accept the fact that since it was a pilot study and number of study participants were less, so I accept the fact. We aim a further study with more number of study participants in future to arrive at a better conclusion. These are my reference, and thank you so much.
Good. So you said this was an observational study or an interventional study? Was it an observational or interventional study?
Sir, it was an observational study.
Observational. That means you just observed, you didn't randomly allocate.
No, sir.
That's it. Number one. How did you define who were having fatty liver by those VCT parameters? Means who were the entry point patients inclusion and exclusion
Sir,
criteria so far as the BCTE parameters are concerned?
Sir, since we conducted this study on OPD patient only, so liver elastography was the parameter or the investigation. We have excluded the patient who are alcoholic, who is suffering from chronic liver disease.
No,
already.
that's all right. Means at what entry point and exit point of cap value did you or your teachers recruit? Means with a cap say of 110, did you include or 240 or 300? Likewise, with fibrosis say LSM of 14, 13, did you include? What was the range of cap and LSM that you included in the study?
Sir, it was the range of 2 to 7 for cap, and it was less than 328 for LSM, which we consider normal. Any increase in LSM beyond that point?
LSM will be lower, not 328, less than 8.
LSM is in kilopascals
Yes,
and
sir.
cap.
8 possibly you're talking
Yes,
about.
sir.
So in your study, did you include patients with type 2 diabetes and MASLD?
No, sir. Since we have not conducted diabetic.
No, what I mean to say is that in those 50 patients that you included in your study, did none of them have diabetes? Was diabetes an exclusion criteria?
No, that was not exclusion criteria, but sir, we have conducted, didn't go for the, no, it was an inclusion criteria, the patient.
Like in these patients, did they have diabetes or none of them had diabetes?
Sir, some of them have diabetes and some of them.
If some of them had diabetes, did your ethical committee say that you are using an off-label drug?
Yes, sir.
Why? So vitamin E in fatty liver disease, what's the indication for use? Can you use it in diabetes with MASLD, or is it not allowed to be used there?
Sir, it can be used in diabetes also.
Cannot be used in diabetes with MASLD. Without diabetes, MASLD is the indication. So it would be a off-label and the ethical committee might have flagged it.
Okay,
You said observational study. So if I have understood correctly, you just followed up people who are using saroglitazar, people who have used the FDC.
Yes, sir.
Is that correct?
Yes, sir.
On what basis that FDC was prescribed or saroglitazar? It prescribed by somebody else or you?
No, sir, it was not prescribed. It is observational study, sir. I took data from the.
So it is just somebody who is being followed up and then you continue to see how they have improved with these two drugs.
For the 24-week outcome, I have seen the data and.
Okay.
Likewise.
Just tell approved drugs for MASLD.
Sir, glitazones like pyoglit.
My question is very simple. Just name approved drugs for MASLD.
Sir, is the SGLT2 inhibitors?
Thank you.
Okay, well done. Can we ask the next participant, Dr. Praveen Kumar Yadav, to come up, please?
Good morning, everyone. My name is Dr. Praveen Kumar Yadav, third year DNB resident, Department of Emergency Medicine, Health World Hospital, Durgapur and West Bengal, India. So my study is lung ultrasound and anti-proBNP in acute heart failure, a prospective observational study in patient presenting with acute dyspnea to the emergency department. So disclosure, my study has no external funding, so author declares no conflicts of interest in the design. And this thesis is approved by the Institutional Ethics Committee, Health World Hospitals, and conducted as a part of DNB thesis under the National Board of Examination in the Medical Science, New Delhi. So the background and rationale, the clinical problem is acute dyspnea is among the commonest emergency department presentation. So to differentiate between cardiac and non-cardiac causes overlaps and are hard to distinguish clinically. Echocardiography is accurate but needs expertise, equipment and time, often not feasible immediately in a busy emergency department. Lung ultrasound, that is B lines and anti-proBNP levels are rapid, bedside and repeatable tools, but region-specific evidence on their combined and serial use is limited. So the Indian patient differ from Western cohort in age, comorbidity burden and disease severity at the presentation. So why this study? Because few studies systematically evaluate lung ultrasound and anti-proBNP together and serially over the time in Indian ED patients with acute dyspnea, and combining a bedside imaging test with a biomarker may reduce diagnostic uncertainty and support earlier and more confident treatment decision. So the serial assessment at admission, at 24 hours and at 72 hours captured treatment response, not just a diagnosis at a single time point. So the main aim is to evaluate the role of lung ultrasound and anti-proBNP level in diagnosing acute heart failure in a patient presenting with acute dyspnea in emergency department. The primary objective is to examine the correlation between anti-proBNP levels and B lines on lung ultrasound in a patient with acute heart failure at the time of admission. And the secondary objective is to assess the serial changes in lung ultrasound findings and anti-proBNP levels after 24 hours and 72 hours of therapy. So methodology, it is a single center prospective observational study held in the Department of Emergency Health Ward Hospital of duration 18 months. Total sample size was 115 patients. The inclusion criteria is age greater than or equal to 18 years and undifferentiated acute shortness of breath at ED presentation. So the key exclusion criteria is pleural effusion, that is more than 2 quadrant, pneumothorax, interstitial lung disease, confirmed pneumonia, and history of lung resections and cancer, mechanical ventilation and pleural drain and pregnancy. So the simplified study flowchart is the patient presenting with acute dyspnea came in emergency department after first history and physical examination, and taking the consent, we do the initial assessment with lung ultrasound and baseline anti-proBNP level. And after 24 hours, we repeat the lung ultrasound and anti-proBNP levels, and subsequently at 72 hours, we repeated this and saw the therapy response tracking change over the time. So the primary endpoint is diagnostic accuracy of lung ultrasound and anti-proBNP level for acute heart failure. So let me discuss few points about the lung ultrasound, that is according to the blue protocol, that is bedside lung ultrasound in emergency. Just you have to put the linear probe in the upper anterior lung side and lower lung side and flaps one, that is posterolateral alveolar lung space, and just see the vertical lines that is starting from the pleural space and covering whole captures. So that is the B lines. So we have to see the number of B lines. If greater than or equal to 3, it is significant. It signifies that his patient is having heart failure and having increased hydrostatic lung pressure that causes the interstitial edema and alveolar edema. So my result is the total B lines had been counted, and the median of total B lines, that is at admission, was 38, at 24 hours 22, and at 72 hours 12. So it reduces significantly. And the mean anti-proBNP level at the baseline at the time of admission in the emergency department we have sent, that is 6,996, and at 24 hours 4,539, at 72 hours 2,428. So at admission, that is 96.5% score, that is greater than 30 lung comet score is there, that is just so severe congestion at the time of admission, and at 24 hours, that is 100% shifted to 16 to 30 category, that is the number of lung B lines had been reduced, that is lung comet score. Then at 72 hours, it came scored between 0 to 5 lung comet score. And second result is correlation, that is anti-proBNP level versus lung ultrasound B levels, that is R is equal to 0.682 and P value is 0.003. that is strong and statistically significant positive correlation between baseline NT-proBNP levels and B lines counts. Higher biomarkers levels tracked with greater pulmonary congestion on lung ultrasound. And heart failure subtype by ejection fraction, heart failure with reduced ejection fraction was the most common subtypes, consistent with the predominance of reduced systolic function in the emergency department population. So how this adds to the clinical practice? That is the faster triage, that is the bedside lung ultrasound and NT-proBNP level can differentiate cardiac from non-cardiac dyspnea within a minute without waiting for echocardiography. Serial B lines count and NT-proBNP levels trends offer a quantifiable way to track decongestion during the first 24 hours of the therapy. Combined accuracy, that is integrating imaging with the biomarker data, reduces misclassification since each state's limitations, false positive and negatives are offset by the other. That is, fourth is the regional evidence which occurred in the Indian population. The strength, this is a prospective real-world ED design, serial assessment at three time points, that is 0, 24 hours and 72 hours. Standardized blue protocol scanning and structure pro forma reduce measurement variability. Limitation is single center study, modest sample size, that is 115. Lung ultrasound is operator dependent and NT-proBNP level influenced by age, renal function, obesity and systemic illness. So this conclusion is a lung ultrasound and NT-proBNP levels both improved progressively with the therapy, and strong significant correlation links baseline NT-proBNP level with B lines burden. And combined bedside imaging and biomarker assessment can support earlier diagnosis and objective monitoring of acute heart failure in the emergency department. These are my reference. Thank you.
You have said something about differentiating cardiac versus non-cardiac, but data is not shown how these two parameters helped you in differentiating.
Sir, actually, if we will see the flow charts of our study, we do the lung ultrasound at the time of presentation. If it is non-cardiogenic pulmonary edema, we exclude it, actually. We just see the cardiogenic pulmonary edema.
So is this going to help in differentiating those two?
No,
Cardiogenic versus non-cardiac pulmonary edema?
No, sir. Actually, the main objective is used start decongestion as soon as possible.
Correct.
So we just do the lung ultrasound. If non-cardiogenic, we have excluded actually from the study.
So that whatever point you mentioned about differentiation, that was excluded prior hand.
Yeah, non-cardiogenic has been excluded, sir.
Okay, just tell some drugs which have shown mortality benefit in heart failure.
Sir, that is diuretics and
Mortality benefit in heart failure.
angiotensin receptor inhibitors, ACE, ARBs, and
Okay. Which diuretic has given mortality benefit? Since you have said so.
no, sir, by chance.
No, there is a diuretic which has given.
Sir, ये spironolactone.
Anything else? ACE inhibitor ARB or anything added to an ARB?
Sir, SGLT2 inhibitors, and one is
What is ARNI?
ARNI, sir, ARNI.
What is that?
This angiotensin receptors, natriuretic inhibitors, sir.
One is valsartan, that is an ARB, and it has another component. What is that drug and what does it cause?
So NI stands for?
Sir?
ARNI, angiotensin receptor, and
Naprolysin inhibitor.
inhibitor.
Okay. So in your study, you didn't mention about improvement in clinical features or symptoms. You only spoke about NT-proBNP and ultrasound. So what if these patients clinically went bad, deteriorated, and your biomarkers improved?
Actually, sir, I just focus on the NT-proBNP levels, and
I understand, but the patient has to get well, not the reports.
yes, sir. With biomarkers and B lines as reduces, the clinically also patient gets.
Should do, but did you look at this? You didn't mention about anything about symptoms or clinical features.
Yes, sir.
Thank you.
Thank you, sir.
Should I start?
Go ahead.
Start करें? Good morning everyone. I am Dr. Swati Singh, a PG DNB third year resident from Department of General Medicine, Health World Hospital, and today I will be discussing my study, which is evaluation of cardiorenal benefits of SGLT2 inhibitors in type 2 diabetes mellitus patient. So I have taken basically 3 drugs, dapagliflozin, empagliflozin and remogliflozin, and the question of the study is, even if these drugs have same mechanism of action and belong to the same group, do they really differ in their cardiorenal properties? So before starting, I would like to state that I have no conflicts of interest, no external funding and no financial relationship with any pharmaceutical companies. The study was approved by the Institutional Ethics Committee and all written informed consents were taken from all the participants. So before starting, I would like to start with the epidemiology that in worldwide the population of the diabetics are increasing and the burden is even more in India, and with every passing years the number of diabetes patient is increasing. So nowadays diabetes is no longer a disease of hyperglycemia, it comes with the cardiac risk and renal risk. Every type 2 diabetes patient have almost 2 to 4 times higher cardiovascular events, and diabetes is the leading cause of CKD. So this gives the term cardiorenal syndrome, means the cardiac dysfunction can lead to renal hypoperfusion, and renal dysfunction can lead to impart stress on the heart by neurohormonal mechanisms. So different SGLT2 inhibitors acts via the same mechanism. So where is the research gap over here? So there are no direct head-to-head comparison in our given between 2 different drugs. All the studies which is being done right now till date is when comparing with a placebo, any one drug comparison with a placebo. So this is what I wanted to do. So my aim was to compare the cardiac and renal benefits of 3 drugs, dapagliflozin, empagliflozin and remogliflozin with type 2 diabetes patient, and my primary objective was to compare the cardiac outcomes using the following parameters: acute coronary syndrome, coronary revascularization, heart failure with hospitalization and CV death, and renal outcome using CKD progression, acute kidney injury, renal death. And secondary objectives was to show any improvement in the glycemic parameters, metabolic parameters, any adverse effects. So let's see whether the drug has a difference in the cardiac or renal outcomes. So my study is a single-centered prospective comparative observational study done in the Health World Hospital, and the study duration was 18 months, and the patients who all matched the inclusion criteria was being followed up by me for a period of 24 weeks, and the parameters of like cardiac parameters, renal parameters was taken at the baseline 12 weeks and then at 24 weeks. And I have done the sampling by using universal sampling method. So all the patients who were included and who matched the inclusion criteria, which is age more than 18 years of age and type 2 diabetes without are being taken, out of which 15 were lost to follow up. And these allocation of the drugs was done by the primary physician, and which was non-randomized. 45 individuals were given dapagliflozin 10 mg OD, 43 were given empagliflozin 10 mg OD, and 25 were given remogliflozin 100 mg BD. So before starting telling the results, I would like to state that the baseline characteristics of all the 3 groups were comparable. Most participants across the group were of mid-age group, male predominant, obesity was common in all 3 groups, and all the baseline comorbidities were common. So the primary thing which we all know is that they do reduce the glycemic index, they do reduce the HbA1c values over the period of 24 weeks. Dapagliflozin decreased it by 1%, EMPA by 1.08 and remogliflozin by 1.07. Postprandial and fasting levels also decreased, but the question of my study was not showing this. The question was whether it has a benefit of over cardiac or renal. So it has definitely shown a benefit on the renal cardiac functions. The NT-proBNP level has been reduced over the periods of 24 weeks. The left ventricular ejection fraction was improved most in empagliflozin from 49.4 to 55.4, and then for DAPA. And global and longitudinal strain patterns also improved similarly. But one thing was noticed that with remogliflozin, there was hospitalization for heart failure percentage 8%. And renal outcomes also showed the similar thing, but there was one thing that the DAPA and EMPA kept the eGFR and serum creatinine largely stable with consistent fall in urine ACR, but Remo shows a steeper decline in eGFR from 78 to 71.9. And there was also increased incidence of AKI and renal replacement therapy. So this was the comparison table which shows that overall the greatest improvement in cardiac outcomes was with empagliflozin, and remogliflozin showed less decline in the GFR. So this was my key takeaways, that all the 3 SGLT2 inhibitors produce comparable sustained improvement in glycemic control. Cardiac markers improved with all the 3, whereas with remogliflozin the GFR decreased. Adverse effects were mild and manageable, and no major adverse effect was there. But it also comes with certain limitation, that my study was a non-randomized design done in a single-centered, a very small group sample size for remogliflozin, and very short period of time follow-up, which could be done in future studies. Thank you so much.
You said that your study was non-randomized.
Yes,
Why
sir.
didn't you try to randomize? Was it very difficult to randomize? How would you have randomized?
So I would have taken the patients and I would have randomly allocated the.
So how do you randomly allocate? Means if you have 3 groups, how do you randomly allocate? You didn't do it right, but if you were to do, how would you
So simple randomization, stratified randomizations.
how do you do a simple randomization?
So I will give the first one the DAPA, second one the Remo, then third one the EMPA, then again first one the DAPA, like that.
That's not,
Serial wise.
that's a purposive sampling. You could have done at least that also. You could have used a random number generated table and give it. Now, you said that in the remogliflozin group, the patient, some of starting eGFR of all these 3 groups.
So I have excluded all the patients with GFR less than 45. So all the patients were having GFR 45 or above 45 only.
So you don't know the mean, but it was above 45.
Above 45.
But in how many patients did in the remogliflozin group they required renal replacement? I mean dialysis, probably hemodialysis. And probably I think this is because of AKI. So it is rather surprising that the patient was not requiring any renal replacement therapy. Only with 24 weeks of SGLT2 inhibitor therapy, patient landing up in AKI necessitating renal replacement therapy. Is it quite that common? And what was the cause of AKI, and how many patients were there? And what were the details of those patients who required renal replacement therapy? You said 8%. So how many patients out of 25, 8% means who are the patients?
So out of 25, 8 patients means.
8%.
8% means around 3-4 patients.
So who were the patients? Why did they require? How did they behave?
I think, sir, most probably they were old age patients. That's why they were they might be having some baseline renal issues.
How do you define cardiorenal syndrome?
So, patient is who is having any cardiac abnormality and also having reduced EGFR along with it.
How many types of cardiorenal syndrome do you know of?
So, 2.
Okay. And when you give SGLT2 inhibitors, what do you expect which happens to EGFR?
So initially the EGFR reduced by 10 to 20% due to tubuloglomerular feedback, but this only happens for a brief period of time. Later on the GFR should increase.
Okay.
So we know that we have published data in heart failure with dapagliflozin, empagliflozin. So your study showed something which was not there in those trials. Do you know what? You showed something in your study with DAPA and EMPA happening, which was not seen in the heart failure trials with DAPA and EMPA.
So my studies is basically showing that EMPA is superior.
You showed a finding which was not there in those trials, which is improvement in ejection fraction. It was not there in the published trials.
Sir, yes.
So do you know what is heart failure with improved ejection fraction? Have you heard of it?
Yes, sir.
So what is it?
When the patient with reduced ejection fraction, when comes for the follow-up with increase of 5 to 10% of the increase.
Which drug is known to cause heart failure with improved ejection fraction?
Sorry, sir?
Which drug helps in heart failure, in causing heart failure with improved ejection fraction? ARNI, ARNIs. But not SGLT2 inhibitors. But that was interesting. In your study, you showed ejection fraction improving with the agents.
Thank you, sir.
Good morning to all the respected judges and delegates present here. I am Dr. Obhinav Pal, first year postgraduate trainee from Department of Community Medicine, IQ City Medical College. My title for today's presentation is Burden of Diabetic Kidney Disease and its association with the triglyceride glucose index among type 2 diabetes mellitus patients in Durgapur, West Bengal. Here is my disclosure. Coming to the introduction and rationale, diabetic kidney disease is a common microvascular complication of type 2 diabetes mellitus and a leading cause of end-stage renal disease. Estimated glomerular filtration rate, that is EGFR, and spot urine albumin to creatinine ratio remain the standard markers, but they are often costly and not feasible in resource-limited settings. The TYG index derived from routine fasting blood glucose and fasting triglycerides is a simple, low-cost surrogate marker of insulin resistance. There have been several studies which have linked a rising TYG index to DKD risk, but comparable data from the urban population in West Bengal, especially Durgapur, is very less. My objectives were fourfold: to describe the clinico-social characteristics of type 2 diabetes mellitus patients attending a diabetic clinic in Durgapur, to determine the prevalence of DKD among the study participants, to find the association between the TYG index and diabetic kidney disease, to determine the association between the TYG index and BMI among the study participants. Coming to the materials and methods, my study was a clinic-based observational descriptive study, cross-sectional in design, conducted in a diabetic clinic in Durgapur, West Bengal, which served an urban population. The study was conducted over a duration of 3 months from May 2026 to July 2026. The inclusion criteria had all the patients who were aged 18 years and above having a case of diabetes, type 2 diabetes mellitus as per ADA 2026 criteria and gave informed written consent. For exclusion criteria, all other forms of diabetes were taken. Any patient with known end-stage renal disease, patient on diuretics, any known case of glomerulonephropathy or having UTI at the time of enrollment, patients on steroid therapy, pregnant women, and any case of known malignancy or patients who were critically ill. The sample size was calculated using the Cochrane's formula, where I have taken the expected prevalence of DKD as 0.47 from a previous study by Malpani Y et al. In Bhubaneswar, Odisha, a 95% confidence level. Absolute allowable error was taken as 10%, and after adding 5% non-response, the final sample size came to be about 100 study participants. The technique used was systematic random sampling. The dependent of the outcome variable was the presence or absence of diabetic kidney disease. The independent variables included clinico-social characteristics, biochemical parameters, BMI, the triglyceride glucose index, and eGFR. The key definitions include the TYG index, which was a natural logarithm of the fasting triglyceride multiplied by fasting blood glucose divided by 2. The eGFR was calculated by the standard CKD EPI 2021 formula. The diabetic kidney disease was explained as per the KDIGO criteria of either spot USCR of 30 mg per gram or more, or eGFR less than 60 ml per minute per 1.73 meter square, or presence of both together. And obesity was defined by the South Asian cutoff of 25 kg per meter square or more. The study tools included a pre-designed, pre-tested semi-structured schedule incorporating the socio-demographic variables, duration of diabetes, history of hypertension, a calibrated digital weighing machine, a non-stretchable measuring tape, and a stadiometer for height. The technique incorporated was face-to-face interview. All the anthropometric measurements were taken following standard operating procedures. Fasting venous blood sample and spot urine sample were collected to measure the biochemical parameters as per the standard laboratory methods. Various methods of statistical analysis were used. The two softwares that I used were MS Excel and IBM SPSS version 16. A p-value of less than 0.05 was considered statistically significant throughout the study. Now coming to the results, Table 1 and Table 2 show the clinico-social characteristics of the study participants. The median age of the population was 61 years and the median duration of diabetes in the study population was 5 years. 67% of the study population were male and almost half the study population were obese. 39% of the study population had a history of hypertension and were having good glycemic control. The prevalence of diabetic kidney disease in the study population was found to be 40%. Table 3 shows the association between the TYG index and various clinico-social characteristics with the diabetic kidney disease status. In the patients who were having diabetic kidney disease, there was a significantly higher median value of TYG index and total cholesterol. The male gender, hypertension, very poor glycemic control, taking HbA1c as 8% or more, had significant association with the diabetic kidney disease group. However, obesity did not show any significant association. The TYG index had a strong positive correlation with the spot urine albumin to creatinine ratio with a Spearman's rho of 0.739. It had a moderate correlation with HbA1c having a Spearman's rho of 0.362. However, there was no significant correlation of the TYG index with eGFR or BMI. And I have shown a scattered matrix plot showing the correlation between the different predictors of diabetic kidney disease. After ROC curve analysis, an optimal cutoff was calculated for the study population, which came out to be 9.0045 for the TYG index with a sensitivity of 92.5% and a specificity of 85%, thereby showing the diagnostic accuracy of the TYG index and an area under the curve of with 95% confidence interval 0.919. In univariate logistic regression for the predictors of diabetic kidney disease, almost all the biochemical parameters showed significant values and had significant odds for the diabetic kidney disease. However, after adjusting for potential confounders in the final multivariable logistic regression table, the triglyceride glucose index had significant and independent association with the diabetic kidney disease. The male gender and very poor glycemic control also showed a significant association. However, hypertension lost the statistically significant association after adjusting for confounders. The different values show that the final table had a goodness of fit, and the pseudo R-square value of Nagelkarke and Cox and Snell also explained the variation of DKD in the study population. So here is a summary of my results. Overall, the prevalence of DKD was 40%. The TYG index was significantly higher in patients with DKD, and it correlated strongly with spot urine ACR and HbA1c. It remained independently associated with DKD on multivariable logistic regression and had good diagnostic accuracy. Now coming to the discussions and conclusion, comparing with available literature, our findings were largely consistent with previous studies. The Malpani et al. Study from Bhubaneswar, Odisha had a DKD prevalence of 46.7%, whereas our study had a similar DKD prevalence of 40%. When the ROC analysis was compared, our study had a better area under the curve of 0.919. Compared to Shankar et al. In Uttar Pradesh, our study had good correlation with spot urine ACR, similar to the study. Similar to Liu et al. In China, the TYG was significantly and independently associated with DKD. And in comparison with Gao et al. Study from China, the TYG index showed equivalent sensitivity and specificity like the two other standard markers. So we can conclude that the TYG index is significantly and independently associated with diabetic kidney disease in this population. It shows a good discriminatory ability and can serve as a simple, low-cost surrogate marker for the screening of diabetic kidney disease in resource-limited outpatient clinics. However, this is a cross-sectional study, therefore further multicentric larger studies, longitudinal studies should be conducted to have a better result. Here are my references, my acknowledgements. Thank you.
Thank you. I ask you two basic questions.
Yes.
First, you said a certain proportion of patients did have diabetic kidney disease, some didn't. How did you define diabetic kidney disease? The presence of DKD.
So in our study, since it was a cross-sectional study, we took the values of spot urine albumin to creatinine ratio and estimated glomerular filtration rate.
What were the thresholds?
So for EGFR, it was taken as less than 60, and for spot urine albumin to creatinine ratio, it was taken as 30 or above. Presence of either of this or both together was used for diagnosing, but so there was a certain limitation as per the KDIGO-based guidelines. This should be persistent for a period of 3 months or more, but there have been studies where a single snapshot value has been taken for screening purposes, so we did take a single value.
You took a single value for microalbuminuria too?
Yes, sir, for both, for UACR and EGFR both.
Right.
TYG glucose actually came as a surrogate marker for metabolic syndrome. Your BMI did not show any correlation with that.
No, sir.
Any comments? Why?
Sir, it might be possible because since the patients were already on medication, most of the patients were on follow-up basis coming to a diabetic clinic. So it might be a possibility that the BMI was improved after starting therapy. So that could be a reason.
So in a patient with diabetes on statin, you do 10 serial cholesterol values on 10 days and you do 10 serial triglyceride values on 10 days. Which is likely to be more variable?
So can you say it again?
You take a patient with diabetes on statin. For the next 10 days, you do a serum cholesterol every day. For the next 10 days, you do a serum triglyceride every day. Which is likely to be more variable, vary a lot? Cholesterol or triglyceride? Suppose in the same patient, inter-day variability, which is likely to be more?
So cholesterol should...
no, triglyceride. Why?
So
Okay.
because insulin resistance is...
What are the determinants of serum cholesterol and what are the determinants of serum triglyceride?
So serum triglyceride can increase, like in our study, if there is insulin resistance, there is increase of... like.
Okay, well done. We now call upon our final candidate, Dr. Riya Pandey.
Good morning, everyone. I'm Dr. Riya Pandey, a second-year pediatrics resident from Durgapur Steel Plant Hospital. And today I'd like to talk about a case that we recently encountered, which was a true diagnostic challenge for us. So we had a 3-month-old infant who came to us with fever and a complaint of crying during micturition for the last 4 to 5 days. Upon examination, the child was found to be undernourished with parameters like length for age and weight for age suggestive of failure to thrive. As for the birth history, the child was born at 34 weeks via a non-consanguineous marriage and had IUGR. The child was admitted in our NICU for around 16 days due to neonatal jaundice, neonatal sepsis and anemia of prematurity. And the child also had a sibling who died at the age of 2 months, likely due to sepsis. So at this point, like we do with all children, we send routine blood investigations, and it was while drawing this blood that we found that the samples were highly lipemic. And this was our first clue that we were dealing with something unusual and prompted us to dig deeper. At this point, the urine examinations that were sent, it revealed glycosuria, and that prompted us to check the child's blood glucose levels, and that came out to be 855 mg per dl. And to put this into perspective, a normal neonate's blood glucose ranges from 45 to 120 mg per dl, which makes this an extraordinarily high value. But despite this severe hyperglycemia, the child did not have any ketone bodies in the urine. So at this point, we had a child who presented to us with fever and what seemed to be like an infection, but the lab picture, it showed us a complete different view, because the child was found to have hypertriglyceridemia with triglycerides of 4082 mg per dl, which is more than 50 times the upper limit of normal in a child of this age. Along with that, the cholesterol levels were also high, and the other findings of hyperglycemia, glycosuria and failure to thrive were also there. So at this point, it was evident that a single infection could not explain all this, but before we could go for the differentials, we had to focus on stabilizing the child, for which the child was initiated on IV fluids and IV antibiotics. Insulin infusion was also started at 0.1 IU per kg per hour with close monitoring of glucose levels and serum electrolytes. And in order to decrease the fat intake, the child was started on a diet of MCT oil and skimmed breast milk. So at this point, we had to look for differentials which could explain both the hypertriglyceridemia and hyperglycemia in this child. So our first consideration was stress hyperglycemia, which could be explained by the fact that the child was critically ill. However, even in such cases, glucose of more than 300 mg per dl is quite rare. Our second consideration was an insulin deficient state, which would explain the severe hyperglycemia and failure to thrive. But such high levels of triglycerides are quite rare. Third option was CGL, or congenital generalized lipodystrophy, which would explain both the hypertriglyceridemia and hyperglycemia. However, the typical phenotypic features of lack of subcutaneous fat was absent, and presentation in a child this young is quite rare. Our last option was FCS, or familial chylomicronemia syndrome, which would explain the severe hypertriglyceridemia. However, again, such high glucose levels are a rare manifestation of this condition. So at this point, since we did not have one single condition which could explain all of this, we had to focus on sending investigations to rule out every condition. So first, we decided to do a USG whole abdomen to visualize the pancreas and send C-peptide levels. Then to rule out CGL, we had planned on sending leptin levels, but since this test is conducted nationwide only once a month, we had to put this on hold. And we focused on FCS, and we decided to send a lipid profile with lipoprotein electrophoresis. By this point, after 4 days of insulin infusion, the child's triglyceride levels dramatically decreased to 425 mg per dl with a significant decrease in cholesterol as well. This dramatic fall in triglycerides by insulin infusion and a dietary modification alone made our differential of CGL quite unlikely. And at this point, the blood, urine and CSF cultures that were sent all came back negative. So at this point, we made CGL, it was unlikely, and we were left with the other 3 options. At this point, the lipid profile with lipoprotein electrophoresis that we had sent, it revealed an absent chylomicrons, which again ruled out FCS, since FCS is characterized by elevated chylomicrons. And this also revealed that the child had an elevated level of VLDL, which again could be explained by both insulin deficiency as well as insulin resistance. So at this point, we were dealing with either stress hyperglycemia or an insulin deficient state. And at this point, the USG that was done, it revealed a structurally normal pancreas, which ruled out pancreatic agenesis or hypoplasia as a cause of insulin deficiency. And the C-peptide levels at this point, they came out to be lower than the normal range. So this suggested a reduced endogenous insulin secretion. And so all of this together, it indicated diabetes. Reaching this diagnosis was a major milestone for us. However, due to the absence of standardized guidelines and textbooks for the use of subcutaneous insulin in a child this young, we had to rely on expert consensus and published case reports in order to guide the therapy in this child, based on which we started the child on injection glargine and Lispro, and considerable amount of time was given to educate the parents on how to administer insulin at home, monitoring glucose based on the feeds of the child and modifying the dose of insulin accordingly. And after this, the genetic test that was done, it revealed a homozygous GCK mutation, which confirmed a diagnosis of permanent neonatal diabetes mellitus. And at this point, it is interesting to note that this particular mutation is so rare that in 2014, the largest international case series done on this mutation noted around 30 cases worldwide. And so our take-home messages would be that a child with hyperglycemia, especially less than 6 months with persistent hypoglycemia, should not be attributed to stress hyperglycemia alone. And severe triglyceridemia can be a consequence of insulin deficiency and can mimic primary lipid disorders. And failure to thrive and IUGR are important clues to an underlying insulin disorder and should prompt us to evaluate further. Thank you.
So good, that's an interesting case, presented well.
Thank you.
So you did the C-peptide assay.
Yes, sir.
So tell me details of the C-peptide. When did you do? At that point of time, what was the ambient glycemia? Number one. Number two, did you do a random unstimulated C-peptide, or you did some stimulus you know about, at least in adults or older children, some stimulated C-peptide values? And third, what was the glycated hemoglobin? You mentioned something. Did you look at the glycated hemoglobin of that child?
So as in HbA1c?
Yeah.
So in children less than 6 months, we usually do not rely on HbA1c because fetal hemoglobin levels are quite high in that age group. And so HbA levels are lower. So even if it is high, then it supports our diagnosis of diabetes. But even if it is low or normal, it cannot rule it out.
So did you look at it?
No, sir.
Okay. So C-peptide?
So we went for an unstimulated test because the child was so young, we cannot go for any stimulation.
What was the ambient fasting PP on the day you had sent the blood for C-peptide?
So it was around, it was on day 2. At that point, the blood glucose was still, it had not come under complete control. It was still ranging between 500 to 600.
So was that a logical step to do it, or you should have waited for a couple of days or a few days to normalize the glycemia? Because what happens to the C-peptide in the face of acute hyperglycemia? What happens to beta cell function?
So in normal cases, when if a child has hyperglycemia, the beta cells will be functioning even more, so there will be higher insulin levels. So C-peptide would be a bit higher if we had we should have technically waited for a bit more.
How do you just name the drugs to correct hypertriglyceridemia, number one. And number two, any options of oral drugs in your patient? If so, when, what, how?
So firstly, for hypertriglyceridemia in this age group, we have only used one drug, which is fibrates. However, in this child, we did not need to use it. And secondly, sir, as for the oral drugs for hyperglycemia, in some cases of neonatal diabetes with a mutation which affects the potassium channel, sulfonylureas can be used. However, in this child, since this is a GCK mutation which does not have any effect on those channels, no oral hyperglycemic agents will work. The child is insulin dependent for life.
Options other than fibrates and insulin for controlling triglycerides of beyond, you said 4,000.
So in neonates, these are the only two ones we have.
General, suppose a child walks in, familial chylomicronemia.
So I don't know.
could this child have had type 1 diabetes or type 2 diabetes?
Sir, according to the guidelines, if a child presents at less than 6 months with hyperglycemia, it is most likely a monogenic form of diabetes, and genetic testing is the first, the preferred one.
Most likely or 100% likely?
So most likely, not 100%,
Almost
but
100%.
most likely.
Anyway, and about glucokinase?
Is maturity onset diabetes of the young, type 2, MODY 2.
Thank you, all of the presenters. I congratulate all of you for the courage you have shown to stand up in the podium as MD or DNB students of first year and second year in a conference as this. In our time, neither were such opportunities available, nor we could muster the courage to do so. So there were flaws. You faltered on answering many questions, but that is quite natural on the study design or on the basic questions, but it's a learning process, and don't get disheartened. And all of you did exceedingly well. The case that Priya, she presented was a very eye-opener. The case studies were very good. Somebody would come up first and somebody would come up second, but I think the variance between who has come, will come, eventually come first, and who would come last would be only a fraction of 3 or 4 marks. So all of you did exceedingly well, and please keep this habit of presenting in conferences your original research works, not only your thesis works, so that will enrich you academically and enrich the fraternity. So all the best, congratulations, and may I, who would be announcing, either Hari or Tarok will be announcing the results. We have given the marks, so when will you announce, that's up to you. So that's up to the organizers. So as the organizers, when we decide, the results would be in the valedictory session. So you have to stay back up to that. That's the catch here, to let the suspense be there till the valedictory session.
Thank you, sir, for being the suspense builder amongst the students. Now, after an intuitive and candid discussions among the students and the stalwarts of this branch, we will formally start today's session. Our today's session is jam-packed, starting from gastroendo crosstalk. Sorry.
So you should be corrected. You have all the today's session has started, and the most important session of today was the first session, that is research paper presentation.
Thank you so much for correcting me, sir. So we will have the sessions of gastroendo crosstalk to the practical realities of GLP-1 analog, some myth busters, and we will wrap it up the session with the debate in which our brightest endocrinologists will fight with each other to establish their priorities. And at the end of the session, there will be a postgraduate trainee quiz session for which 9 teams have already participated. A general rule, all the WBMC certificates will be distributed after lunch in the registration desk. So without a further delay, I want to announce the first session. And for the first session, I would like to invite Dr. Neha Agarwal, who is a colleague and senior in my hospital. So please, ma'am, over to you.
Good morning, everyone, and welcome back to the third and final day of our BDCON conference. So we'll begin the first session of today with the topic diabetic remission, myth, reality, and clinical practice. For this, I would like to invite our esteemed chairperson, Dr. Rajiv Kumar from DSP Hospital, and our distinguished speaker, Dr. Joyditya Ghosh. Please, sir, come in the dais. Thank you.
Hello. Good morning, everyone. Actually, the important misconception is my sugar is normal, so my diabetes is now cured. So what actually this diabetic remission is? The diabetic remission is defined as HbA1c less than 6.5% for at least 3 months. And the important thing is the person should not be on any glucose lowering medication. And how it can be in a remission phase, the important aspects are we already knowing that there should be the approach of sustained weight loss, then bariatric metabolic surgeries and intensive lifestyle modifications. There are certain groups in which the remission can be possible. Those groups are who are having recent type 2 DM, then they should have at least some preserved beta cell function, and other are those who are having a sustained weight loss. So combining these all effort, the diabetic remission can be achieved. Now, our respected sir, Dr. Joyditya Ghosh from Yasoda Hospital, Hyderabad, will be elaborating so many things regarding this diabetes myth that diabetes can be put in remission or not. So, sir, welcoming you for this session.
Thank you, sir. So at the onset, I would like to thank the organizers for the kind invitation. So today we'll be discussing regarding the diabetes remission, myth, reality in clinical application. So today we'll be covering regarding the definition, what interventions that have been tried, the lifestyle, intensive pharmacotherapy, metabolic surgery, incretin therapy, whether it does lead to remission or not, the durability, which is more important, and whether even a short-term remission can lead to long-term effects, and whether should we try it or not. So as it was stated, the definition is very important. The HbA1c less than 6.5%, where it was measured and it is sustained for a period of 3 months after stopping all the glucose lowering medication. This is very important. On medication, even if the HbA1c is less than 5.7, it does not count as remission. In patients having HbA1c where it is unreliable, like hemoglobinopathies, the FBG less than 126, less than that for 3 months can be counted as having remission as well. So there are certain terms which are used sometimes: cure, reversal, remission of diabetes. Cure overpromises because there is an underlying beta cell defect. Reversal, it's a false impression. It is very catchy term among the patients when we tell that there is diabetes reversal, but it is actually a false impression. And remission is the actual term that is advocated by ADA and ESD 2021. So ADA 2009 split the remission into partial, complete and prolonged, but in 2021 it was characteristically stated as only remission. So why is it so? In cure or eradication, once we eliminate the disease, it's done. Zero ongoing risk. Whereas in remission, for example in diabetes, the underlying risk persists. Genetics, age, beta cell defect. Only doing weight loss and metabolic unloading leads to disease in the latent stage. It does not eradicate the underlying problems that are there. So remission is possible when the unloading disappears. It can again revert back to a state of diabetes. So remission controls the disease expression. There are multiple RCTs, real-world evidences, global and Indian data. Multiple strategies have been used regarding diabetes remission in patients both obese and non-obese. So we'll be discussing regarding that. So what leads to remission? What is the physiology regarding that? So there's a concept of personal fat threshold. As you can see, there's a normal patient and a type 2 diabetes patient, both having almost similar percentage of body fat. But when the threshold is on the higher side, the spillover to the ectopic sites is at a later stage, and therefore the patient may not develop diabetes even having the same percentage as to the next person. Whereas on a person who is having a same amount of percentage of body fat develops diabetes earlier when this threshold of percentage body fat is crossed and spilled over to the ectopic sites, that is the pancreas and the fat, which was stated by Roy Taylor et al. So once this threshold is come down, when the percentage fat is decreased in the body, it leads to a state of remission because of beta cell recovery and also the fat percentage loss. So as you can see here, the threshold is much lower in this person, therefore even having the same percentage of body fat leads to the development of diabetes, whereas the other person is having a normal glucose level. So there is another concept of twin cycle hypothesis where there is chronic calorie exposure, where the liver fat increases, spills off to the pancreatic fat, which leads to beta cell dysfunction. And when we decrease the percentage of fat in the liver and the pancreas, the beta cell improves, insulin sensitivity improves, and thereby the person has a better glucose insulin sensitivity, better glucose profile. So what are the interventions that have been tried? The direct trial, the landmark trial that was done, where intervention of only diet and lifestyle was done. A calorie deficit diet was given of around 800 to 850, and patients were followed up regularly. So in that, in 12 months, the remission percentage was around 46%. At 24 months, it persisted at around 36%. The mean weight loss was around 10%, 10 kgs, and a quarter of them achieved a weight loss of more than 15 kg as well. And we saw that in that trial, more than 15 kg weight loss, in that group, there was around 86% remission rate, which was significantly high, and that stated that maybe the remission was directly proportional to the percentage weight loss. The other trial that was done in Qatar, the Diadem trial, where similarly intensive lifestyle was done, and the remission percentage was a bit higher at 12 months of 61%, where mean weight loss of 12 kgs, which reiterated the fact stated that a Western population data can be extrapolated to the Middle Eastern population as well. This is a very important study, the Retune study that was done. Earlier, all the studies was done in obese patients. Here, the study was done in patients who had a BMI of less than 27, that is normal or near normal weight participants. Again, calorie deficit diet was given, and in that also 70% remission rate was seen with a median weight loss of around 8%. So it stated that even in thin type 2 diabetes, excess ectopic fat was a cause of diabetes development. Reducing that do lead to remission. That is also possible. So we should not exclude normal BMI patients from remission attempt in some scenarios as well. So another study was done, which was the Look Ahead trial, which looked into the caveat of this is that the primary endpoint was to look into the primary CV endpoint, not into the remission percentage with the lifestyle intervention. In that, a subgroup achieved 11.5% remission at 1 year versus 2% in the controls, and a weight loss of around, and the remission persisted around 7% at 4 years. But here, initially, in the Look Ahead original trial, they did not look into the remission percentage as the primary outcome. The primary outcome was CV benefit in the whole cohort, which was negative, therefore it was stopped primarily. So coming to the counterpoint and counterbalance trial. So this is very important. Why? In the counterpoint trial, it showed that benefit starts by day 7. Fasting glucose starts normalizing at day 7 of intervention when started, and it also starts normalization of liver fat to some extent. And the pancreatic fat drops to by around 8 weeks. So even interventions lead to decrease in the percentage body fat and thereby improving the glucose. Whereas in the counterbalance, there were two groups. Both achieved 15 kg weight loss. One achieved remission, other did not achieve remission. So we have two groups of 15 kg weight loss. So why did the other group did not achieve remission? So here came the concept of shorter duration of diabetes and more durable beta cell function was essential for achieving remission. So not all patients who achieve weight loss will have remission at the end point of the intervention. So counterpoint made the proved the twin cycle hypothesis, that is liver fat and ectopic pancreatic fat was reduction was essential. Whereas counterbalance trial stated that not only weight reduction is the primary endpoint, the other parameters also needs to be taken into account when we were deciding who can achieve remission and who could not. So these are the Indian data that we have by Tripathi et al. That study was done here. They looked into certain parameters like age less than 50, HbA1c baseline less than 7%, duration of diabetes less than 6 years, weight loss percentage more than 10%, and a drug naive patient were at more higher they had a higher achievement of remission as compared to their counterparts. This was another trial by Vijay Sarathi et al. From the Indian population, where the young population, young diabetes was looked into regarding the remission percentage. There was significantly higher with 75% and it persisted at 2 years. So these are the trials that have been run in the Western population, Indian population and the Asian population as well, which all reiterated the same fact. Coming to the intensive pharmacotherapy that have been tried. So regarding the intensive pharmacotherapy that have been tried, the initial ones was with insulin. So early intensive insulin was compared with a continuous subcutaneous insulin infusion with a multiple dosing insulin infusion and oral agents, where the continuous subcutaneous insulin infusion led to a better remission, drug-free remission at 1 year of 51%, whereas the oral agents performed a bit less. So the main mechanism here lies that early intensive therapy leads to improvement in glucose level, decreased glucotoxicity, which improves the beta cell function, thereby leading to remission in this group of patients who were already diabetic, started on intensive pharmacotherapy. The other trials that have been done with metformin intensive insulin, the RECITED trial, REMIT pilot trial, where metformin acarbose was used with basal insulin, and REMIT DAPA trial, where glargine, metformin, and dapagliflozin were used, all had a remission around 20 to 40% depending upon the various trials, but the concept remains the same. Early intervention, early pharmacotherapy, aggressive glucose lowering, decreased glucotoxicity led to beta cell recovery and thus diabetes remission. This trial was done in PGI Chandigarh, where there was two groups, the intervention arm and the control arm, where intervention arm included metformin, dapagliflozin, liraglutide, where the control arm showed it was using metformin, vildagliptin, glimepiride. Both groups actually achieved a 31% remission. It states that with whatever therapy we are using, remission can be achieved if it is intensive, if lifestyle intervention was followed strictly in this trial, where lifestyle was also a part of the therapy apart from the medical therapy. So coming to the bariatric surgery, the third thing that have been tried apart from the lifestyle and the intensive pharmacotherapy. So the STAMPEDE trial was the landmark trial regarding that, where gastric bypass, sleeve gastrectomy and other surgeries were compared with the medical therapy. So the percentage of persistence of remission was significantly higher in the surgery group at 5 years. At 5 years after the surgery also, there was around 29% of patients who were having sustained remission as compared to only 5% who were tried with medical management initially. So surgery gave a durable weight loss that is evident, and fewer drugs and better quality of life in that aspect. The other trials were done with the surgical background are Migrone and the Swedish obesity study. Diabetes surgery study was another study which was done. In all these, the percentage remission was significantly higher. If you look into the Swedish obese study, at 15 years, the percentage of remission persisting was 30%. So that is significant. Now coming to the incretin, the blockbuster medication at this present scenario, whether they can induce remission as well. We all know the semaglutide and tirzepatide have significant potential of weight reduction and it has a significant chunk of population achieving a HbA1c of less than 6.5, even less than 5.7. Whereas only a handful studies, one study only, glimpse study, where only 5% of the patient had remission irrespective of the medication used, whether it is dulaglutide, liraglutide or semaglutide. The other trials, we don't have data regarding after stopping of the medication, because we all know that stopping of the medication is very important in order to stamp the patient whether the patient is having remission or not. So if we look into the landmark trials, the first three, the upper three are the trials which was done with lifestyle modification, where the percentage varies around 40 to 60. In the medical therapy, it varies from 20 to 30, whereas after surgery, even at 5 years, it persists to around 30%. That is significantly there. So if we compare the four modalities that have been tried in this literature, the lifestyle, which was ranging from 30 to 70, pharmacotherapy, metabolic surgery, and incretin therapy, where we cannot say remission as a whole, we have to look into the other details that are coming up in the literature. So how long does it last? This is very important to think. In the direct trial, over a period of time, at 5 years after the remission was achieved initially, only 13% could maintain the remission, and other patients had development of diabetes again. Surgical group, the Swedish obesity, at 15 years, it was around 30%. So weight regain is the main driver for relapse. Again, reiterating the fact that again fat deposition leads to development of diabetes, whereas surgery, it is having a sustained weight loss that is actually protecting the patient from developing diabetes on the longer run. So some predictors are there which can predict who we can select patients when trying for remission. Younger age less than 50 years, shorter duration of diabetes less than 6 years, drug naive patient, higher weight because the chances of weight loss are more in those. Around 10 to 15% of weight loss leads to around remission, and higher C-peptide. So what is the cutoff is actually debatable. Some studies have given a cutoff of 1.1 nanogram per ml, whereas stimulated value of more than 2.7, but it is not universally accepted. So does even short remission count? Does it help? Yes, there were studies where in Japan, those patients who had at least once remission in their lifetime had a lower CAD and stroke potential as compared to those who did not achieve remission any time in their lifetime. So this was an Indian study that was done in South India, where you can see there are three. So if you can see, there are the gray indicates those patients who did not achieve remission any time in their lifetime. The orange indicated those patients who achieved remission at least once, they have relapsed, and the other, they did not achieve, they are in sustained remission. So if we look into the complications, the patient who achieved remission at least once had significantly lower complications in all four parameters of retinopathy, nephropathy, neuropathy, as well as PVD. So that is very important. So this was a post hoc analysis of look-ahead trial. I had already stated that it did not attain the primary outcome, but when a sub-hoc post hoc analysis was done regarding the patients who achieved remission, in that there was CKD and CVD benefit in the long run when it was followed up over a period of 12 years. So that is also important. So the benefits of remission, we all know: lower HbA1c, better beta cell function, better insulin sensitivity. The most important thing is that even if you achieve remission at least once, there are fewer chances of micro and macrovascular because legacy effect continues, and the patient has a better quality of life as well. So when a practical pathway is identifying a patient who fits into the criteria we can try for achieving remission, we should achieve a strategy after discussion with the patient, because it is up till the patient to decide what he or she wants, and accordingly we can go forward with the strategy. Percentage weight loss of around 10 to 15% actually helps in attaining remission. Tapering down medications and confirming remission. After that, monitoring is also important, because chances of relapse after remission is also significantly there. So we should be monitoring the HbA1c and the other parameters in all these patients who achieve remission as well. Certain myths: only bariatric surgery can reverse diabetes. No, we all have seen diet and lifestyle even can lead to remission. Remission means diabetes is cured. Again, no, we all know that beta cell dysfunction is already there, so it cannot be told as cured. The other thing is that only obese can achieve remission. No, even lean diabetes have an increased percentage fat above the percentage threshold. So in retune study, it showed that. Good control on GLP equals remission. No, even if HbA1c less than 5.7 on medication cannot be termed as remission, because we have to stop the medication and look into it. Short-lived remission is pointless, not to try it. No, again, no, because the long-term legacy effect continues. Lower complication rate is another thing which is there if a patient achieves at least once of remission in the lifetime. So I would end by saying that younger population, motivated population, better beta cell function, structured therapy or lifestyle followed by monitoring is important. Remission is real, can be achieved. Even it can relapse back, but it is worth going forward with it because the complication risk on the longer term is benefits is also there. So thank you. I would end with this.
Thank you so much, sir. Your information was exceptional and you have elaborated each and everything. So the fact of myth and reality regarding diabetic remission is open for discussion, and I will be pleased if there is one or two questions.
Thank you, sir. Thank you, sir.
Define diabetes remission.
Sir, I could not hear you.
Definition of diabetes remission.
Sir, diabetes remission is HbA1c less than 6.5%, 3 months off medication, then only we can tell the patient that patient is having remission.
Right. So, isn't this a political gimmickry? Because I think we should if at all we have to tell about remission, we have to tell whether it is a disease-free remission or a drug-free remission. At best, it is a drug-free remission. And we know that therapeutic lifestyle change is also an intervention for diabetes management. So it is not a treatment-free remission, it may be drug-free remission. Second, if it is after a bariatric procedure, we are doing a major procedure to achieve remission. Because the moment you tell the patient that you are in remission, the therapeutic lifestyle change will go for a toss. So I face this question from my patients. I say remission occurs in literature and social media. I do not believe that diabetes remits. Once a diabetic, always a diabetic. However politically incorrect the statement may be, is the old adage that stands to my experience and understanding. So, but then since the literature is there with remission, we have to accept it, and 3 months is too short a time. If you make it 5 years, I do understand, okay, for 5 years. So 3 months is too short a time, and I think this is nothing but of political gimmickry in literature. Thank you.
Thank you, sir. Well accepted point, sir. But we have to accept whatever there is in literature. And as there is some benefit in terms of long term, so we can motivate the patients with something or the other that way. Thank you, sir.
Yeah, Jayaditya, it was a good presentation.
Thank you, sir.
Professor Jayan Panda from Cuttack. What we see, the remission is mostly lifestyle modification, weight reduction and the right diet. And once that is gone, as per the natural history, again it gets relapsed.
Yes, sir.
Suppose somebody is on treatment for obesity. You know, the GLP-1 era is going on. Somebody is on GLP-1, which works also for obesity as well as diabetes. But primarily the GLP-1 is given for obesity, either dual agonist or semaglutide given for obesity, but the patient remains normoglycemic for 3 months. Can you designate it remission?
So the first thing is that if the patient is given for obesity, patient having diabetes, if the patient is having normoglycemia off medication for 3 months, if the patient was initially diabetic, we can say the patient is having remission if the patient is off all medication. But if the patient is on medication like GLP-1 analog, even the HbA1c less than 5.7 does not label as remission. So it should be off all diabetic medication. Even GLP-1 given for obesity or diabetes does not count because the mechanism stands firm in that.
Yeah, because you know the obesity management, GLP-1 has to be continued.
Yes, sir.
And that works also for diabetes.
Exactly, sir. So that's why we don't have much data regarding remission with GLP-1 because there is no data after stopping of only a single retrospective data that is there which states that only 5% persist after stopping that. So regarding management of obesity using GLP-1, we don't have data regarding after stopping the medication.
Thank you.
Thank you, sir.
Sir, from my side,
yes, sir.
On one of the BDCON conference, some of the renowned physician has told that if I can take 3 glasses of soup per day, so it is a possibility that my diabetes can be put in remission. That was a medical humor, sir. But what is your strong belief regarding these two? It is a myth or the reality as per your personal experience regarding your patient and number of or percentage of patient was put diabetes on remission?
So, sir, as you said, it depends upon the patient motivation as well. So dietary intervention can lead to diabetes remission, but it is tough in patients who are having high HbA1c and all those things. BMI is on the higher side and motivation is not there. So it can happen in 20 to 30% of the patient, but the relapse rate is very high with dietary modification as well as with medication, because on stopping that, the patients, as Nilanjan sir had rightly said, once we label the patient as remission, the patient's lifestyle goes for a toss and the patient gains weight, and again, as I had said, the percentage body fat increases, the mechanism which is leading to remission is actually lost. So again the patient lapse. So it is possible, but the motivation is very important, and the patient's weight loss, that is, and in suitable patient, that is the duration of diabetes, beta cell function also needs to be. Earlier, in new onset diabetes, we can go for aggressive therapy and try remission because the long-term benefits are also there because of legacy effect.
And sir, what is your strong belief that it is a myth or the reality?
It is reality in a sense because remission is possible. That is what we are telling, not reversal. Remission means it can again come back once the lifestyle is lost. So remission is possible, yes. Reversal is not. Reversal is not there. That is the point to be taken, because in the social media everyone is proposing the term reversal, diabetes reversal. That does not have any medical background. Only remission, yes, it is possible, it is a reality, but it depends upon the patient's motivation. Therefore, we say that.
Thank you. Thank you so much, sir.
Thank you.
Thank you, Dr. Ghosh and Dr. Kumar, for the excellent discussion on diabetes remission and busting the myths related to it. I would request both of you, sir, to please wait for the group photograph. And moving on to the next session, that is on complication of diabetes and the role of AI in detecting it. For this, I would like to invite our respected chairperson, Dr. Rajan Palui, and for this, our speaker for the day is Dr. Riddhi Das Gupta. Please, sir, come on the dais. Thank you.
It is always a privilege to learn from avid researcher like Riddhida. Over to you, Riddhida.
Very good morning to all of you. First of all, thank you to the organizers of BDCON, especially Nilanjan sir and my colleagues, juniors. Rajan is here, Sunetra, Shomikda. So all of them for inviting me. And this is a topic which I think AI is something like everyone likes to use it, but no one kind of wants to admit it. So these are my disclaimers. At the onset, I would like to say that I remain a clinician and I'm more of an accidental AI enthusiast. So I don't know coding. I don't know much about the computer jargon, so please don't ask me about that. So today I'll be covering a bit about the various aspects of artificial intelligence and how we can use them to screen for diabetes and its various complications, and also look at a bit of the work which is being done in India, and I've been fortunate to be associated with some of these. So this, of course, Yeah, the audience here I don't think needs any introduction to these kind of figures. These are the scale of problem that we are dealing with, both globally as in India. The question is why AI in diabetes care? Why now this lot of noise about AI is coming in? The main reason is we have a lot of data which is being generated from CGMs, computing devices, and of course the algorithms to translate this data into clinically meaningful action has undergone a paradigm shift. So that is why AI has become important in diabetes care. So we'll briefly look at the various AI modalities that can be used in diabetes research. I think all of you are aware that under the broad umbrella term of artificial intelligence, we have broadly the machine learning, and then we have the next layer of deep learning and neural networks, and of course the LLMs, which all of us are using in our daily life. So broadly, these can be classified into supervised, unsupervised, and reinforcement learning, with various techniques under each of them. I will show some of the studies that we have done utilizing these various aspects of AI in diabetes care. So this is what a machine learning looks like. So to put it very simply, it's someone, say, preparing for an exam or a NEET, and you keep on doing mock papers. We used to do a lot of these old papers. So the machine also does that. You keep on feeding data to it, it learns from those data, and finally the aim is to expose it to a new question paper, something which it has not seen, and then we try to assess whether the machine is able to use the knowledge learned to solve these kind of problems. So that's kind of the very basic of machine learning. A step further is the deep learning or a convolutional neural network. So this is mainly an image-based AI tool, which again, you feed various aspects of the image. You break it down into pixels, and they convert it into mathematical formulas, and finally they will be able to identify whether the image is what you want to see. So it's more of an yes and no type of answer. And then, of course, the large language models, which we are all using on a day-to-day basis, and this is how it works. So how do we apply these AI tools in practice? So these are some of the evolution of AI in diabetes care as also in other disciplines, things some of which are established in practice and some of which are still emerging and is the future, things like outcome prediction, adherence, and of course drug delivery through AI. So coming to large language models, as we all know, the major impact has been in literature synthesis, documentation, and patient education. This has been taken one step forward, where we have developed bots that can help in mobile services and decision support. These are two publications that have been done, one in gestational diabetes and the other in dealing with complex type 2 diabetes, where they have looked at these large language models. At our center, we are now working with IBM to develop an LLM-powered chatbot. This would be for diabetes self-management in school-going children for type 1. So this is an ongoing trial that we are part of. Next, we come to deep learning and medical imaging. As I said, this has a huge role in the case of diabetes in terms of screening for retinopathy, neuropathy, foot ulcers, and risk prediction, because all of these are image dependent. And if we can train the AI model in these images, then sometimes the prediction can be even better than the clinical prediction. So this is published recently in Nature Medicine, where they used a deep learning system. They took images from the fundus photography as well as images from the OCT to train the model, and they developed time to progression of diabetic retinopathy. So something like this can be very useful when a patient comes to you for the first time, and you can actually predict the time and the duration to retinopathy that can happen. This is another one which has looked at utilizing confocal microscopy images in diagnosis of peripheral neuropathy, and also a deep learning technique for diabetic foot ulcer identification. At our center, we are working a lot at the interface of diabetes and bone. So this is one of the models that we have developed which can predict osteoporosis at the lumbar spine, as well as the hip using chest x-rays. So we looked at around 700 or so people who had had routine chest x-rays for some reason or other, and then we trained this model on predicting osteoporosis. So this can be a very cheap, easy to use tool because availability of DEXA still remains a concern in many places in the country. This again is another study done in collaboration with Dr. Lakshmi and Dr. Sunetra from NRS. And here we tried to look at developing a fracture risk score which would be independent of DEXA and TBS in patients with type 2 diabetes. And as you can see, even without the incorporation of DEXA or TBS, we ran the model with and without these features, and we found good fracture predictions, and the important parameters that can be included are all available in a routine OPD. So something like this could very well be the answer to predicting fractures in patients with diabetes. The other area which can be very useful is osteomyelitis. Often when we look at an X-ray or when we get a clinical picture, it's not very easy to pick up the osteomyelitic diabetic foot. Low sensitivity, poor specificity, and subjective interpretation are some of the things which preclude. Obviously, MRI is not available in a lot of places. And osteomyelitis risk is a dynamic phenomenon. It keeps changing with the clinical features, with the blood parameters of the patient. So a static tool like an ESR, a CRP, or an X-ray may not be the answer, and you may need to have a multimodal interpretation of the same. So this is work done entirely in Durgapur. Dr. Sunetra again very meticulously collected patients who were working in the factories here, and they were using a kind of boot which actually was contributing to their diabetic foot ulcers. We have published this, and you could see a very staggering 80% of the population had forefoot ulcers and around 30% polymicrobial infection. This was a clinical study, and then we thought of utilizing machine learning to see whether we can predict osteomyelitis in this group. These are some of the very easily available data that was fed into the model, including demographic data, footwear details, lab parameters. Intentionally, we did not use MRI, we have used X-ray so that this becomes available across the country. And as you can see, the XGBoost model, which was used for this AI tool, has a very good accuracy and precision in predicting osteomyelitis. Obviously, this is in a group of factory workers with a higher risk, and we need to validate it in the general population to make this available. These are some of the important factors that contributed to osteomyelitis in the same population: frequency of footwear change, age, CRP, and the Sinbad scores. The next area where AI can be useful, given the number of CGMs and the wearables that have come in, we now have a huge load of data that is being generated. However, a lot of times we are not sure how to convert this data into clinical actionable endpoints. So that is where again an AI tool, a neural network, can be useful. This is a study published in the Journal of Diabetes Science and Technology. They have used explainable machine learning to predict weekly changes in glucose levels based on CGM data in type 1 diabetes. So this is very interesting. We tried something similar at our center. We have a specialized pancreatic diabetes clinic. So in FCPD patients, we developed this app known as the Nidra Hypo. This app, the specialty was that it could predict the occurrence of a nocturnal hypoglycemia at least 6 to 7 hours before. So around, say, in the afternoon or the evening, based on the person's CGM, diet and exercise pattern, it could predict whether that fellow is going to have a nocturnal hypoglycemia. And not only that, it could also suggest an intelligent snack that a person has to take. So we did a randomized trial, and this is currently in the stage of review for publication. We now move on to the sphere of cluster analysis. Many of you would be aware of Leaf Group's publication on the novel clusters of type 2 diabetes, which was largely based on the unsupervised machine learning cluster analysis. This is something very interesting, again, based on our work in the bone and diabetes cohort. we looked at patients who had data of diabetes, had data of DEXA, and had data of TBS. And we did a K2 clustering in these patients. Very interestingly, you can see that the third phenotype, which is adiposity dominant but low muscle, had the least TBS. So this goes against the standard thinking that obesity protects against osteoporosis. We usually go by BMD alone. But when we included the muscle and when we included these into the AI tool, we found there are three very distinct phenotypes that come across, and there is a progressive worsening of the bone microarchitecture in patients with diabetes, suggesting that going by BMI alone may not be the ideal way to look at these patients. We are also working on clustering early diabetic retinopathy at our center. We have used two novel indices, the microaneurysm formation rate and the microaneurysm disappearance rate. And based on this, we were able to pick up some very interesting early phenotypes of diabetic retinopathy, and we are now following them up to see how many of them turn into severe retinopathy and CSMEs. This is another ongoing study based on foot thermograms. And based on the temperatures and the thermal analysis of the foot, we have divided it into mild, moderate, and severe classifications. Again, these are based on AI, and this can very well be used in a general OPD setting if you have the access to temperature monitoring in these patients. Coming to a bit more futuristic AI and its role on metabolic health, digital twin. I think most of you would be aware of this. This is one of the upcoming techniques where an AI-generated twin of the person is created, which kind of simulates your daily metabolism. And then in that twin model, you can introduce various interventions and see which one would be ideal. This moves away from the classical teaching of one size fits all and focuses more on precision medicine, where we are particularly finding out an individual's metabolism, and then we are trying to figure out which treatment will work best. These are two studies, one by Shashank Joshi's group on a retrospective real-world data, where they have used the outcomes of a twin intervention in type 2 diabetes. The other is again another series on complex type 2, where digital twins have been created to simulate the physiology. This is ongoing work. Again, it's a multi-center trial involving our center as well as those at NRS, Guwahati, AIMS, Kalyani, and BHU. And our idea is to develop India's first twin-guided precision framework for pancreatic diabetes. Obviously, this is under review for grants and subject to that, but as of now, we are hopeful of carrying this work further. The other area, futuristic area where AI can be useful is in the stage of drug development. So there are a lot of work going on in the basic science field about target identification, repurposing the drug, and also toxicity prediction. So these are novel areas where we may be able to reduce the side effects of the drugs and make it more patient-friendly. As we know, AI has had its fair share of negative interpretations and its blind spots, and there still remains a gap between what is being promised and what is delivered. Largely depends on the bias in selecting the particular AI model. The data always should be very clear and heterogeneity should be less. And of course, large-scale validation of these tools are still something which is lacking. The GIGO phenomena, which is the kind of base of how good your AI model is, again, it is totally based on the data which goes in. Whatever you put into the model will learn from that and give you an output. So accurate labeling, good data quality, and completeness of data remain the foundational framework for a good AI model to be developed. These are the different types of AI errors and bias. A lot of you would have heard terms like hallucinations and data bias, and these are increasing use of AI. We see these getting more and more common. How to deal with this is to develop what we call an explainable AI. So explainable AI is a concept where the physician or the person using it is actually having a peek into the various stages of how the model is working, and that makes it more transparent. So we are now working on an RSSDI grant where we are developing this smartphone-based AI app, and this is supposed to pick a picture of the diabetic foot ulcer, and from that picture it can predict whether it's an infection or an ischemia. We have used explainable AI for that. This is an ongoing one-year work, again in collaboration with Dr. Sunetra at NRS. And we also plan to have two interfaces for this app. One is a patient interface, so the patient can upload the picture of the foot and send it to the doctor. At the clinician level, you can use the AI tool to gauge the risk of infection or ischemia, and based on that, you can triage your patients whether it needs an urgent hospital referral or it can be treated at home. So in a peripheral center, where all the resources for diabetic foot care or osteomyelitis detection is not available, a smartphone available tool like this can be game-changing. Again, there are concerns about the applicability of AI models across various ethnicities. We know that the diabetes and its complications behave very differently in an Indian population compared to the Western. Unfortunately, the AI data that we have as of now is largely based on Caucasian population. So there is a need for more studies based on Indian phenotypes and building a database of Indian patients that would aid us in developing these models. And finally, ethics and privacy. Who owns the data? What happens if the AI model goes wrong? Whose responsibility is it? There are frameworks in place for preventing data leakage, ensuring confidentiality. India now has brought out its own guidelines on this, so if you are developing a model, you need to be aware of these guidelines and stick to that. So I would end my talk with these key messages. I think there is a larger debate about whether AI will replace clinicians. Probably not. I don't think clinical acumen can be mirrored by an algorithm, but clearly physicians or clinicians knowing AI may be the ones who will do well. So knowing AI or using AI should be actively pursued. It should be a part of your daily care, but we should use it responsibly. We should know the guidelines around it. And also the AI tools which we are developing, it needs to be validated in Indian settings to make it clear that these are useful for our patients. So these are our references. Thank you again for your patient hearing.
Excellent talk, Ridhita. The house is now open for questions.
Thank you, sir, for this nice presentation. Sir, I just wanted to know how much useful are these apps? Are you using in your clinical practice this app? How much it is accurate actually?
Yes, so depends on which app you are using. Broadly, there are 2 or 3 kinds of apps that you can use. Some are based on these LLM models, which are mainly designed to reduce your workload in the clinics, OPD settings. So quite a few of them are commercially available and they are doing good. As far as risk prediction or disease prediction is concerned, we have to be careful about the app is not the issue, the AI algorithm which drives the app is the issue. And you need to look whether that has been based on Western or Indian cohorts, and if on Indian cohorts, whether that has been externally validated or not. Like the one I showed for predicting chest X-ray, osteoporosis from chest X-ray, already there is a commercially available app, I think from China, which is doing quite well. So it's not that all of these are insensitive, but we need to have a working idea of the algorithm that drives it and look at the literature on how robust is the validation used.
Any app will you suggest we can use in our day-to-day practices?
There's no one app like that. It again depends on what purpose you are using it for, right? So there are apps now which can trace the CGM data and convert it into clinical actionable models. which can send alerts. I think a lot of these smartwatches have inbuilt AI algorithms. In cardiovascular diseases, that has made a huge leap in terms of predicting myocardial infarction and things like that. In endocrine, I think we are still lagging a bit behind in bringing these to the forefront. So we need, I think, more multi-center data to actually bring them into clinical practice.
Thank you, sir.
Great presentation, Dr. Riddhi. Dr. Panda here. Actually, very well shared that AI is the future of medical practice, may it be any specialty, and it will assist us rather than challenging us. Just one thing briefly I'd like to know from you regarding ethics, data privacy, and legal tangles. You know, it's an age-old science and we have certain things in place. And here, if we go digital, go AI, so is there a risk to the medical professionals from this angle?
Yes, that's a very valid ground, and that's probably one of the reasons why there is still a lot of hesitation in bringing this. I think now we have the DPDP guidelines and also the Indian guidelines. So whenever you are developing a model, we should be very clear that on paper we have evidence in consultation with the AI team and the legal team that you are following that. It is mandatory for all data to be anonymized, and there should be double encryption on that, and you should use a portal, so they should not be available to anyone. There should be a dedicated portal in your hospital where only the people concerned with the study are able to use it, preferably with a 2-factor or a 3-factor authentication. So some of these steps can ensure that we minimize the data leakage. Again, as the study builds up or as you go into more multi-center studies, there is a risk of data leakage and patient privacy being hampered. So I think that part has to be very stringently taken care of. There are enough guidelines on that, but it's essential that you are aware of it and you stick to it when you build the model.
Thank you, sir.
Thank you. Vidita, just one last question. Like, you are working now in multiple models, like in osteoporosis from chest X-ray and foot related. So what is your now in your model, like you are in which stage now? This is in the validation stage or development stage, and who are the, like the problem statement, everything is in your mind, like who are the technical person who are doing just for it? Right.
Yes. So as I said at the outset, I don't have the knowledge, neither the inclination to learn mathematics or coding at this age. It's a decision I took when I appeared for joint entrance, and so I don't plan to change that. We are fortunate because our institute, it's an university which has an engineering college with it. So we liaise with the IT and the AI people from there. We have also collaborated with IBM India, which is quite keen on medical research. And there's a group from IIT Indore, which has now developed a digital twin hub. So it is government sponsored. India's first digital twin hub has been developed, and they are actively looking out for medical researchers. So I have tried to reach out to them personally through contacts and get them on board. So the technical part is taken care of by them. As far as readiness of these models are concerned, as I showed, like the chest X-ray one and the diabetic foot osteomyelitis have been internally validated. So we are now moving into the stage of prospective validation in an in-hospital setting. Some of the others, like digital twins and all, are both labor and cost intensive. So we have applied for grants for that. Hopefully if we get something, might get moving on that. So those are the stages at which they are.
Thank you and congratulations.
Thank you.
Thank you, Riddhi sir, for the insightful and interesting discussion on role of AI models. So let's move on to the third session of the day, which is titled as the rise of Met-ALD. And for this, I would like to invite Dr. Dipen Rai to kindly chair this session, and Dr. Anand Sharma sir to deliver the talk. Thank you, sir. We welcome both of you on the dais. Thank you, sir. And I would request Dr. Riddhi Dr. Rajan to have a group photo and
Good morning to everybody. As we are running late, so without wasting much time, I will ask the speaker to start his lecture.
Good morning, everyone. I'm Dr. Anand Sharma. I'm the Associate Professor in Gastroenterology from AIIMS Rishikesh. At the outset, I would like to thank the organizers for giving me this opportunity to talk about this topic in front of such an august audience. So, I'm a hepatologist by education and profession. And the topic given to me is a very creative one: sugars, spirits, and steatosis, rise of MET-ALD. So let me start by answering one question which is probably there in most of your minds. So this is an august gathering of endocrinologists and diabetologists. So you must be thinking, what is a hepatologist doing amidst you? Okay, so firstly, I think it's now more and more recognized that liver has been a kind of a neglected component of metabolic syndrome, and now it's more and more apparent or more and more recognized that liver also bears the brunt of the disease, like the heart and other organs. So, and there are certain socio-demographic changes among the patient population we cater to. Okay, so this patient on the screen, a middle-aged, affluent man, obese, diabetic, and who does not drink to the extent of causing cirrhosis. Conventionally, 60 to 80 grams of alcohol per day are thought to cause cirrhosis. This patient consumes something like 2 or 3 drinks, so he's a social drinker, and he goes for a routine annual checkup, and he finds grade 2 fatty liver. So this patient is becoming more and more common in our clinics. So this guy can come to any of our clinic, and he'll come to you because you are his care provider, because he was a diabetic, and he will ask you what to do for this fatty liver. So I hope by the end of this session, I will help you answer that question. Okay. So let's answer the first question. What is the cause of fatty liver in this patient? So previously there was this terminology called non-alcoholic fatty liver disease. So there were people who used to consume a lot of alcohol. They were called alcohol liver disease. There were people who did not consume alcohol at all and had fatty liver. They were called NAFLD, or non-alcoholic fatty liver disease. The problem with this definition was that it was exclusionary. The patient has to not consume alcohol at all to fit in that definition. So this gentleman we just spoke about doesn't fit into either. So the term was then modified to metabolic associated fatty liver disease, which said that if the person has a metabolic liver disease, even if he consumes alcohol, he will be under this MAFLD definition. The problem is the quantification of alcohol is not considered is not factored in the definition. Patient can have social drinking, can have harmful drinking, can have risk drinking. He'll still be called MAFLD. So it was still inadequate. And the term fatty was somehow thought to be stigmatizing. So then they came across the definition that is currently accepted, called steatotic liver disease. So it's an umbrella term, and in that it's a spectrum from the purely metabolic to the alcoholic liver disease, who also has metabolic risk factors. And in this, a new subclass was termed, that is called the metabolic dysfunction and alcohol-related steatotic liver disease, otherwise known as MET-ALD. So it's the new kid on the block, and it is defined as a fatty liver that is caused due to a metabolic risk factor, that is as defined as presence of at least one cardiometabolic risk factor, and also has moderate alcohol intake. By moderate alcohol intake, we mean alcohol intake that is not in the range of that which can cause cirrhosis. I'll come to the quantification later. Okay, so this is the classification we're talking about. It was defined in 2023. So overarching term called steatotic liver disease. On one end, we have the metabolic associated steatotic liver disease, which is purely metabolic. The other end, we have alcohol-related liver disease. So once the person consumes alcohol in excess of 50 to 60 grams per day, it becomes alcohol-associated liver disease with metabolic factors. In between, we have something called MET-ALD. So the person has at least one cardiometabolic risk factor and he consumes some alcohol. Now, what is some alcohol? In females, it is defined as 20 to 50 grams per day. In males, it's defined as 30 to 60 grams per day. Okay? So if the person is having alcohol to the tune of 30 grams, the disease is more dominated by the metabolic factor. If the person is having alcohol near the 50 or 60 gram limit, the disease is more affected by the alcohol factor. But then both are supposed to play a role. So this is MET-ALD. Again, one cardiometabolic risk factor and moderate alcohol intake. So this is the diagnostic criteria. I think I already spoke about this. If the person is having fatty liver and at least one cardiometabolic factor, you need to ask the fact, does the patient have alcohol consumption or not? If no alcohol consumption at all, then it is MASLD or metabolic. If there is alcohol consumption, if it is the serogenic dose of 50 to 60 grams per day or more, it is called alcohol liver disease. If the alcohol consumption is between 20 to 50 grams in females and 30 to 60 grams in males, then it is called MET-ALD. Okay, so our person probably has MET-ALD because he was obese, he was diabetic, and he was having alcohol to the tune of 30 to 40 grams per day. MET-ALD, so what? So we tell him he's MET-ALD. The next question he will ask you is, should I worry about it? Is it anything more than just the fatty liver because of diabetes or obesity? So does the ALD part add on to the MET part? That's the question. So how common is MET-ALD? It is relatively new definition, so the data is limited. In general population, it is thought to be present around 1.7 to 4.5%, and in primary care setting, around 5.6%. The problem with the data that's currently available is that it is very heterogeneous regarding the modality that's used to diagnose steatosis. It can be ultrasound, it's been fibroscan in some of the studies, and in other studies, it's MRI. So there is no uniform tool used, and hence the data as of now is limited. Next question, how relevant is it? Okay, so I'll first talk about its relevance with respect to the progression of liver disease, then I'll talk about the cardiometabolic part. So with respect to the progression of liver disease, whatever data is available suggests that MET-ALD comes somewhere in between MASLD and alcoholic liver disease. So it is a little less benign than metabolic, but a little more benign than alcohol liver disease. There's a risk of liver fibrosis. With regards to liver-related events and prognosis, it is similar to what I just said. This large Japanese study, which is a follow-up of 4 odd years, showed that MET-ALD sits in somewhere in between alcohol liver disease and metabolic liver disease with regards to liver-related events and prognosis of liver disease. What about the cardiovascular events in MET-ALD? So this again mirrors the liver-related events. That is, regarding cardiovascular events, MET-ALD again sits in between MASLD and alcohol liver disease, although the studies that are available differ regarding which is the most harmful of all. Some studies say alcohol liver disease is the most riskiest. The other study says that metabolic has a higher risk of cardiometabolic events, cardiovascular events. But both the studies agree on the fact that the MET-ALD sits in between the alcohol and the metabolic liver disease. What about the all-cause mortality? So it's a large study of 10,700 patients with 26.7-year follow-up, and it showed that surprisingly, although MET-ALD did increase risk of all-cause mortality, MASLD did not, but that requires further prospective data. So we know that person has probably got MET-ALD. Regarding prognosis, it is a little more serious than just purely metabolic liver disease, but which is the one which is causing the problem? Is the metabolic part or the alcohol? What is harming him more? So what is the impact of alcohol on the metabolic liver disease? There's a large study of 38,000 odd patients, and it showed that the green and the blue quadrants, right? These are people who are having alcohol but having moderate amount of alcohol. So it was shown that these patients have at least most of the patients, almost 40 to 50% patients, at least had 3 cardiometabolic risk factors. When they saw the risk of incident liver disease in these patients, they saw that the people with metabolic syndrome, among the people who were having moderate alcohol intake, had a higher risk of developing incident liver disease. This is another study in which 1,760 patients were there who were consuming moderate or heavy alcohol. 275 of them were heavy alcohol, and they saw that there was association that those people who had metabolic syndrome among these had a higher odds of developing significant as well as advanced liver fibrosis as assessed by FibroScan. So should we investigate further? How should we investigate? So it's a multi-pronged approach. The first thing that we need to evaluate is the assessment of the metabolic status, including diabetes, obesity, and dyslipidemia. I don't need to talk about this in front of this audience. So I'll move on to the other part, which is the assessment of alcohol intake. So whether we are calling it MET-ALD or we are calling it alcohol liver disease, depends on the quantification of alcohol intake per day or per week. So the problem with alcohol is that it suffers from underreporting. So there are questionnaires available to assess this. There are blood markers like gamma glutamyl transpeptidase, AST or MCV, which have been there for a pretty long time but have their own inaccuracies. Or there are newer tests like PETH, which are measured in hair or other parts, other body tissues, and they tell you alcohol intake over the past few weeks. Then comes to assessment of liver. Okay, so now liver biopsies are not preferred in such situations. It's more preferable to do a non-invasive assessment. So fibrosis assessment can be done in the clinic using simple tools like APRI or FIB4, which uses usual blood parameters like AST, ALT, AH, platelets, as well as FibroScan, which is a relatively expensive and not always available tool. Okay, this can quantify fibrosis. For the quantification of steatosis, ultrasound, and with the FibroScan we get a parameter called a control attenuation parameter, which can be used to quantify the amount of steatosis in the liver. How to treat these patients? So it basically depends upon which is the predominant factor in the person. So if it is towards the metabolic side, he will do well with treatment with the metabolic status, better glycemic control, treatment of obesity. And if it is more on the alcohol side, then typical medications and psychosocial intervention to limit alcohol intake will be helpful. A lot of drugs that are there in the pipeline are being studied now. I'll just mention 2 of them because these have got a little more evidence. So one is semaglutide. Okay, this is like, it's the latest superstar. It acts on practically everything. So along with the obesity and diabetes, it's also known to act on the liver and cause improved steatohepatitis, as well as it is considered to have some central mechanism of action to reduce alcohol consumption. So this drug is being further studied in this patient population. Other one is FGF21, especially a drug called pegozafermin, which improves the insulin sensitivity and improves steatosis and steatohepatitis and causes resolution of steatohepatitis and fibrosis regression. This also has seen to be having effect on reducing alcohol consumption. So the take-home points will be MET-ALD is a newly recognized entity. It combines features of metabolic dysfunction and moderate to high alcohol intake. It fits somewhere in between mast cell, which is a purely metabolic, and alcohol, which is a purely alcoholic in terms of the risk of liver fibrosis and overall prognosis. The diagnosis involves assessment of both metabolic status and alcohol intake, and the management focuses on lifestyle changes, alcohol reduction, and emerging therapies such as semaglutide and pegozafermin. Thank you.
I will ask the audience to ask one or two questions to the speaker.
So one question, that is, what's the role of alcohol dehydrogenase in the alcohol dehydrogenase enzyme in these cases? Secondly, has it been compared with the age and sex match population regarding morbidity and mortality?
I am not sure I follow the question. So alcohol dehydrogenase enzyme in what, sir?
Yeah. What's the role of alcohol dehydrogenase in individual cases? Because if it is increased, we know the alcohol effect will be less.
Yes. So
it has been done, and age and sex match population, in number of patients of 60 to 70 years of age, Y number of males, and it's then other diseases without steatosis and those with normal population. Have you compared mortality and morbidity?
Thanks for the question. So the polymorphism of the ALDH enzyme that affects the predisposition of a person to develop alcohol liver disease is being studied. I don't think there is any data regarding the same specifically in this subgroup. It's a newer definition, so I don't think maybe the study is upcoming. And with regards to age, yes, I mean there is data to say that age is also a risk factor in developing fibrosis. I mean these patients for developing liver disease as well as liver-related events.
Dr. Panda here. Nice presentation, Dr. Anand. Recent concept that even little amount of alcohol is dangerous for the fibrosis and the metabolic backup. So previously there was a concept that the social drinkers or the severe, moderate or the mild intake have different grades of metabolic challenge and the alcoholic liver disease. So what's your opinion regarding, because you have shown the grade of alcohol intake and the assault deteriorates with the amount of alcohol. So even a small amount of alcohol like social drinkers or the occasional drinkers, they can also have a severe problem. What is the latest opinion?
So previously there was this, as you rightly said, previously there was this opinion that moderate or little amount of alcohol was actually protective. So that thing is gone now. There is emerging data to suggest that no amount of alcohol is safe. So any alcohol is unsafe, it leads to adverse outcomes. But if you're asking me, have we compared the MET ALD to, so when I said MET ALD, I spoke of moderate alcohol consumption, that is 20 to 50 grams and 30 to 60 grams. So if you're asking me if there is data to say that the conclusively say what is the risk of the 20 to 50% from 0 to 20, there is not very much convincing data yet. But definitely there is emerging data to suggest that even those people who have little alcohol ultimately end up having a worse prognosis.
Thank you.
Sir, one thing I want to ask that in our general practice we are doing fibroelastography for assessing liver stiffness. So considering the patient of MASLD and MET-ASLD, whether it can be differentiated by this tool?
Are you asking me whether MET-ALD and mast-cell can be differentiated based on FibroScan? So FibroScan is a tool to assess the fibrosis of liver irrespective of the etiology. So the difference between metabolic and MET-ALD lies in the difference of the alcohol consumption, which unfortunately will come from the history only. I spoke of certain markers like PET, which is tested on hair, But again, there are some legal concerns, medical legal and ethical concerns regarding that effectively amounts to you or the doctor challenging the patient's history and taking the hair to examine and counter check the history, which, if you ask for the patient for consent, I don't know how many will actually be ready to do that. Okay, so no, so fibroscan cannot differentiate between the two, but it can assess the risk of or the amount of fibrosis in the liver by the stiffness.
Sir, as you told that MSLD is a combination of metal-D and this alcoholic liver disease. Sir, am I here? Okay. So, sir, is there a difference in prognosis of this metal-D in comparison to MSLD and ALD?
So, sir, MET-ALD is not a combination of mast cell and alcohol.
Yes.
There are 3 different conditions, even among the metabolic part. So there are these patients who are purely metabolic, that is with respect to, they have cardiometabolic risk factor, but his alcohol consumption is less than 20 or 30 grams per day. They are considered purely metabolic. Then there is MET-ALD I spoke about. Then there is this people who have more than 50 to 60 grams of alcohol per day. And they may have diabetes also or obesity also. They are called alcohol liver disease with metabolic risk factor. Some people are calling it ALD MET. So yes, there is a difference between the prognosis. The ALD MET do worse when it comes to the prognosis. Compared to the MET-ALD, the MASLD are relatively little better prognosis. So it's MASLD, MET-ALD and alcohol with metabolic risk.
Thank you, sir. Thank you.
Now I want to make this part of the session to end.
Thank you, Dr. Anand, for your excellent talk. So let's move on to the last talk of this session, that is on perioperative care of morbidly obese patient. For this, I would like to invite Dr. Pratim Datta sir to kindly chair the session, and we have Dr. Jayant Kumar Panda sir to deliver the talk. We welcome you, sir. Thank you.
Running late, so this very important topic, I would ask Dr. Jayant Kumar Panda sir to start the session. Sir.
Thank you, sir. Thank you for those nice words. And it's a beautiful ambience. I congratulate the Bengal Diabetes Foundation, especially my good friend Dr. Amitabh Biswas and the whole team for such a beautiful conference year after year. And I request all of you to give a big hand for the Bengal Diabetes Foundation and also the BDCON 26. This is a very innovative topic that I am speaking this morning. It's a preoperative care of the morbidly obese patient. This is a practical challenge for the surgeons, for the physician who are taking care of the patient around surgery. But all of us are well acquainted of preoperative or perioperative care of diabetic patients, controlling the blood glucose, controlling the outcome and controlling the operative situation. So this is something new, so I seek your attention next 15 minutes that if you are called as a metabolic physician by your surgeon friend to make the patient fit, follow up, how should you proceed? Thank you, BDCON. Why this topic now? We know that the obesity is in the focus, and of late obesity has been accepted as the chronic disease, not a lifestyle disorder by the WHO. and see the situation our surgeons are facing on the operation table. This class 3 obesity, where we define BMI to be more than 40 kg per meter square by WHO in adult more than 18 years, and the challenges around the OT table in the different WHO regions in the world have increased so far. In the Southeast Asia region, there is a 150% rise of surgical volume. That's increase in 6.8% per year since 1975. Means in 1975, a person on OT table being obese, whatever difficulties the surgeon was facing, that has increased by 150%, increasing 6.8% per year. And you can see the challenge in different WHO regions of the world. And then this obesity is increasing. The global obesity prevalence has tripled since 1975. And you know, after US and China, India is the third country in the world to have the obese population, even in pregnancy, even in children, even in elderly, and women population are more obese than the male population. It amplifies the perioperative mortality by 1.5 to 3-fold, and complications raised by up to 40%. You saw during COVID time, most of the people who died were obese, were morbidly obese, and it was directly related to their outcome from the severe COVID and cytokine storm. So elective and urgent surgery on high BMI patients are rising by 6% per year, straining systems in every WHO region. So today, in the next 15 minutes, I'll take you through the defining morbid obesity and its multi-system impact, integrating the cardiovascular, pulmonary, metabolic, and pharmacologic optimization into preoperative plans, plan airway positioning and thromboprophylaxis strategies, coordinating multidisciplinary teams and resources, and recognizing special populations and research gaps. So that is very important for you as a metabolic physician attending a patient in a hospital setup or in operation theater. Defining morbid obesity. That's very clear. I told you more than 40 kg per meter square BMI or more than 35 kg per meter square with serious comorbidity is defined as morbid obesity. They have obstructive sleep apnea, they have diabetes, they have hypertension, and they are considered as the serious comorbidity. A simple guideline you can take waist circumference and central adiposity when the waist circumference is more than 150 centimeter in men and 125 centimeter in women, adds independent risk for difficult airway and cardiopulmonary events. So, you know, the BMI is gradually being replaced by the waist circumference, and here we take the cutoff of 90 in men and 80 in women. Here 140 in men and 125 in women. If you measure, there is a clear indication that the patient is going to have a turbulent course in the operation theater. And this is the BMI classification by WHO. So your patient can be overweight, can be obesity class 1 or obesity class 2 or morbidly obese, but there is increasing risk in surgical outcome in these patients. Looking to epidemiology and global burden, 24 WHO reports show the class 3 obesity highest in Pacific Islands, Middle East, and rising sharply in Southeast Asia, that's 3 to 5% in 5 years. You can see the WHO regions. Definitely the Pacific Islands have highest patients, but ours is the first rising region, and 3 to 5% in 5 years, and every year we add around 6% people in this category. The perioperative risk profile, the American Society of Anesthesiologists, they closed the claim data telling more than 30% of severe or respiratory events attributed to obese patients, despite representing less than 15% of caseload. So the caseload is low, the complications are very high in them. So the 4 important issues they have are airway, the pulmonary complications, cardiac complications, and thrombotic complications. Be careful for these 4. The reduced functional residual capacity, rapid desaturation, difficult mask ventilation, and the intubation are issues in the airway. Decreased lung compliance, the atelectasis, the VQ mismatch, and higher risk of hypoxemia and pneumonia are the issues with the lungs or the pulmonary segment. The increased blood volume and the cardiac output, LV strain and hypertension, arrhythmias and ischemic risk are there in the cardiac field, and pro-inflammatory state because of the obesity, the venous stasis, endothelial dysfunction, and the platelet activation, high risk of DVT and pulmonary embolization are arterial events. So the morbid obesity amplifies perioperative risk across multiple physiologic systems. Proactive, tailored, preoperative strategy is essential to face them. Let us see multi-system comorbidity checklist. So when you are at the bedside of the patient in the hospital, what are the things you look for? In the cardiac, the left ventricular hypertrophy, heart failure with preserved ejection fraction, arrhythmias, and coronary artery disease. The echocardiography is a must, the ECG is a must, and clinical history and assessing ejection fraction is a must. In pulmonary, you take a history of obstructive sleep apnea, obesity, hypoventilation syndrome, asthma, reduced functional residual capacity, and increased risk of atelectasis and the hypoxemia. In metabolic, the type 2 diabetes has to be ruled out. If patient is not a diabetic, you have to assess the blood sugar and A1C as well. Dyslipidemia, MASLD, and insulin resistance are what you'll see. Psychologically, the depression and anxiety, the binge eating disorders, the body image disturbance and the low self-esteem, stigma and discrimination, and reduced treatment adherence are important factors. Endocrine, you have to see for hypothyroidism, adrenal stress response, polycystic ovarian syndrome, the altered sex hormone function, and rest you have to see for the CKD, for the reflux disease, osteoarthritis, and chronic pain syndrome. If you are not seen these factors, perhaps the preoperative assessment of obesity is incomplete. Let us see the team-based preoperative pathway. You have to do a early flagging in scheduling, the obesity clinic referral, and the multidisciplinary team evaluation. Always give a call to anesthetist, to surgeon, to cardiologist, to pulmonologist, nutritionist, the physiotherapist, and the psychologist, because it's sharing of responsibility. What you want to do alone, all can contribute their part, and that is a combined benefit for the patient. Weekly complex cash board you have to do with all specialty, optimize clear, and there is, if team approach, 40% shorter clearance time with weekly complex case board and less complication in these patients. The goals and shared decision making. The patient goals is realistic expectation. You have to understand the potential benefit and limitation of surgery. The weight loss targets, set achievable preoperative weight loss goals. When appropriate, the CPAP adherence. Before a week of surgery, you have to ask your patient to take CPAP, optimize treatment of obstructive sleep apnea, ensure the CPAP compliance before surgery, the post-operative mobilization, early mobilization, and the rehabilitation for faster recovery are important. So you have to discuss with your patient regarding risks like airway difficulties, respiratory complications, cardiovascular events, wound complications, and thromboembolism, and the benefits like symptom relief, improved quality of life, better functional capacity, and long-term health improvement when the weight reduction and the approach becomes very valid. The structured weight optimization includes 5% of pre-op weight loss via very low energy diet and GLP-1 agonist. Many of you have to practice this. Remember, if it's an emergency surgery, we cannot take this part. If it's an elective surgery, very well in the week 0 with the baseline assessment of medical and surgical evaluation, body composition, in week 1 to 2, the very low energy diet, and the week 3 to 4, the nutritional monitoring, titrating the GLP-1 agonist, which we have started week 1 to 2, and 5 to 6, assessing weight loss, reviewing the glycemic control, 7 to 8, the final assessment, the anesthesia and surgical planning, and day of surgery, reducing liver volume, improving metabolic state and better surgical conditions. Many of you must not be thinking that 5% weight loss is possible in a week's time, pre-operative, with a nutritional and GLP-1 approach. But this is what the science recommends. Please target 5% pre-operative weight loss, which has multifold benefits. It reduces the liver volume, it improves the insulin sensitivity, it betters the surgical condition, lowers the complication. And this is evidence in practice that structured 8-week program with more than 5% weight loss, 50% reduction in ICU admission in bariatric cohorts. So please take this 2 months effort of decreasing 5% weight, and that is possible in elective surgeries. The cardiovascular risk assessment includes assessing clinical risk, then the functional capacity with more than 4 metabolic complication and less than 4 MATs, and then in step 3, the mean BNP or NT-proBNP, and step 4, the echocardiography, stress imaging, and then no additional testing. So active cardiac condition may be present, and you have to look for the cardiac optimization, because the most important cause of morbidity is the cardiovascular issues. Then drugs. I have covered 3 important drugs, the cardiac drugs and the diabetic drugs the patient must be taking. One is the beta blocker, one is the ACE inhibitor or ARB, one is the SGLT2 inhibitor. Remember, you stop SGLT2 inhibitor in these patients at least 3 days prior to surgery because of risk of euglycemic diabetic ketoacidosis. This cannot be given, and if patient is on, you have to hold the surgery for at least 3 days if it's an elective one. You have to stop the ACE inhibitor ARB on the day of surgery if significant intraoperative fluid shift are expected, but you can continue with beta blockers throughout the perioperative period. Of course, you have to optimize the heartbeat, keep it 60 to 80 beats per minute, but you have to be careful regarding SGLT2 inhibitor, ACE inhibitors, and ARBs. The pulmonary evaluation, which includes screening for obstructive sleep apnea, assessing lung function, screening for obesity, hypoventilation syndrome. All of us know about the OSA or obesity sleep apnea, but obesity hypoventilation syndrome can put you in problem. So stop bang questionnaire is what you have to remember. This is a mnemonic I have given. Stop bang, STOPBANG, S for snoring, T for tiredness, O for observed apnea, P for pressure, that is high blood pressure, B for BMI more than 35 kg per meter square, A for age more than 50 years, N for neck circumference more than 40 centimeter, and G for gender, that's male gender. If they are positive, every criteria has 1 score, 0 to 2 is low risk, 3 to 4 is intermediate risk, and if this stop bang score is more than 5, it's high risk for obstructive sleep apnea. So you have to assess in every patient. You can jolly well do at the bedside, and you can remain careful for these patients. Optimizing the respiratory function, the preoperative CPAP therapy I was telling, at least for 7 consecutive nights before surgery you have to do that, which improves the PaO2 and reduces PaCO desaturation, and breathing physiotherapy has to be done before and after surgery for better outcome. The airway prediction, the red flag signs are large neck circumference, I have told, more than 40 centimeter in women and more than 43 centimeter in men. Limited mobility, that reduced neck extension and the head movement. The Mallampati classification, 3rd to 4th, indicates limited oropharyngeal view, and decreased thyromental distance less than 6 centimeters suggests potential airway difficulty. Please remember these 4 important red flag signs which help you assessing the patient bedside. Equipment and positioning are important. The head elevated laryngoscopy position has to be maintained. The video laryngoscope first pass has to be done. The Woogie has to be ready. The difficult airway cart and the fiber optic backup has to be there. So in these patients, you have to be especially careful for intraoperative problems. And remember, a gastric ultrasound helps. The enteral assessment, the epidiameter of the stomach, there is a high intra-abdominal pressure, increasing reflux, the delayed gastric emptying, and reduced lower esophageal sphincter tone if there is a issue from the stomach side. So the sodium citrate antacid, the rapid sequence inductions and ultrasonic gastric assessment is a must in these patients preoperative. The endocrine and the glycemic control, like targeting the blood glucose 100 to 180 milligram per percent, the basal insulin I have told you have to reduce by 20 to 30%, SGLT2 inhibitor hold 3 days before surgery, metformin you can continue unless eGFR is less than 30, and other oral agents has to be hold on the day of surgery. So this is perioperative insulin adjustment flow. I have shown you the chart, I am not going in the interest of time. Renal and hepatic considerations are important. You have to rule out the CKD or impaired renal condition and MSLD, as you heard right now, and the dose of low molecular heparin, the actual body weight up to 190 kg, you can give prophylaxis enoxaparin 40 milligrams subcutaneous, and therapeutic dose is 1 milligram per subcutaneous 12 hourly. Aminoglycosides like gentamicin and amikacin, the dose by ideal body weight to monitor and plan. The venous thromboembolism risk is very important in BMI more than 40, mobility, obstructive sleep apnea, and hyperestrogenic state. Here the Caprini score more than 5 is high to highest VT risk is predicted. So Caprini risk assessment has to be done, assessing risk factors, calculating the Caprini score, stratifying risk, and choosing the prophylaxis. The nutrition and micronutrient screening has to be done, looking to iron starters, vitamin B12, folate, vitamin D, and albumin. The psychological and behavioral health like depression, the binge eating, the substance use and support system have to be assessed. Logistic and infrastructure include assessment space, equipment, and safety workflow. This is what the OT structure has been shown, where the obese people are planned for surgery, and enhanced recovery after surgery includes your careful monitoring, where 1.2 day reduction in the length of stay is possible by your meticulous planning. Regional and multimodal analgesia is important. You can see here the gas, the needle in the plane. This is the transversus abdominis plane, where the air, this is the transversus abdominis plane where the anesthesia has been put, and this can be planned for intrathecal morphine, the neuroaxial consideration, TAP and ESP block. So the special population like pregnancy, pediatrics and elderly are to be treated carefully.
Sir,
There is 30 seconds. There is a reinforced wooden theater tables, portable oxygen concentrators, regional first anesthesia and teleconsultation specially designed for the obese surgery. An airway plan blood product consent, DVT prophylaxis order, escalation trigger, and other essentials are important that you have to do. And this research and innovation, you have heard about AI. These are the things, the AI airway prediction, the integrated patient profile, closed loop glucose control, the genetic VT risk stratification is what will give a future direction. So ladies and gentlemen, now we have to get ready in this era because obesity is the pandemic, and we have to take up many more patients, obese patients, for general surgery, for special surgery, also for bariatric surgery. So like you are giving the fitness to the diabetic patients, this is the time we have to get ready to give fitness to our obese patients, and here is the checklist which will make you fit for assessing and giving a go-ahead to your surgeon. Thank you for your time. Thank you for the invitation. Thank you all.
Thank you, sir. So, planning a surgery for a morbidly obese patient is definitely a challenge, and sir has elaborated in detail. As the time is short, so we can take one question from the audience.
Sir, if the patient is taking AC or ARB for non-hypertension, for any cardiogenic cause, do you still recommend stopping of the drug for 24 hours before elective surgery? As
Yes.
the recommendation is class 2B, if the patient is having no features of volume depletion, what is your opinion, sir?
Yeah, if there is no feature of volume depletion,
Yes,
you
sir.
can continue with that. But stopping ARB or ACE inhibitor for one day doesn't make much fluctuation in blood pressure. You can substitute with beta blocker if required.
Thank you, sir.
So, thank you. Thank you, sir.
Thank you everyone for this wonderful session. Now I request every speaker and chairpersons for the group photograph, please. I also like to call Dr. Jayaditya Ghosh sir, Dr. Riddhi Das Gupta sir, Diabetes is a vast and evolving field, extending far beyond glycemic control alone. There are several unique challenges, emerging concepts, and interesting clinical scenarios that enrich our understanding and shape our approach to diabetes care. We now move to our session titled Miscellany in Diabetes, where diverse aspects of the diabetes will be explored through experts' insights and practical perspectives. To conduct this insightful session, may I respectfully invite our esteemed moderator, Dr. Praveen Kumar Jadhav sir, to kindly grace the dais and take over the proceedings.
Good afternoon. After the informative previous session, we'll go to the next session, that is miscellaneous in diabetes. We have 4 talks here. The first one, the topic is gut microbiome in obesity and diabetes. I would invite the chairperson, Dr. Deep Mukhopadhyay, to chair this session. Dr. Deep, please. I'll request the chairperson to introduce the speaker and to start this session, please.
Just a small announcement for the delegates and all. We are distributing the BDF t-shirt from our BDF stall in the second floor. So the delegates can collect their BDF t-shirt from the BDF stall. Thank you. Over to the session, please.
I welcome Dr. Sinjan from Kalyani to talk on the burning topic of microbiome
be it any NCD, this is like in obesity and diabetes.
Thank you. Good morning all. Good morning all respected delegates. Thank you Chairperson for the kind introduction. At the outset I must like to thank the organizer for their kind invitation here. It's really nice to be here at the BDCON and pleasure having here. So just going to the topic per se, it's about the gut microbiome and most important topic as of now, the gut microbiome in obesity and diabetes. So the most important aspect which I will be trying to highlight, do we have a proper clinical implications of knowing the variety or the dysbiosis or the abnormality of the gut microbiome in cases of obesity and diabetes, and can we modify, and with the existing clinical therapies, can we make a gut microbiome directed therapy? So that is the basic points which I will be most likely try to cover. So starting with some historical points. So this is perhaps the earliest recommendations or earliest representations of the gut microbiota. This is the person, the Leeuwenhoek, Antonio van Leeuwenhoek, at the earliest 1631 or 1634 per se, from his own fecal and saliva samples. He saw all this, whatever that time the microbiology was not that developed, so he called this animalcules. And then after subsequently, almost, he wrote a letter to the society describing this and what he found that, but there was not much of a findings even after 100 years after that. So then comes almost after 100 years, there was a proposed connection with the gut microbiota and neurological health, and from then the real clinical history of gut microbiota started. So what it is, it's basically the trillions of microorganisms in the gastrointestinal tract which influence the development of the various metabolic syndrome like diabetes. It's almost around 100 trillion cells, almost 10 times of the number of the human cells, and the density of composition varies from the upper intestine to the lower intestine to the colon. Various factors like host, age, sex, weight, diet, I'll come into the later slides, immune system, mucus production, disease states, medications affect the distribution of the gut microbiome. We need to know why colon is the most inhabited gut microbiome area, because having a high transit time, favorable pH, low cell turnover, redox potential, and particularly conductive to this bacterial proliferation. So just need to know these predominant 6 phyla, because I will be discussing these names again and again. So Firmicutes, Bacteroides, Actinobacteria, Proteobacteria, Fusobacteria. Some other names I will also call out in the subsequent slides. Now, how it happens from the birth to elderly population. So obviously, the total distribution of the gut microbiome varies throughout the life. So it influenced by the delivery mode, differences between a vaginally born and a caesarean born infants. So first it shows an actinobacteria abundance, but it decreases after weaning and continues to decline with age. Then comes the Firmicutes, which dominate post-weaning, but it again getting less abundant after 4 years of age. And the Bacteroides and Proteobacteria that increase typically in the elderly age at around 70 years, opposite to the Firmicutes, it starts decreasing. So these are the usual composition of the microbiota. We will be obviously discussing about the gut, but these are the other commensals. They are in the skin, respiratory system, and the oral mouth cavity. Now there is the diversity not only among the whole intestinal system, there is a diversity according to the global population as well, or a geographical population. So it has been seen a typically vegetarian population, obviously India will be a prime example, where the Prevotella is very predominant. Wherever most of the non-vegetarian diet, predominantly non-vegetarian diet are consumed, especially meat, they are having Bifidobacterium and Ruminococcus. So as I was highlighting, so there are host factors, external factors, and some intrinsic factors that lead to the distribution of the gut microbiota. So it can be feeding method, various types of weaning, age, gender, weight, circadian rhythm, immunity, or it can be external factors like mode of delivery, or it can be various intrinsic factors like the bioavailability of the nutrients, pH of the colon. These all highlight the distributions of the gut microbiota. Now, what does this gut microbiota do? Why it is important to know specifically in relation to the metabolic syndrome or diabetes? So basically it has got three important functions. The first is the structural integrity of the intestine. It maintains the barrier integrity. Then the metabolic functions, which we will be discussing in detail, production of the various secondary bile acids, fermentations of the non-digestible carbohydrates, association with the xenobiotic metabolism, and also it's very important to protect the immunity, pathogen displacement, acting as antimicrobial factors, an important factor in innate and adaptive immunity. So just to summarize how it works, the gut microbiota. So this is the gut microbiota which produces the short chain fatty acids, because this is the most important mediator of their functions. So what they do, the generation of the monosaccharides or the formation of the secondary bile acids or essential amino acids or essential vitamin K or biotin. This is one of the most important thing they do. Another very important thing they do or modulate, which will be very important in this metabolic syndrome or diabetes discussion, is this. They induces the satiety and produces this anorexigenic hormones. This anorexigenic hormones is typically the GLP-1, the PYY and the leptin. These are the three very important hormones productions they monitor or they modulate. Another one, they releases the leptin in the adipose tissue, causes the gluconeogenesis in the liver, increases the gluconeogenesis in the small intestine, similarly lipogenesis in the muscle, bile acid productions as well as release of these hormones again in the large intestine is very important. So now, what are the association of the various diseases with the gut microbiome? So we will be mostly discussing about this area, why there will be a metabolic dysfunction or diabetes or obesity related to the abnormalities in the gut microbiome, but obviously also the chronic inflammations or the neurodegenerative or the neuropsychiatric disease, they are also implicated to be associated with the abnormal modulations of the gut microbiome. So how this metabolic abnormality happens, there are generally two broad mechanisms. First and foremost is the increasing energy harvest. What they do basically to make it as simple as possible, they extract more calorie from the food. So a patient with diabetes or a metabolic syndrome, their gut microbiome extract more calories from the food. How they do? Obviously, there are various predictors, but one of the most important predictors is the modulation of these short chain fatty acids, because these short chain fatty acids produces those anorexigenic hormones. So, what are the predictors? The most important one of the predictor can be this formicoids and bacteroides ratio. I already highlighted these are the two important phyla of the gut microbiome. It has been shown in some of the study, this increased formicoids and bacteroides ratio is associated with the metabolic syndrome. But yes, it has been also refuted in some, and this is one of the reviews where they highlighted this ratio cannot be taken as a very definitive marker of a metabolic syndrome. So what is now currently known is the total bacterial count or the specific composition abnormality or the altered short chain fatty acids that is responsible for this metabolic syndrome. And some of the specific phyla like Lachnospira, Oscillospira, Prevotella, they are negatively associated with the weight, or some Faecalibacterium, Clostridialis or Clostridium, they are positively associated with the weight gain. Also, it has been shown that whenever there is a reduction in the butyrate producing microorganism, that leads to glucose impairment, glucose intolerance, reduced insulin sensitivity, reduced PYY and GLP-1, and leading to diabetes. So in one of our recently published review paper in Indian Journal of Endocrinology and Metabolism, we suggested these particular metabolomes to be studied for diagnosis of the diabetes and metabolic syndrome, where we have typically highlighted the short chain acyl carnitines and this phosphatidylethonamines. They can be associated with the modulations of the gut microbiota, where we can these particular metabolomes to be upregulated for the diagnosis of the diabetes and metabolic syndrome. Now, the role of diet is also there, which can alter the distribution of the gut microbiota. So it has been shown with the Mediterranean diet, it reduces the Prevotella copri. which link to the improved insulin resistance. Similarly, whenever a fiber-rich Western diet the person consumes, it reduces the same bacteria, which gives the similar metabolic benefit. Wherever in the opposite side, if a high-fat diet has been consumed, they alters the gut microbiota, increasing the gram-negative bacteria and reduce those short-chain fatty acids. So ultimately, what happens that compromises the intestinal integrity, allowing the translocation of bacteria, and these components, the lipopolysaccharide, like flagellins, peptidoglycans, they are released into the systemic circulations. And also it has been seen comparison between an animal-based diet and vegetarian-based diet, that the animal-based diet lead to increase in a bile-tolerant bacteria and decrease in the fiber fermenting bacteria. Can be results, the alterations of this gut microbiota can be due to various drugs. So there has been studies where prenatal exposure to various drugs, antibiotics obviously, has been studied to see the alterations of the gut microbiota in the children. So there has been studies, like this is one of the typical long-standing study, long-term study, where the short and long-term impacts of the azithromycin treatment on the gut microbiota has been seen in 12 to 36 months of child because of respiratory tract infections. And this RCT showed that 14 days using azithromycin that reduced the gut microbiota richness and diversity, but there has been no differences in the gut microbiota composition after 3 years of therapy. Apart from extracting the higher calorie from the various complex carbohydrates, altered inflammation and endotoxemia can also be responsible for this metabolism defect. So what it leads to, there can be the various, slides are not moving, I think. Slides move. Is this gut microbiome dysbiosis? So what happens is that obviously this can be the precipitating factors like the high fat diet or the high protein diet. So what leads to, there will be increasing intestinal permeability, there will be more of energy extractions, there will be loss of the hypoxic environment, causing this increasing firmicutes to bacteroid ratio. So leads to more of adipogenesis, sympathetic nervous system activations, this metabolic endotoxemia and this meta-inflammation. So these are the complex mechanism, the metabolic alterations of the gut microbiota that leads to this metabolic syndrome. Now, just knowing the pathophysiology is not enough in our thing. We need to have an understanding all this metabolism, all this abnormal metabolism, how we can modulate therapeutically to get rid of this abnormality and treat the diabetes per se. So obviously treating as one of the most important point is the dietary interventions, because the diet is one of the most important factor that modulates the gut microbiota. So that's why Mediterranean diet has been shown to restore this diversity in the gut microbiota. And the studies have shown, this is one of the review published by Perron et al., which has shown the beneficial effect of the Mediterranean diet in restoring the normal gut microbiome and improving the metabolic health. The others, the prebiotics, the probiotics, or it can be the fecal microbiota transplantations or the use of the GLP-1 receptor agonist. So what about the prebiotics and the probiotics? So the prebiotics are basically the non-digestible food ingredients from the oligosaccharides, dietary fibers, or the non-digestible carbohydrates. It promotes the growth of the beneficial gut microbiota. Whereas the probiotics are which is found in the normal foods or the supplements in microorganism, yogurt, cheese or fermented foods, that also improves the survival and activity of the beneficial gut microbiota. So how we do is basically modifying the short chain fatty acid, reducing the cytokine expressions, recovery of this tight junction, increasing the leptin or the GLP-1 or PYY hormones. Now, little bit about the fecal microbiota transplantation, one of the recent advances to restore the abnormal gut microbiota. So there has been few published cases. There are randomized controlled trials as well in people in obesity and diabetes, where they have been comparing with the lean donors or the obesity donors. The problem is there has been not much of a good results, specifically if the fecal microbiota transplantation from the lean donors have been there. There has been good results in the lean donors, but not much in the case of obese donors, where the colonization occurs in over 90%, but the weight loss or those outcomes were not that great. So there is a review article just recently published by Proenka et al. They have summarized all this fecal microbiota transplantation, which shows improvement in the metabolic syndrome parameters, but again, they are very less in number and short-term follow-up, so maybe not that important or not that clinically significant as of now to highlight the importance. Now, very importantly, the role of the GLP-1 agonist. We are using it specifically after the op-patent of the semaglutides. A lot of patients are putting on the GLP-1 agonist. So importantly, we have trials, preclinical as well as clinical trials, mouse models and human models about the dulaglutide, liraglutide and the semaglutide, which has shown beneficial effect on the microbial ecology. Weight loss itself obviously can occur, alters the microbial composition, and obviously there can be a bidirectional relationship which has to be understood in the upcoming times. So there has been also a review, a detailed narrative review of the GLP-1 analogs and agonists on the gut microbiota, which has shown beneficial effect with the use of both, all these three, this dulaglutide, liraglutide and of course with the semaglutide. Now, obviously, some aspects of the newer techniques which can be used as a bacteriophage, we can use the microbiota targeted drugs as well as some postbiotics as well as the byproducts of the metabolic process, or exopolysaccharides or GABA or extracellular vesicles can be used. But obviously, as we are going into the precision age of the endocrinology, so perhaps we can have a microbiome informed obesity phenotyping. We can have a more predictive biomarkers, specifically when you are using the GLP-1 analogs, and specifically therapeutics targeting these metabolites and maybe integrations more with the metabolites. So just to summarize, that the gut microbiota are a rich, heterogeneous, biologically important microbial agglomerations. The mechanism causing the metabolic syndrome is basically two gross mechanisms. One is the increased energy extraction. The second is the altered inflammations or the meta-inflammations, which we call. I think it's too much of everything. So obviously with the manipulation of the alterations, there can be increased generations of the pro-inflammatory metabolites. And as far as the clinical significance is concerned, or the therapeutic significance is concerned, diet, prebiotics, probiotics are proposed to modify, but not much of a data which we have. Fecal microbiota transplantation results are encouraging, but we need long-term evidences. But perhaps the realistic, which we are using more and often in our clinical practice, is a GLP-1 receptor-based therapy, which is there in the fecal microbiota, in the gut microbiota mechanism as well, and it has shown a promising results in improving the gut microbiota. So with this, I end my talk. Thank you for your kind attention. I will be happy to take any questions. Thank you.
Thank you, Dr. Sinjan, for a nice deliberation. We can accommodate one or two questions from audience. Please shoot
Sorry,
something.
I think most of the slides gone like that only.
Audience may shoot some questions to Dr. Sinjan if they have any.
Yes, sir.
I came late. So what's your take on intestinal dysbiosis with metformin, a very commonly used anti-diabetic agent? You have talked about the positive effects of GLP-1 agonists, but what with metformin?
Yes, it has been shown in some of the trials that it can alter the intestinal microbiota with the long-term use of the metformin. But again, to term metformin to be improving or decreasing or improving or deteriorating the gut microbiota, that evidences we are lacking as of now. Till on as an anti-diabetic drug, the GLP-1 receptor agonist having the best possible evidences as of now. Metformin still a bit
We take it as neutral.
Yes, till on neutral. As far as other anti-diabetic drugs, it's mostly neutral as of now. No, not much of any bad or good effects as of now for any other anti-diabetic. Yes, sir. Yes. I think you were talking about the inflammatory bowel disease and irritable bowels. Yes, yes. Obviously, that is there more because anyway the gut microbiome is very important to maintain the immunological barrier, the integrations of the intestinal barrier as well. So obviously, fecal microbiota transplantation can be helpful in those diseases as well. But to interpret this or to make it more helpful in this metabolic syndrome and diabetes, we need more evidences, more long-term trials, and that is anyway difficult in such case. Thank you for the comment, sir.
Sir, in one slide you have told that 14 days treatment with azithromycin can cause this loss of my but we are hardly using 14 days therapy with azithromycin.
Yes, so that trial actually shows they had done a short-term and a long-term outcome. Their short-term outcome, there was abnormality in the gut microbiota. But when they see after 3 years, that was the good point of the study. That's why I quote that study. There was hardly any evidence of that. So they are saying that short-term anyway, azithromycin we will use anyway for short-term only for those respiratory tract infection, asthma or regarding that. That doesn't alter much of the microbiome. But yes, these antibiotics and all, they are one of the predicting factors of the abnormality of the gut microbiota that we should keep in mind. That is one of the important highlight I tried.
Or simultaneously we can give prebiotic and like that?
Yes, that's...
Okay. Thank you, thanks.
Okay, thank you, Dr. Sinjan. Congratulations for your talk. Thank you.
Thank
you. So, very informative session. We'll go to the next lecture that is on a very important topic, that is from insulin resistance to organ protection, repositioning the pioglitazone, dapaglitazone. And I would invite Dr. Manas Malik, who is an eminent physician and diabetologist in this region, to take over as chairperson for this session.
Thank you, Dr. Praveen. Good afternoon to you all. I would like to call upon stage, without wasting any time, Dr. Abhamani Baro for the next topic and talk and enlighten us. Thank you.
At the very outset, I would like to thank the organizing team of BDCON, Bengal Diabetes Foundation, for giving me this opportunity today. So it is very, very nice to be here, and thank you for today's session. So my topic is from insulin resistance to organ protection, repositioning pioglitazone, dapagliflozin. My agenda would be, so I would talk about SGLT2 and pioglitazone combination. So why am I talking about this? So because like we have still forgotten pioglitazone, and we are somewhat very much afraid on using pioglitazone. So basically, why to choose this combination? What are the best candidates for this combination? Are we afraid of pioglitazone, and when to avoid this combination? So why this topic? Because currently GLP-1RA and SGLT2 inhibitors are the first line drugs for type 2 diabetes management, especially if the person has ASCVD and cardiovascular disease or CKD. But then pioglitazone is not a popular choice till date. The reason being doubt on cardiovascular safety, adverse effects, and reduced familiarity. Pioglitazone is an age-old neglected drug, needs reevaluation for better understanding its safety and efficacy. Pioglitazone, I would say it is D. Franz's favorite molecule. He said that it is better to die little overweight, it is better to live little overweight than to lose weight and die. So pioglitazone is a forgotten cost-effective cardioprotective drugs for type 2 diabetes. We have remembered the adverse effects like bladder cancer, macular edema, but then we have forgotten that yes, it do have a cardioprotective effect as well. So why choose this combination? Because it targets two different pathophysiologies of diabetes. Pioglitazone is the only insulin sensitizer, because metformin is also a sensitizer, but it is more potent insulin sensitizer. And SGLT2, we know it inhibits renal SGLT2 and it leads to glycosuria and calorie loss. So both of this together leads to complementary and synergistic action. Now, also they mitigate each other's limitations. Now, SGLT2 indicates adverse effects of pioglitazone like fluid retention and sodium retention, because SGLT2 leads to glycosuria and natriuresis. It also reduces the pioglitazone heart failure. So it reduces the risk of heart failure due to pioglitazone. It reduces the weight gain due to pioglitazone. On the other hand, pioglitazone reduces the risk of SGLT2 induced diabetic ketoacidosis, because pioglitazone reduces lipolysis and also reduces the availability of free fatty acid for production of ketone bodies. So the chances of euglycemic decay with SGLT2 goes down if we use that combination together. Now, there are various studies going on in regards to the combination therapy as compared to monotherapy. So there is additional HbA1c reduction with pioglitazone when added to SGLT2 inhibitor. So there is an additional 0.48 to 0.5% when this combination used. So the combination gives us superior glycemic control. Moreover, the weight gain seen with pioglitazone alone is not seen when the two drugs are used together. Rather, there is a overall weight reduction. So almost minus 2.3 to minus 2.5 kg when both drugs are given together. So it is equivalent to only SGLT2 inhibitor. So when the two drugs are combined together, the weight loss effect of SGLT2 is not omitted. It is more or less similar. Now, pioglitazone, it induces adipose remodeling. It is an insulin sensitizers which remodels adipose tissue. Basically, pioglitazone, when given over 6 months, it was given in obese humans. It's a recent study with type 2 diabetes, and biopsy of the adipose tissue was taken. So it leads to selective decrease in arachidonic acid containing glycerophospholipids. Because this AA, that is arachidonic acid containing glycerophospholipids, are responsible for inflammation. So they reduce this AA containing glycerophospholipids, ultimately reducing the meta-inflammation. So the weight gain associated with pioglitazone is a healthy weight gain. So pioglitazone and SGLT2, there is fat redistribution plus there is fat loss. This is the ideal combination for South Asian phenotype. What is the South Asian phenotype? It is early onset diabetes at a lower BMI. There is increased visceral adiposity, increased waist circumference, high insulin resistance, as well as there is thin fat obesity. So this is Dr. Yajnik. So we all know Dr. Yajnik is from Pune, very renowned senior diabetologist and a national figure. So he had put this photo with Dr. John, it is his friend. So he is from London and Dr. Yajnik is an Indian phenotype. So as you can see, BMI is a not good method to understand obesity, because both of them have similar BMI, but if you look at the body fat percentage, Dr. John, his friend from London, had only 9% body fat, but yeah, Dr. Yajnik had only 20, he had more body fat, that is 21.2% of body fat. So BMI is not an ideal way to understand or to diagnose obesity. It is a body composition and body fat. So in this type of patients, this is the YY phenotype, the South Indian phenotype, the thin fat obesity, pioglitazone works the best. DAPA and PIO combination, it has multiple benefits beyond glycemic control in the heart, kidney, as well as stroke, MSLD, and as well as diabetes prevention. How? Let us see. So if you look at the study, that is pioglitazone SGLT2 combination, this is a national-wide cohort database study, and in this trial, it was in this meta-analysis, in this study, it was seen that when combination therapy was used, it led to 24% lower risk of MACE and 28% lower risk of stroke. And this is primarily driven by pioglitazone by reducing stroke as well as reducing myocardial infarction. So in ASCVD, combination therapy provides complementary action because pioglitazone primarily acts on the pipes. It reduces atherosclerosis, it improves endothelial dysfunction, it reduces triglycerides, and it increases HDL levels. Whereas SGLT2 primarily acts on the pumps, that is the heart. It acts on the failing heart. So again, if you can, if you revise the that is proactive trial of pioglitazone, that is prospective pioglitazone clinical trial in macrovascular events, where more than 5,000 diabetic patients with macrovascular disease were given pioglitazone and they were followed up for a mean period of 3 years, then pioglitazone had significantly reduced the composite of all-cause mortality, non-fatal MI, and stroke in diabetic patients with high risk of macrovascular events. But then somehow there was slightly higher heart failure with pioglitazone. But the secondary main endpoints were significantly better with pioglitazone use than the placebo. Moreover, from the declared TIMI and DAPA heart failure, we know that SGLT2 inhibitor, dapagliflozin, reduces hospitalization due to heart failure as well as it reduces the all-cause mortality. So when we combine these the two molecules, then the heart failure effect of pioglitazone goes away. So you can see that combining this molecule, it ultimately leads to 33% lower risk of heart failure. So as you can see, when we use pioglitazone, there may be a risk of heart failure, but when we combine both, the risk of heart failure goes away. At the same time, the benefits of MACE given by pioglitazone, it is exaggerated. Again, observational studies more have shown that there is also improvement in all-cause mortality with this combination. But some meta-analysis may not show all-cause mortality improvement, but again, still the effect on the all-cause mortality is a conflict, but some studies say there is improvement, but some studies do not show improvement. Effect on the ischemic stroke. So pioglitazone from the IRIS study, we know that is pioglitazone after ischemic stroke or transient ischemic attack. So if we go back to the study, we will understand that pioglitazone has a role in stroke prevention. So as you can see, in the IRIS study, pioglitazone reduced stroke or MI by 40%. Along with acute MI also, it reduced the occurrence of new onset diabetes by 80% over a median follow-up of almost 5 years. So definitely pioglitazone has a role in reducing stroke. About SGLT2 studies, some studies are showing that it reduces stroke, some studies are showing that it increases stroke. So again, conflicting results of SGLT2 on stroke. But again, when we combine SGLT2 and pioglitazone, then we may get a reduction in stroke and a stroke benefit in patients. Now again, a stroke benefit from pioglitazone again through the pipes, that is reduction in atherosclerosis and atherosclerosis progression, reducing triglycerides and increased HDL levels. Now again, if you look at this study, this is the first Indian study to evaluate the effect of this combination of SGLT2 inhibitor and pioglitazone on liver, that is fibrosis score in patients with type 2 diabetes with MSH, and it was shown that the combination when used together, it has better impact on the V4 index score. There are other studies which are being recently published, and it has shown that this combination of pioglitazone and gliflozins or SGLT2 inhibitor can they can improve MRI PDFF. So MRI PDFF means it's a non-invasive technique to see the basically fat fraction, MRI based proton density fat fraction. So it significantly reduces. It also reduces the ALT levels and also the GGT levels and as well as the liver fat score. Again, SGLT2 and pioglitazone, they together have synergistic action. Pioglitazone reduces the influx of fatty acid to the liver, so the non-esterified free fatty acids deposition in the liver comes down. SGLT2 again leads to calorie loss, almost 400 kilocalories, and ultimately leads to glucosuria. They also have other pleiotropic effects like anti-inflammatory action, antioxidant action, reducing leptin, increasing adiponectin. So these are other pleiotropic effects which both have, and again apart from this, their indigenous effect on the liver ultimately have an additive effect and leads to betterment in the MSLD. Now combining these two molecules, there are newer studies that if we combine this molecule, and these are on the nephropathy, these are studied on the animal study only. So mice study are being done, and then they have said if this combination is started at a very early phase of diabetic nephropathy, they can even reduce the progression of diabetic nephropathy progression by they ultimately slows renal hypertrophy progression. They also decrease the various inflammatory and fibrosis markers in animal models. Now DAPA-CKD, again we know DAPA-CKD have a very good result on the kidney progression and CKD progression. So again, if we add pioglitazone, so even dapagliflozin will exert its effect, and pioglitazone can give a synergistic and boost the effect of dapagliflozin. Now chances of diabetes reversal. From the ACT NOW trial, we know that this study was done on patients with prediabetes with impaired glucose tolerance, and pioglitazone was given, and it showed a significant 72% reduction in the development of diabetes. So again, that is why pioglitazone came up as a drug for prediabetes. But now there are newer studies that even dapagliflozin and SGLT2 can lead to improvement in beta cell function, and there are now studies on like mice studies and animal studies which shows that dapagliflozin can promote beta cell regeneration from the duct cells as well as from the alpha cells. So it is by dedifferentiation, transdifferentiation as well as replication. So this is a very good news, and yes, if we start this combination together early, then there is a chances that we can get a reversal of diabetes in future. Also, we get an economic benefit with this combination. So if you see, look at the NNTs, number needed to treat. So when pioglitazone was used, so in the proactive trial, the NNT for MI and stroke was 24, stroke was 39, diabetes was 12, and it was over 5 years. The economic benefit of dapagliflozin also, the prevention of heart failure, NNT is 21. But if we think that, okay, pioglitazone can lead to fracture, NNT for fracture is 125. So definitely it is unmatched. The benefit outweighs the risk. So we should always go for this combination wherever it is possible. Again, risk of bladder cancer, still a conflict. There are studies where it has seen that pioglitazone leads to increased risk of bladder cancer. Again, there are studies where use of pioglitazone has not been associated with increased risk of bladder cancer. Now, when to avoid this combination? Suppose a patient has osteoporosis, because yes, pioglitazone can lead to osteoporosis, because again, it leads to dedifferentiation of the osteogenic cells to like adipogenic cells. So that is the reason. Again, heart failure, NYHA 3 and 4. When we use it in NYHA 1 and 2, again, we have to be careful. If there is an active bladder cancer, then again, we do not use it. If the patient already has a liver failure, transaminases are more than 3 times elevated, because there are case reports of pioglitazone. It is very rare. It is more common with troglitazone, but with pioglitazone it is very rare. But even with pioglitazone, there are very rare case reports of acute liver failure. So if the AST/ALT are very high, patient is in acute liver failure, then we don't give. And yes, pioglitazone can lead to progression of macular edema, and that is why in presence of macular edema we do not give. Now, use with caution in elderly. Again, more than 65 years, the chances of osteoporosis are high. So again, and bladder cancer is also high. So again, we have to be careful. Postmenopausal women with high risk for osteoporosis, we have to use it caution. Again, in elderly patients, if we look at the risk of heart failure does not increase with use of pioglitazone. Dementia, it is better, but then again, new diagnosis of fracture may be higher in patients who are elderly, and when we use pioglitazone in them. Now, even recent guidelines on this combination, IDS says, as you can see, this combination has, like when a patient has risk of MASLD or MSH, then definitely we give SGLT2 and GLP-1 RA, but the guideline also suggests that we can give pioglitazone as an add-on to SGLT2 or a GLP-RA, a combination in diabetes with MSLD and MASH. Now again, as you can see, the guideline has already endorsed this combination. So it is better to give this molecule or combination in early part of the fibrosis or early part of the MSLD, that is FIB score 1, 2 and 3, but then when the person has already have a compensated cirrhosis or decompensated cirrhosis, again issues with fluid retention may come out when we use this combination. ACE guideline has also endorsed pioglitazone as a molecule to treat MFLD and to reduce the fibrosin risk stratification. Now, combination drug, again, it can be given separately or it can be given as fixed drug combination. So again, the fixed drug combination that are available of DAPA and pioglitazone, they are bioequivalent, and again, giving a FDC gives a better and simpler regimen to our patients. So to conclude, combination therapy of pioglitazone and SGLT2 have cardiac, kidney and metabolic benefit, should be an initial choice in management of diabetes and started early. Pioglitazone should be repositioned as a powerful metabolic agent, not just a glucose lowering therapy, and it is well suited for Indian phenotype because it reduces insulin resistance, improves visceral adiposity and also MSLD along with cardiac, kidney and other benefits. Thank you for your patient hearing.
Thank you, madam, for a very informative talk. Thank you very much. Due to lack of time, I am giving it over to Dr. Praveen for the next talk to invite upon us.
So we are sorry we are not taking any questions due to lack of time. So thank you, ma'am, for the wonderful lecture, and we'll go to the next talk, and let me invite the chairperson, Dr. Ashish Chatterjee, who is a well-known physician in this region, to chair the session. And the topic will be a very interesting one: protein engineering for reduced insulin burden, the advent of ICODEC, that is the weekly insulin. And I'll invite Dr. Pankaj Singhania for the lecture.
Good afternoon, everyone, and thank you BDCON, Amitabh Vishwas sir, and the rest of the organizing committee for bringing me here and bringing this very interesting molecule, which perhaps is the latest thing in endodiabetes that we know of. Perhaps there is nothing more thought-provoking. Patients are coming and asking us, Doctor, we've read about this, can we take this? And so perhaps it's less than maybe 15 or 20 days old in the Indian scenario. It was in the middle of July that it was available to us. Many of us have perhaps not had our first-hand experience with it also. We've not yet used it. I have used it in a couple of patients. We are still waiting for the results. But it's good that we are discussing this in this gathering, a thought-provoking topic, and I expect a lot of queries and questions regarding this. I'll try to answer most of them with the limited knowledge that I've gathered over the last few weeks. So it's about ICODEC. We know insulin is short-acting, intermediate, long-acting and ultra-long-acting. The ultra-long-acting insulin available to us till now was degludec, which has a duration of action more than 40 hours, but it has to be taken once daily because that does not cover up for more than one day. Now we're moving into an era with the help of protein engineering where we have modulated or modified an insulin molecule with certain changes to make it very, very long acting. Not just long acting, we are now saying weekly insulin. So insulin, once a week injection has become a reality and it is available to us, and we expect that it will work. And the data from the onwards trial that has happened over the last many years are also convincing about the efficacy and the safety of this drug as well. So let's dive into the presentation. This is the burden of diabetes in India. Many people in India need insulin. They do not get insulin. They do not take insulin. The biggest problem with insulin is it's an injection. Whenever you ask your diabetic patient who is on a combination of OHAs, that is not working and he or she needs to take insulin, the patient looks at you with a blank staring look. He suspects you. You look at the patient that, how do I convince you? How do I convince you? Please agree to this immediately because there's nothing more that I can do. And then obviously sometimes there is a breach of trust also where the patient does not take your advice and move to the next doctor who might be offering another combination of OHAs. So the biggest problem with insulin injection is an injection. We always looking for maybe tablets of insulin, nasal insulin, other forms of insulin which are not painful. But then this is one solution that we are looking forward to, which will reduce your pain if not entirely mitigate it. So less frequent injections, simple and easy to use regime and flexibility in dosing. So it's like increases adherence, increases convenience, and increases satisfaction. So it kind of reducing the number of injections to maybe 4 per month. From 30 to 31 injections, it comes down to 4 per month is what we are offering to our patients. That is sometimes very satisfying for some of our patients who are on daily long-acting insulin injections. So what is the science behind this? Like what I've said, 365 injections per day to 52 injections per day. And this is the molecule and its modifications that have been done. 3 amino acid substitutions, removal of the terminal threonine, and addition of this fatty chain. We always do this addition of fatty chain in order to create a depot, and then it's released from that depot subsequently, and therefore prolong the action. That's what we have also done to the other long-acting insulins which are in use currently. It increases the binding to the receptor, improves stability, is highly soluble. There was one query which came to me the other day when the patient, I offered this, the patient thought that I'm giving a 7 days injection in one shot. 20 units multiplied by 7 makes 140 units. So it will be maybe this much of injection that the patient will have to take, this volume, maybe 1 ml, 2 ml or 4 ml of injection he will have to take at a shot. No, the increased solubility of this molecule has made it very concentrated. We know of U100, we know of U300, the initial injections were U40, this is U700, that is 700 units of insulin in 1 ml. That's very, very concentrated, and ultimately the volume of injection that you are taking, whether it's 20 units of glargine or 140 units of icodec, the volume is almost same. So the painful thing with the high volume is also not there. And slow receptor mediated clearance, obviously that prolongs the action, and strong reversible binding to albumin. That is where it binds primarily to albumin and obviously releases from there slowly over a duration of 7 days. And the release over 7 days is almost equal on each day. Therefore, there are no chances of severe or difficult to treat hypoglycemia. The hypoglycemia risk is also like the previous long-acting insulins. So it's a once daily injection, as I've said, 7 times the dose, 700 units is the concentration of the insulin. 1 ml contains 700 units of icodec. This is how it works. An hexamer dissociates into monomers. These monomers bind to albumin, form an inactive depot with the help of albumin, slowly release, and the same signaling mechanism. Basically, the thing is like regular insulin, like insulin what we've been using. The mechanism of action is same, the receptor is the same, the place where it goes and works is the same, excepting for that we are creating a small depot for 7 days in association with albumin. So the onwards trial. The onwards trial was a series of trials which were done with icodec to look at how icodec works. There are primarily 3 things which we are looking at: HbA1c compared to a comparator, we are looking at TIR, and we are looking at hypoglycemia episodes, because there might be a concern about higher incidence of hypoglycemia, prolonged duration of hypoglycemia, and difficult to treat hypoglycemia once you've given this weekly injection. The injection has gone inside, you cannot withdraw it for the next 1 week. So people are concerned that it might lead to difficult to treat hypoglycemia. But that is not what the case, that is not the case which the onwards trial have proven. These are the 3 trials, onwards 1, onwards 3 and onwards 4. These are the trials where insulin was initiated in a patient. The patient was not taking insulin. So onwards 3, 1, 3, 5 are 4 those, and onwards 2 and 6 are 2 and 4 are the trials where the patient was already on insulin, shifted to icodec. So this is the study design for the onwards 1-3 trials. You can see icodec on top and glargine or other forms of comparator insulin in either glargine or degludec was given in this arm. And this is the trial. The trial went on for 78 weeks. Primary analysis was done at 52 weeks, and then there was another duration of 5 weeks follow-up. Look at the HbA1c reduction. It is not inferior. I will not say it is superior compared to glargine or comparator, though it might seem a little superior. But the main problem or the main intention of doing this was finding out whether it is inferior to glargine or degludec. It is clearly proven that this molecule is not inferior to glargine or degludec, because we are not looking at efficacy. We are looking at safety and reducing the number of doses. So that's why it worked as good as glargine or degludec. TIR, the time in range by the CGM metrics, was also impressive. 71% plus with icodec compared to 67% with glargine. Hypoglycemia. These trials, these onwards 1, 3, 5 trials clearly proved that there was no significant difference between the episodes of hypoglycemia with icodec compared to comparator, and the duration of hypoglycemia was also 35 to 40 minutes. There was no prolonged hypoglycemia that you will have to treat it for a longer duration of time because the drug has been injected for 7 days. So how do you initiate? These are all patients who were not on insulin, the onwards 1, 3, 5 trials. You always start with 70 units of icodec once weekly, and then you can up titrate or down titrate according to the fasting glucose levels over the previous 3 days. Like we do for a long acting insulin, we always look at the fasting glucose levels. If the fasting glucose levels are high, add 20 units. If the fasting glucose levels are low, minus 20 units from that 70 or whichever dose you finally arrived at. So this is for a person who is not on insulin. You've initiated insulin, and the insulin of choice in this case is icodec once weekly insulin. Now this is the other set of trials, onwards 10, onwards 2 and onwards 4, where the person was already on insulin. It could be a basal bolus regime, it could be just long-acting insulin, but the insulin in that case was either glargine or degludec. You switched from that long-acting insulin to once weekly insulin. So how do we do that? The design was primarily similar. In this case, we had 26 weeks of trial duration, and it was seen again that there were no significant episodes of hypoglycemia when switched from another comparator insulin. And the efficacy was also found to be good. The results of the SMBG, the results of the CGM, and the results of the HbA1c again proved that icodec is non-inferior to other long-acting insulins. How do we do it in this case? Supposing your patient is on 20 units of long-acting insulin glargine, along with a combination of OHs or maybe 3 shots of insulin, short-acting insulin in the day, multiply that by 7, whatever the value. If it's 10, then it's 70. If it's 20, then it's 140. And that whole injection of 140 units is to be injected once weekly, and specifically mention that day of the week on your prescription so that there is no confusion about 1 weekly. And then the patient takes the injection again the same day of the week. Like today, if I see the patient, I inject 140 units of insulin instead of 20 units of glargine subcutaneously. The patient takes the next 140 units coming Sunday. So that is how the patient does, and the glargine goes off the prescription. The other drugs, the short-acting insulins, the OHAs, the GLPs, the combinations have to be titrated according to the response. The doses may reduce, the doses may remain the same, but primarily we are targeting glargine only. It is not a substitute for the short-acting insulin. It is not a substitute for any other OHA or GLP. So if your patient wants his only basugin to be replaced by a long-acting weekly insulin, this is a choice. So actually, we've come across many patients over the last few weeks who are only on glargine plus OHA. They are very happy with this. For the basal bolus patients who are already taking 4 shots of insulin per day, 3 short-acting and 1 long-acting, it's not very exciting for them because they will continue to have those 3 shots of regular insulin. In fact, it was my mom. I asked my mom whether she wants this. My mom takes 4 injections daily, 3 times short-acting insulin and glargine at night. She was very happy learning about this from social media and all. When she asked me about it, in fact. I said, yes, it's available. We can do it for you. Then she was very happy again. But then when I told her that it will replace only her Lantus at night, she frowned and went away. She did not even ask me again about this because it hardly helps her. She is continuing to take those 3 shots of insulin in the daytime. So maybe if they want, you can replace the long-acting. But the best target audience, the best clientele will be who are not on insulin and you are planning a long-acting insulin, and who are only on long-acting insulin. They are the best clientele for this formulation. So to summarize, it reduces your number of injections, 4 injections per month, better HbA1c, better TIR, more patients at target, lower rates of hypoglycemia, and the hypoglycemia rates are not higher compared to the comparator. So this is what we have, the latest thing in endodiabetes for us, icodec, available as the brand name that you all might be knowing. And I've used the pen personally. It has got 20 markings. It is 0, 20, 40, 60. That is how you titrate the dose. And in between 0 and 20, 20 and 40, there is also a mark. So the dose titration has to be 10 or multiples of 10 only. You cannot make it 65 or 75. It has to be 0, 10, 20, 40 in multiples of 10 thereafter. And this pen contains 700 units. So, and another interesting thing, when I calculated the cost of therapy for the patient taking glargine, now moving to icodec, thankfully the cost is not high. It is hardly a few rupees more per shot of injection or a monthly dose of treatment compared to the standard glargine that we use. The cost of therapy is also affordable for all those patients who are already on glargine. Thank you very much for your patient hearing.
Any question from the audience?
Yes, there is.
Sir, regarding the first loading dose, there have been discussions about the initial dose should be 1.5 into total requirement, basal requirement of the
that was an initial discussion. Yes, in fact, the innovators had also come up with a similar proposal. Yes, currently, that is not being considered any longer. We are not giving any loading dose of 1.5 times. We are either giving 70 units for a new patient or X into 20 units for those who are already on long acting. No loading dose concept currently.
Thank you, sir.
Any other question?
Sir, after giving the first dose, when to check the fasting?
You can check it every day.
Every
Generally you start checking. In fact, I did it with one of my patients. With the first patient that I prescribed, I was a little anxious about how it will do because she was kind of an elderly lady. In fact, I calculated the dose to be 140, 20 into 7. I got myself a little conservative. I prescribed her 120 units. I prescribed her at night, injected the first dose right in my clinic, asked her to go home and come back to me after 7 days with 7 readings of fasting glucose starting next day morning. And I can share with you that this is perhaps the only experience currently with data that I have generated over the last 7 days. The fasting glucose levels were very impressive.
From the very first day?
Yes, they were very impressive. All the fasting glucose levels were hovering around 80 to 95.
Thank you, sir.
Sir, thanks for the wonderful talk. Sir, my question, sir.
Yeah, please.
Sir, my question is, the patient, suppose he's on icodec as well as some other OHs. Now, this patient is admitted in the hospital with a level 3 hypoglycemia. So now what to do?
If the patient is on icodec and has been admitted with a level 3 hypoglycemia, that could have happened also with glargine. But we expect our long-acting insulins not to cause severe hypoglycemia unless the patient is on a combination of OHs like a sulfonylurea or on short-acting insulins like that. If the patient has taken the icodec, is scheduled for the next injection, has got admitted in between, manage the case like a usual case of hypoglycemia and do not fear that once you handle this hypoglycemia, there will be a rebound hypoglycemia after 2 hours, after 24 hours. Just manage it as a case of hypoglycemia that has happened. And perhaps icodec is not to be blamed for it.
Thank you. Thank you, sir. Sir, is there any recommendation for type 1 diabetes?
It's for adults only. So for adults with type 1 diabetes may also be given the advantage of this. But again, the question is that they are already taking 4 injections daily. How much are they interested in is a question. It's not for children.
Thank you, sir.
So I think there is no more question.
Time in range was wonderful.
In some condition where there is severe albumin deficiency, what is your take on those
yes,
conditions?
that's an interesting question. Like patients with CLD who might have hypoalbuminemia because it binds to albumin primarily. In patients with CLD and CKD, like you're talking about hypoalbuminemia, someone who has maybe decompensated liver disease, in them obviously this can be a problem and should be used with caution, because already those patients are more prone to hypoglycemia because of their end organ damages. And the TIR which I showed, it's more than 70% in the onwards group of trials, and it's quite impressive, as good as with glargine only.
So with this we will come to the end of this session. Thank you very much, sir, for such a nice presentation and elevating everybody with a good knowledge.
Thank you, Dr. Pankaj, for the clear-cut presentation and clear take-home messages. So the next talk is a important topic, that is fracture assessment, risk assessment tools in diabetes mellitus. And I'll invite the chairperson for this session, Dr. Piyush Ranjan Nayak, who is a consultant physician at Health World Hospitals, to take over as the chairperson and to introduce the next speaker.
Good afternoon, everyone. So, in today's topic in BDCON, so we have a lot of things to discuss regarding diabetes, its treatment, protocol, what are the new medications. But many a times we forget that bone aging and bone risk is also a very important factor while we are treating diabetes, because many a times we go by the treatment whereas we miss the bone health. So a very important topic, and there are a lot of risk factors, lot of calculators, lot of calculation that we should do in patients who are having diabetes and with a risk of bone fracture. So may I introduce a speaker. He is an eminent speaker. He doesn't need any introduction, Dr. Soumik Dutta. He is an eminent endocrinologist, associate professor, Department of Internal Medicine, Calcutta National Medical College, Kolkata. So may I request sir to come over to the stage. Yeah. May I have an applause for Dr. Soumik Dutta.
Thank you, Dr. Nayak, Chair, along with Dr. Jadhav. So, my dear colleagues and boys and girls, I hope all of you will agree with me that osteoporosis and osteoporosis-related fractures is a major public health-related issue today across the globe because of increased proportion of senior citizens in our society. And in the same breath, we can agree that diabetes is associated with increased risk of fracture. And it may be due to bone intrinsic factors, it may be due to bone extrinsic factors. Bone intrinsic factors like collection of AGE inside the bone because of poor bone turnover and also the loss of microarchitecture of the bone because of poor microcirculation. Apart from these all bone intrinsic factors, there are also so many bone extrinsic factors, particularly related to diabetes, like poor vision, because of neuropathy, both peripheral as well as autonomic neuropathy. It may be due to sarcopenia, may be due to hypoglycemia, as already discussed, may be due to some effects of drug on the bone metabolism. So, these are the factors which can complicate the life of a diabetic person with osteoporosis-related fractures. But as Dr. Nayak had already told us, that bone health assessment in the context of diabetes is frequently forgotten by us. We always remember these two lines. Osteoporosis means low BMD. But let's try together to complete this sentence. Osteoporosis is defined as a systemic skeletal disease characterized by low bone mass along with microarchitectural deterioration of bone tissue. So, these three lines make the sentence complete. Let's go through few evidences. The fracture risk of type 1 diabetes is 3 times as high as that in the general population, and it occurs 10 to 15 years earlier than that in non-diabetic individuals. So alarming. At the same time, if we go through this popular study done in the South Korea, we can see that more than 6 million people participated in this study, and out of that population, more than 2,000 was suffering from type 1 diabetes, and almost 5 lakh people, they are living with type 2 diabetes. And they have found the fracture risk was higher in patients with diabetes than in non-diabetic individuals for all measurement sites. So, if we are not borrowing much further evidence from the bone literature, we can assume that identification of the people living with diabetes combined with increased fracture risk is very essential, very much crucial for proper diabetes care. So, if we move further, we have to think of how we can address this issue. Definitely, assessment of BMD had been considered as a gold standard for the decades, and DEXA can help us in this direction. As you know, DEXA is a very simple method. In a convenient way, it can assess bone mineral density, though it may be aerial bone mineral density. Definitely, it can identify the people with osteoporosis. It can help to identify the people having high risk of fracture and the people who are on treatment. It can also tell us how much responding they are. Yes, we are familiar with the disadvantage of DEXA also, because it can be influenced by the aortic calcification, it can be influenced by lumbar degeneration. And we should never forget this statement, and that should be kept in mind for the next part of discussion. Contribution of bone mineral density to bone strength is approximately 70%. So, other major players are there who can influence the 30% of bone strength. This group had found that lower bone mineral density in patients with type 1 diabetes compared with controls without diabetes, and fragility factor risk in type 1 diabetes, just note it, fragility factor risk in type 1 diabetes is much higher than value at risk predicted by DEXA. If we think of type 2 diabetes, we are having another evidence. Type 2 diabetes had higher BMD than control. Surprisingly, type 2 diabetes had higher BMD than control, and it is thought that it may be due to obesity associated with type 2 diabetes. As you do know that obesity can help to reach peak bone mass at higher level. It may also be due to higher insulin level associated with insulin resistance. Higher insulin level is having some protective effect on bone loss. So, we can understand that although BMD is an important tool for assessing bone mass, the assessment of fracture risk in patients with diabetes remains controversial, particularly in the context of type 2 diabetes. So, what can we do? Let us see how facts can be helpful in this context. So, if we go through the evidence, we can have some assumption, we can have some idea that prediction ability for fracture, prediction ability of fracture in diabetes by facts was lower than that of the non-diabetic population. It may be due to several factors, but when we are calculating facts, we are considering the age, we are considering the gender, we are asking whether you are smoking, whether he is taking alcohol, whether he is on steroid. We are asking the fracture history of that person concerned, or fracture history of the parents. We are also thinking of rheumatoid arthritis, but FRAX is not considering type 2 diabetes when taking all these matters for calculation. So, it may be one factor that FRAX is underperforming while calculating that predictability of fracture. Now, this fellow and his friends had found a funny observation. They have found that type 2 diabetes had an increase in the mean risk of severe osteoporotic fracture when using the facts without BMD for scoring in postmenopausal women. So they have omitted BMD when they are calculating facts in the group of postmenopausal women, and that had produced some ground reality. However, this is not applicable for middle-aged women. So based on this knowledge, other clever groups, they had tried to find out some way to adjust facts. And here I am having one summary of those observations. One group has replaced rheumatoid arthritis for diabetes. Another group had added 10 years to the age while calculating facts, and another clever group, they have subtracted 0.5 from the t-value. And it had been found that each of these policies had produced some better performance while calculating facts and trying to predict the fracture risk. Coming to the trabecular bone score. So what is trabecular bone score? We do know that it does not need any other equipment. It does not need further exposure to radiation. It can be calculated by using one software, and that software will just assess the pixel grayscale of the image produced by the DEXA scan. So the area of interest is confined within the area which is being assessed by the DEXA scan. Now this TBS method can produce one score, and if that score is more than 1.35, we can understand that it is normal. The trabecular bones are lying very closer to each other, and the gap between the trabecular bones are very small. Bones are strong and tough, but if it is in between 1.2 to 1.35, we can understand that the gap has become larger, bone is deteriorating, and when it is less than 1.2, bone microstructure degenerates seriously. So this meta-analysis had included almost 40,000 people, including both type 1 and type 2, and they had found that diabetes had a significantly lower TBS than those without diabetes, and you can see the calculation and the numbers. So advantage of trabecular bone score, if we are going to summary, we can see that it is more helpful in assessing the fracture risk in patients with diabetes, particularly in the context of type 2 diabetes. It can identify the fracture risk in patients with diabetes having normal or increased bone mineral density. It can be used as a supplementary tool for BMD assessment. So coming to QCT, let's check its performance. QCT is another non-invasive tool to assess bone mineral density, but it can produce volumetric bone mineral density. The beauty of the QCT is that it can distinguish between cancellous and cortical bone separately. And to be noted, it is not going to be influenced by aortic calcification as well as by lumbar degeneration. So QCT is another important tool which can help us to assess bone health. As you do know that the metabolic activity of the cancellous bone is 8 times higher that of cortical bone, so that age-related or treatment-related change in bone mineral density measured by QCT are more sensitive than the changes in BMD picked up by DEXA scan. So it is the advantage of QCT over DEXA. Coming to high resolution peripheral QCT, it can image and quantify the volumetric bone mineral density as in case of QCT, and it can also tell us about bone microarchitecture, including cortical porosity at a low radiation dose. Now this HRP QCT, the target is distal radius and distal tibia. I can cite two evidence from the literature. This study was done based on distal tibia, and they have found that type 1 diabetes had the lower cortical thickness and lower cortical bone volumetric BMD at the ultra distal tibia. It may be due to associated peripheral neuropathy, they had commented. If we focus on distal radius, this group had found that non-weight bearing distal radius was more preferable site than the distal tibia for fracture prediction. If we move further, we can focus on micro indentation. I have talked about trabecular bone scoring. TBS is measuring bone microstructure in indirect way. On the other hand, this micro indentation process can assess bone structure in direct way, and we are having two devices. Clinically, this osteoprobe device is more applicable. It can assess this micro indentation in a direct way. We have to place the device over the mid shaft of the tibia in an aseptic way, and the device, after holding it just in a perpendicular way over the bone shaft, we have to apply 10 Newton and subsequently 40 Newton of force, and after applying that force, the device will produce some indentation over the cortex of the bone. We have to find out that indentation and the increment of indentation, and that indentation will have to be compared with the indentation produced by the same magnitude of force over a plastic, and that ratio will produce this BMW BMSI. BMSI means bone mineral structural index. If this BMSI is on the higher side, it is good for the bone health. Now, this cross-sectional study on men had found that BMSI was lower in patients with type 1 diabetes compared with healthy age-matched women. So, BMD of patients, and another study had found that BMD of patients with type 2 diabetes was higher, but the BMSI was lower than that of control, and that can explain why type 2 diabetes patient having fracture despite having higher BMD. So, reduced BMSI and impaired physical function might explain the increased fracture risk in type 2 diabetes. Bone turnover markers, actually they are being produced during bone modeling and remodeling. Bone turnover markers, however, are lower in the quantity in the context of diabetes. They are the different bone turnover markers which are reflecting the bone formation as well as bone resorption process, but from different study, this is the final observation that whether BTMs can predict fracture risk in patient with diabetes is still controversial. Any single bone turnover biomarker cannot indicate the fracture risk in patient with diabetes. So, ladies and gentlemen, boys and girls, here if we conclude, we can have this take home message that diabetes means increased risk of fragility fracture. DEXA may misguide us, particularly in the context of type 2 diabetes. Fracture adjustment may be helpful in some society or in some community. However, we are not sure about that, and definitely TBS, QCT and IMI had opened a new avenue. Thank you.
Thank you, sir. That was excellent from your side. So is there any question? Then you can take few questions if there is any question. So sir, one question from me. So is there any guidelines or cutoff or any age criteria to access in a diabetic patient? Because there are a lot of age in which we find diabetes, even in young and adults. So is there any guideline that we will do the bone assessment at particular this age or at particular HbA1c?
Now, if we think of DEXA, so there is conventional guidance for DEXA. If the lady beyond 65, so it is universal to go for DEXA screening for the bone BMD. But if they are having diabetes or other comorbidity, you can lower the age limit to 60. In case of male, it is 70. If he is having diabetes or other risk factor one or two, we can definitely reduce the age limit. And regarding TBS, if you are going for DEXA, then only we can have TBS scoring, otherwise it is not possible.
Thank you. Any more questions? Thank you, sir. Sir, applause for sir. Thank you, sir. Thank you.
Thank you, sir, for this insightful session. I would like to call all the chairpersons and speakers of this session to come on the stage. Please come on the stage for the group photograph. Now I request everyone to go to the side stage for the felicitation. We now move ahead to our industry symposium, where we explore the latest developments and practical insights in the field of diabetes care. Industry collaboration continue to play an important role in bringing innovation and near therapeutic approaches closer to the clinical practices. To chair this scientific session, may I respectfully invite our esteemed chairpersons, Dr. Ardhendu Shahana sir, Dr. Rajesh Majhi sir and Dr. Saushthinarayan Chakraborty sir to kindly grace the dais and take over the proceedings.
Good afternoon. I would like to request Dr. Akash Panigrahi for his next talk on pancreatic steatosis and PI, the clinical relevance. I would like to call Dr. Akash Panigrahi sir.
Yeah, very good afternoon. My talk was actually in gastroendo series, so it's not part of the industry symposium. So today we'll be discussing pancreatic steatosis and briefly on pancreatic exocrine insufficiency. I am Dr. Akash Panigrahi from Jamshedpur. And thank you team BDCON for the invitation, especially Dr. Rajan Palvi. So this will be the brief outline of my talk. We'll be seeing how to define this condition, pancreatic steatosis, the epidemiology in diabetes, the pathophysiology. We'll see how to image it and how to diagnose it. Few points on reversibility, which Dr. Jayaditya Ghosh has discussed very elaborately. And then I will end with some words on pancreatic exocrine insufficiency and pancreatic cancer. So coming to the topic of pancreatic steatosis, it is simply put fatty pancreas disease, that is diffuse excessive intrapancreatic fat deposition with metabolic consequences. Although there are many suggested names like non-alcoholic fatty pancreas disease, fatty pancreas, almost all the words are used interchangeably. And briefly, there are two mechanisms. Fatty infiltration, that is adipocyte accumulation within the pancreatic parenchyma, which is mostly metabolically relevant, and the other one is fatty replacement, that is the acinar loss. And there is no agreed diagnostic threshold as of now, therefore the reported prevalence that I would be discussing varies widely. So if you see the intrapancreatic fat deposition is measurable fat within the pancreatic tissue and low levels is often physiological. The fatty pancreas disorder happen when there is excessive intrapancreatic fat deposition that poses various health risks. Exocrine pancreatic dysfunction, this means reduced secretion or a abnormal test without proven maldigestion. And when we talk about exocrine pancreatic insufficiency, this is a maldigestive syndrome because the enzyme activity is low, so there is problem in the nutrient digestion and lot of symptoms. The fat deposition can be interlobular or intralobular, it can be intracellular also, or it can be fatty replacement also. Coming to the unifying hypothesis of Pandora, it means pancreatic diseases originating from intrapancreatic fat. It suggests the intrapancreatic fat sits upstream of both the exocrine and endocrine pancreatic diseases. That is, the intrapancreatic fat is causing both the problem in exocrine and endocrine segment. It's the single driver. It is associated with acute and chronic pancreatitis, pancreatic cancer, metabolic syndrome and type 2 diabetes. The evidence base is growing very rapidly. So the fatty pancreas has shifted from an incidental radiological finding to now a modifiable and measurable factor. Although it's very common, but it's under recognized. If you see the global pooled prevalence, the prevalence is around 21%. That is 1 in 5 patient in general population will have a fatty pancreas. And it varies by different imaging modality. On MRI scans, it's around 18%. On CT scan, it's around 30%. On ultrasound, it's 21%. Now, the criteria on how to categorize the disease as fatty pancreas is something debatable. That's why the prevalence varies. And who all are affected? The older age individual, higher BMI, male preponderance, and metabolic dysfunction are the people who are affected. And fatty pancreas concentrates in type 2 diabetes. Whereas in general population, the prevalence is 1 in 5. In diabetic patient is 54%. That is 1 in 2 is harboring a fatty pancreas disease. It's already detectable in a newly diagnosed type 2 diabetes, and it tracks with poorer beta cell function. Greater the pancreatic fat correlated with worse glycemic indices and faster glycemic progression. And the ectopic fat impairs insulin secretion and chronic glycemia. It's a two-way street. The ectopic fat is causing the decreasing the insulin secretion, and the chronic hyperglycemia and hyperinsulinemia on the other hand is promoting further fat deposition. This is something Dr. Jayaditya has already discussed, that all of us, we have our own personal fat threshold. So a large and obese body will have a larger fat storage capacity, whereas a small and normal weight body will have a less safe personal fat storage capacity. And when this personal fat threshold is overshooted, then there will be relative overflow and metabolic problems will happen. So a person will develop diabetes when they become too heavy for their own body. So overnutrition will come first. The chronic calorie excess will increase the basal insulin secretion and increase lipogenesis, and energy will be converted into fat. When the safe subcutaneous spaces are filled up, the fat will spills into liver, pancreas, and muscle and other ectopic organs, and will cause all kind of metabolic problems. The famous twin cycle hypothesis by Dr. Taylor, it suggests there are two cycles running in our body, the liver cycle and the pancreatic cycle. The energy excess is the driver. It will leads to muscle insulin resistance that will cause liver fat accumulation. The insulin resistance will increase and the basal insulin secretion will increase. The liver will export VLDL triglyceride to downstream to pancreas to increase islet triglycerides level, and that will cause pancreatic problems. So the first cycle is chronic calorie excess, that is causing liver fat accumulation and hepatic insulin resistance, and this will increase our basal insulin production, and hepatic glucose output will also increase. So liver is the first organ to fail under the scenario of chronic calorie excess, and there will be overflow when our personal fat thresholds are exceeded. VLDL and triglyceride will go downstream into pancreas to cause pancreatic fat deposition. So ectopic fat deposition in the pancreas, which is called lipotoxicity, and pancreas is not an organ which is designed to store extra amount of fat. So the lipotoxicity will cause beta cell to some damage. So it's the one ectopic fat which many problems. It is associated with central adiposity, dyslipidemia, hypertension, insulin resistance. So if you see, there is a unifying concept, this ectopic fat across liver, pancreas, muscle, this can be best understood as a single systemic disorder of fat handling and management. What interesting is under this lipotoxic stress, the intrapancreatic adipocyte expose the islets to the fatty acids, and there is inflammation, and that impairs the insulin secretion. The beta cells, rather than dying, are largely de-differentiated. And this is important because they are recoverable. If there is a sustained weight loss that is causing decrease in pancreatic steatosis, the beta cell can revert back to their original position. So this forms the basis of different remission programs that we have already discussed. Till now, the main problem was with measuring the fat in a pancreatic tissue. So pancreatic fat was still a incidental finding reported by some radiologists. We were not intentionally measuring them. So the threshold for defining the pathological pancreatic fat remains unstandardized till today across different guidelines, although we have 4 modalities: the transabdominal ultrasound, endoscopic ultrasound, CT and MRI. The second problem was the fat distribution was patchy. So the fat was deposited unevenly over head, body and tail. So where you sample becomes what you measure. So these 2 problems were there. So if you see MRI, that too with proton density fat fraction, MRI PDFF is the modality of choice as of now. It is quantitative, non-invasive, and the results are reproducible. And when we image the whole gland in a 3D imaging, that also solves the problem for the patchy distribution. And because it is a redistribution, now we have a marker that we can measure and follow up to track our response to therapy. There are different PDFF criteria that is being used. So the mild pancreatic steatosis is defined as PDFF between 6 to 15%, moderate is 16 to 30%, and severe is more than 30%. Other MRI imaging modalities like MRSA or chemical shifting imaging can also be used, but they have their own limitations. If you compare the imaging modalities, we have discussed ultrasound, although very widely available, it is operator dependent, and we cannot rely upon it for quantification of pancreatic steatosis very reliably. CT, there is radiation exposure, and it tends to overestimate. Or under endoscopic ultrasound, we know it's an invasive procedure. So MRI PDFF is the present standard for measuring and following pancreatic fat. Now over last 1 decade, what we have understood that pancreatic fat is reversible. The pancreatic fat is dynamic and it can be reversible, and beta cells can re-differentiate from the de-differentiated state. And we just need to put the twin cycle in a reverse. We need to unload the liver with a very low calorie diet for a sustained period. Liver fat will deplete. That will decrease the insulin resistance within the liver, and the hepatic glucose output will fall. When the liver is defatted, the fat spillover to pancreas will decrease, and that will defat the pancreas. And if both the cycles can be broken off for a pretty long time, then diabetes remission is possible. This is very elaborately discussed by Dr. Jayaditya in early morning session today. So the direct trial he has discussed here, with a low calorie diet replacement, the remission rates were around 46% at 1 year and 36% at 2 years. What was interesting that even at 5 years, the remission rate was 13%, and those who maintained the remission, they have maintained a weight loss of around 9 kg. So a sustained significant weight loss of around 10 to 15 kg is something that we are seeing it. Now even with metabolic surgery, they reduce pancreatic fat by around 36%, 3.9% absolute reduction. The glands become smaller and leaner post-surgery. And there is some suggestion that sleeve gastrectomy may be a better procedure for pancreatic fat reduction than Roux-en-Y, although a larger data is needed to confirm it. We know GLP-1 and the GLP-GIP co-agonist with their powerful sustained weight loss capacity, they are expected to reduce the pancreatic fat further. But till now we don't have dedicated pancreatic fat endpoints in different studies to confirm their direct pancreatic defatting effects. So coming to the second part of the presentation, this fatty pancreas also starves the exocrine gland. They shared the same lipotoxic injuries. The same ectopic fat milieu will harm the islets, also harm the acinar cells, and there is fatty replacement of the acinar tissues that decrease the enzyme secreting mass, and the enzyme secretion declines. The same Pandora hypothesis explains the exocrine dysfunction also, and we know there is a endocrine and exocrine crosstalk, that is the loss of insulin and pancreatic polypeptide signaling further blunts the acinar stimulation and further aggravates the exocrine insufficiency. And coming to the clinical relevance, the exocrine insufficiency is often silent. It may be symptomatic when in overt diseases, when the patient will have symptoms like bloating, steatorrhea, weight loss. There will be maldigestion and malnutrition. Deficiency of fat-soluble vitamins like A, D, E, K will be there, and bone and muscle health will be affected. Around 30% in type 1 diabetes and around 29% in type 2 diabetes patient will have low elastage. So the low fecal elastage is a common entity, but when we look at true exocrine pancreatic insufficiency, it is not that high, because we need maldigestion and nutritional parameters also to diagnose it. So when do we suspect exocrine pancreatic insufficiency in a diabetic patient? If diabetes and malnutrition plus GI symptoms travel together, then we should suspect it. So the digestive clues will be steatorrhea, that is greasy and difficult to flush stools, chronic diarrhea, frequent stool, bloating, gas, postprandial discomfort. The nutritional clues will be unintentional weight loss, low albumin, micronutrient deficiency, fat-soluble vitamin deficiency. And looking at the diabetes clue, if it's a long duration of diabetes, brittle diabetes, there are other suggestion of autonomic neuropathy, or if the history is suggestive of some pancreatic pathology like pancreatitis or pancreatic surgery, then we should be more aware and to look for this entity. So only in patient with diabetes who have symptoms of nutritional deficiency, we should ideally search for exocrine pancreatic insufficiency. And fecal elastage is our go-to test, although it's a probability test, not a binary diagnosis. If the levels are less than 100 microgram per gram, then it makes the more stronger case for a marked exocrine deficiency. Between 100 to 200 is an intermediate zone, and more than 200 the EPI is less likely. And we should know that we should test on a formed or semi-solid stool. Watery stool will show falsely low levels, and we should repeat the borderline or intermediate levels, and we should interpret in the background of symptoms and nutrition. And before calling it diabetic EPI, we should exclude the mimickers like diarrhea after treatment. If there is a recent initiation of metformin, GLP, acarbose or orlistat, then that can cause some GI problems. We will find low fecal elastage in a watery stool. Again, enteropathy like celiac or other diseases can present similarly, so we should search for that and take help of our gastro colleagues if needed. And EPI with atypical diabetes, we should suspect chronic pancreatitis, cancer, like that. We know pancreatogenic diabetes, around 5 to 10% of our patients which we are treating a type 2 diabetes will be pancreatogenic diabetes, so we should keep that in mind. And if you see a diabetic specific diagnostic pathway, if the patient has persistent GI symptoms, weight loss and nutritional deficiency, we should review the medication first, nutrition and a formed stool fecal elastage 1. If the levels are less than 100, then there is high probability. We should then proceed to find the cause, a pancreatic imaging or evaluation for other GI pathologies, and we should treat it when found. For treating, pancreatic enzyme replacement is our go-to therapy, and 40 to 50,000 of lipase units with each meal is something that we should target, and it should be taken with food. and we should avoid routine fat restriction and a very high fiber diet. We should track the patient's weight gain, the GI symptoms and the dietary intake, and we should try to replace the fat soluble vitamins and other micronutrients. Also trying to assess the bone health and muscle health if needed. The pod therapy improves digestion, that is something we know. The glycemic benefits is inconsistent, and because of improvement in fat digestion, the GLP and GIP release will be better. So it will enhance our incretin response and blunt the post-meal glucose spike. And there is a modest HbA1c gain. The largest gain is seen in those with severe deficiency. And on continuous glucose monitoring studies, the pod therapy has been shown to decrease the glycemic variability. So it should be a targeted, not a universal one, because the clearest glycemic benefits is there in those with severe exocrine deficiencies. So we should screen with elastase, replace the enzyme where needed, and also restore the nutrition of the patient and treat the whole gland as a whole. Coming to the cancer connection, the fatty pancreas and new onset diabetes are emerging as early signal for pancreatic risk. So the fat feeds oncogenesis. This is something we know, and this is also explained under the Pandora hypothesis, that the excess intrapancreatic fat is causally linked to both acute and chronic pancreatitis and also pancreatic ductal adenocarcinoma. The diabetes can come first. Now this is something important because new onset diabetes after age 50 can be an early paraneoplastic marker of occult pancreatic cancer, and the diagnosis preceded by months. A median of 8 months is something that we are seeing it. So that provides us a narrow but doable window for surveillance. And if you see the numbers, about 1% of patients, so 1 patient out of 100 with a new onset diabetes after 50 will be diagnosed with pancreatic cancer within next 3 years. That's a 6 to 8% higher risk in the general population, and around 1/5 of pancreatic cancers are preceded by a new onset diabetes. So we should actively search for these patients, particularly if the patient is lean, thin, unexplained anemia, pain abdomen, then that should be the red flag for us. So the clinical takeaways: pancreatic steatosis is extremely common. We should recognize it as a modifiable metabolic disorder, not an incidental finding. We now have a modality to measure it with MRI-PDFF. Sustained weight loss, be it with diet, surgery or incretin therapy, will be our go-to, and we should watch for the red flags like looking for pancreatic diabetes, be conscious of a pancreatic cancer, not to miss those points. So with this I thank you. These are my acknowledgements. Thank you.
Thank you, Dr. Akash Panigrahi, for this excellent talk. And if you have any queries from an audience,
very often in USG reports we see that a lot of asymptomatic patients are having fat infiltration of pancreas. So what is your opinion if the patient is having no symptoms and only USG finding says that he has fat infiltration in pancreas, should he undergo MRI abdomen?
So that will depend upon why was that ultrasound done. So suppose we are suspecting or if it's a obesity case, or suppose we are suspecting, then obviously if you try to quantify fat, then we need a MRI-PDFF actually. So be it liver fat or pancreatic fat, organ fat estimation, MRI-PDFF is our best and most reliable diagnostic modality as of now. So if you want to quantify, we should go for a MRI.
No, I am asking that is it mandatory?
No, sir, it's not mandatory.
Thank you, sir.
okay, thank you. We are moving to the next session. We will discuss after, in lunch session because of the time constraint.
Yeah. Thank you, Chairperson.
Good afternoon. In recent years, semaglutide has generated tremendous excitement. So today's session, beyond the hype, why innovator semaglutide's proven legacy sets the gold standard in obesity management, is both timely and highly relevant. So we are fortunate to have Dr. Sumit Chakravarti, who is an eminent endocrinologist who will share valuable insights into the evidence supporting innovator semaglutide and its role in modern obesity management. Thank you.
Thank you, Chairperson Sir, and thank you, Amitabh and other organizers of BDCON for inviting me here. We are going to discuss why innovator semaglutide's proven legacy sets a gold standard in obesity management. We are all aware that the burden of obesity is tremendous and there is a perceptible gap in the need of pharmacotherapy. Why? We all know this is a complex, chronic, progressive disease characterized by abnormal deposition or excessive fat in our body. And the staggering figures worldwide, about 1 billion people are affected by obesity, and not only that, look at the value for children. About 70 million children are affected with obesity. And the greatest number of people are in the low or middle income countries where it increases the burden of obesity for treatment. Our Indian picture is also not bright. We have around 254 million people, adults living with obesity, and 26 million children are there with obesity. Significant issue. Now, how do we manage? We all know, to begin with, there is MNT, that is medical nutrition therapy, diet restrictions, etc., along with physical activity, and in some situations we can advise for psychological interventions, particularly for those who are of the habit of having binge eating, who cannot control their appetite. But with this medical nutrition therapy, diet restriction, exercise, we can hardly achieve a weight loss of maybe up to 5%. Previously, we would say 5 to 8% weight loss is what you can really like to achieve with these diet restrictions or measurements. But that is not enough. And on the extreme other end, what do we have? We have procedures like endoscopic procedures, the sleeve gastrectomy, Roux-en-Y, etc. And last but not the least is bariatric surgery, where we really can achieve up to 25 to 35% of weight loss. So is not there anything in between beyond your medical nutrition therapy and only we can land with these gastric surgery things? No. Of course there are things in number of people we can offer them the pharmacotherapy. So here is the role of semaglutide or the innovator semaglutide, that is Wegovy, that has transformed our care for weight loss. Wegovy is basically, we know, that is a GLP-1 receptor agonist, and that has got 94% homology to human GLP-1 with a half-life of approximately 1 week. And what does it do? It enhances your satiety center and your hedonic center for eating. So direct activation of the satiety center in the ventromedial hypothalamus and the hedonic center in the nucleus accumbens and other part of the limbic system is one of the very robust mechanism of the action of reducing your eating habits in this semaglutide. Hemostatic regulation occurs when our satiety is increased, making your patients feel less hungry. Along with, there is hedonic regulation that reduces our food cravings and preferences for certain foods. Fine. So what are the evidences that we have with this molecule? There are n number of trials. The trials are all called STEP. That is semaglutide treatment effect in people with obesity, STEP trial. Step 1, when weight management only in normal persons. Step 2, that is weight management in people with diabetes. Step 3, Step 4, Step 5, the longer version of steps. I am not just enumerating all these steps, but few important things. We have step teens, that is when the semaglutide is used in adolescent and young people, and we can observe the good effect. Not only then, we can quote the SELECT trial, that is the dedicated CV outcome trial of semaglutide, then trials of STEP with HEPF essence, particularly when we are dealing with MASH. So number of trials are there to support our confidence that you can use the Wegovy molecule in these situations. Over 30 million people have been prescribed. What is the primary endpoint? The primary endpoint for all these STEP trials is weight loss. We know how to initiate semaglutide, how to increase the dose, and gradually we can reach the peak dose, and the trials were of the duration of 68 weeks, that is over a year. And not only that, some of the longer duration trials were of 104 weeks, almost 2 years plus. So what was observation? If we consider more than 20% weight loss is our goal, then in all the STEP trials, you can see that around 34%, 38%, 40%, 40.6%, all these percentage of people have actually reached this target of achieving your 20% weight loss. Not only that, if you look at the STEP 8, that is a head-to-head trial with liraglutide 3 mg daily. And the observation was the 20% mark was observed in more than 40% subjects with semaglutide as compared to that of 6.5% with liraglutide. So huge benefit can be obtained. Now this is what? This is STEP teens. STEP teen means to treat the young adults or adolescent obesity. And here also we can see that 20% mark of weight loss can be achieved in around 1 out of 3 adolescents on Wegovy. So if you consider 5% weight loss, almost 72%, every 3 out of 4 patients can achieve. If you increase your target to 10%, about 60% patients can achieve. If you increase to 15%, at least 1 out of 2 can achieve this target. And if you raise your target to more than 20%, about 1 out of every 3% can achieve this target, even in younger ages. So STEP teen trials is there for weight management in adolescents who are more than 12 years of age or have a body weight of 60 kg. And this is also approved in our country. The CDSCO approval has been achieved in just a couple of months back in the month of May 2026. So this is the significant benefit of Wegovy that we can discuss. So more than 20% weight loss is not a dream, not a hypothetical issue, it is achievable. And weight loss starts as early as after 4 weeks of therapy, and we can have a sustained weight loss. We have trial data for over 4 years. So this is the benefit of Wegovy. If you consider 5%, almost all of your patients can achieve this. If it is a 10%, 3 out of 4. If it is a 15%, 1 out of 2. And if it is a 20%, 1 out of 3 patients can achieve. But not everything is good. There are something we have to consider. Now, if this weight loss, what is actually we are losing? Out of 100 kg body weight loss, if we consider, 75% is because of fat, and the rest 20% is because of your lean muscle mass. So this is the thing you have to consider. And whenever you are writing something like this, we have to consider how frail is the individual, how sarcopenic is the individual, because this is a real issue of 25% lean muscle mass can also be lost. We have to keep that in mind. And if we just have a comparison between the 2 strongest contender in this respect, that is Sema versus Tirze, though study shows maybe Tirze is little more muscle mass loss is there. Statistically may not be significant, but at least numerically little bit significance is there. Now what about the CV outcome trials? Yes, the Wegovy has a dedicated cardiovascular outcome trial known as SELECT. And the patients were of more than 27 BMI with established cardiovascular disease but without diabetes. So what is there? The primary endpoint was 4-point MACE, and there is a significant reduction in the MACE points, and that starts very early. Just look at the graph. Even after 6 months, the hazard ratio becomes 0.59, and the improvement continues. So separation of MACE curve was very early, and 80% of the risk reduction is mediated by factors believed to be other than body weight loss. So there is other issues like reduction of metabolic health, metabolic inflammation, oxidative stress, all these things, glycemic control, all these things together are improving the MACE outcome. And this led to consistent reduction in MACE, that is regardless of gender, regardless of your baseline A1C, how much you had at the beginning, what is your LDL level, you had a CABG or not, what is the change of HbA1c, whether you have MASH, whether you have hypertension, whether you have atrial fibrillation, what is your baseline hsCRP. You don't have to bother about all these individual parameters. You can have a certain level of benefit in users of Wegovy. Not only that, the SELECT trial subgroup analysis has come up that there are favorable results as far as your kidney endpoint is concerned. So 22% reduction in the risk of kidney events has also been observed in the SEMA arm when compared to that of a placebo. This is also something very reassuring. Not only that, almost all the areas of diabetic complications, be it cardiovascular, be it CKD, be it the metabolic issues, be it the MASH, are being taken care of. People at risk of fibrotic MASH, they also have a significantly reduced risk of MACE. And whether the FIB-4 is more than 1.3, more than 2, whatever it is, even in the extreme cases more than 2.6, the mass reduction was consistent to the tune of around 20 to 30%. So semaglutide consistently reduced the risk of MASH across all the FIB-4 subgroups, potentially helping to address the large unmet need for MASH populations, particularly who are at high CV risk. These are also observed reduction in waist circumference, reduction in blood pressure, reduction in your CRP, as well as triglyceride. Now, what about data from the real world evidence? Yes, we can consider or compare two studies, the SCORE versus STEER. The RWE means the real world evidence, and we can see the individuals aged more than 45 years with overweight or obesity with atherosclerotic cardiovascular diseases were included. They did not have T2DM, and the hazard ratio was very significant, 0.4 in the arm with the SCORE, that is semaglutide, as compared to that of 0.7 with the tirzepatide arm. So much favorable, 57% reduction in your MACE points as compared to that of 29%. So Wegovy is indicated to reduce the risk of MACE events, that is cardiovascular death, non-fatal MI and non-fatal stroke, in patients or adults with established cardiovascular disease who are overweight or obese. They need not have to have diabetes. And this is also recommended by other parent bodies like ESC and the CCS guideline, that is in the chronic coronary syndrome persons. They can also be benefited. Well, the ADA is also there in persons with diabetes who has atherosclerotic cardiovascular disease, who have HEPF, who have MASH. In all these situations, if you consider semaglutide, that tops the list. Only one point I would like to observe is when the persons also have OSA, obstructive sleep apnea, in those particular setup, maybe tirzepatide have an edge over this SEMA molecule. Okay, so SEMA, what about the Indian population? Yes, more than 3,500 participants are from India across different trials. We consider the STEP. Then after that, there is SUSTAIN, there is oral semaglutide Pioneer, there is SOUL, all these studies, and Indian population was also there. So we can really rely on the data that they can be applicable to people whom we cater to. Significant 40% reduction in abdominal obesity has been observed in Asians, particularly with Wegovy. So this is the good things are there, fine. And what we have already discussed, that is 25% of the lost weight, you have to keep it in mind, that is because of your lean muscle mass loss. So a DEXA analysis at certain point, if you think it is necessary, can be helpful, and you have to be judgmental, particularly when you are catering to a patient who is already frail or elderly or having sarcopenia for some reason or other. So this thing you have to consider. And the SELECT trial we have just discussed, that reduced the MACE up to 36% in people, Asian people, with consistent effect regardless of BMI. So Wegovy is basically safe. Safety profile is also very good. It is well tolerated. it does not have much adverse effects apart from the usual GI symptoms, that is your nausea, vomiting, fullness, or GI upset. And the observed rate of hypoglycemia is also not at all increased as compared in step 2 trial, particularly in people with diabetes. We have a consideration of cholelithiasis, again that is very low as compared to 1.1% versus 1.6%, so nothing significant. Very few events of pancreatitis to the tune of maybe 0.1% to 0.2%. There is no increased risk of malignant neoplasms. There is no increased risk of diabetic retinopathy. One buzz is there regarding the issue of NION, that is non-ischemic anterior optic neuropathy, but the causality or the relationship with semaglutide is still not very established, and that is also very rare situation. We need not really worry about these issues when we prescribe, and there is no increased CV risk. It has been studied in n number of people and has a worldwide cumulative exposure of more than around 50 million patient years across indication since its inception in 2018. So, which patients in your practice are suitable for your Wegovy? This is suitable for anybody for chronic weight management who is above 12 years of age. So, younger people, more than 12 years, body weight more than 60 kg, you can go for it. For adults more than 18 years, having a BMI of 27 or more with at least one weight-related comorbidity, you can go for it. When the BMI is more than 30, it is enough indication you can start this molecule. And the usual things you all know, that is start with low dose 0.25, it's once weekly dosing, go for 4 weeks, up titrate to 0.5 to 1, then 1.7. This escalation is very important, and often you have to be a little slower at escalation if the patient experiences some GI adversities. But this is the usual sequence of dose escalation. So to conclude, Wegovy provided substantial and clinically meaningful mean weight and BMI reduction in adults and adolescents. So beyond your medical nutrition therapy for up to 5%, and at the other end for bariatric procedures for 30%, in between 15-20 is achievable with it. This is the only anti-obesity medication with proven and sustainable consistent benefit in Asian subjects. And it has been well studied, has a good safety profile, supported or backed up by your SELECT trial for cardiovascular safety as well. So, and the SELECT trial has also shown to some extent that it helps to improve the kidney outcome. So this is fantastic molecule, go for it. Thank you.
Thank you, Dr. Chakraborty. That was a wonderful deliberation. And we have time for only one question. Rest can be discussed over the lunch.
A small announcement here. There's a small announcement. There will be no formal lunch break. So the lunch area is open. Please proceed according to your liking. We will continue with our academic session. Due to shortage of time, we are not allotting any formal lunch break.
Sir, there has been reports of regaining of weight after discontinuation of these therapies. So what is your opinion, sir, about the duration of the treatment of GLP-1 and dual agonist?
There is no such defined duration, as long as you can. And you have to keep in mind, you are taking anti-blood pressure pills. If you stop it, the blood pressure will increase. You are taking anti-diabetic medications, you stop it, the glycemic control will be bad. So as long as you can, of course there is some legacy effect like thing, that if you continue with your lifestyle managements, if you continue with your exercise, then your weight management will remain good for at least several months or several years. Just someone was of 100 kg body weight, if he can achieve say 20%, 80 kg, he will be more physically fit, he will be more like to do the exercises, etc. So he can possibly maintain a better outcome.
Now going to our next session.
Thank you, sir. Please take your seat. Our next topic again is in the industry symposium, and for that I invite our esteemed speaker, Dr. Soumobroto Rai Chaudhary from Kolkata, and sir will be speaking on holistic type 2 diabetes management with innovator semaglutide, evidence and experience. Over to you, sir.
Thank you. We all know that we are running short of time. But taking permission of the chairs, could we please observe a 15-second silence in the memory of Abhaya who died on this day? Could we please? If everyone agrees. Somebody to keep the time, please. Today was the day when she deceased in Arjikar Medical College, which incidentally is my alma mater also. Thank you. Thank you so very much. This is my disclaimer that I have used artificial intelligence as a design aid for organizing images and generating graphical and infographic layouts. The medical content, literature review, interpretation of evidence, and final presentation were developed, verified, and approved by me. So this is the agenda for today's talk: the burden of diabesity, the need for holistic management, and why is semaglutide an ideal fit to manage diabesity. Then we would look at Ozempic, the original semaglutide for metabolic management, sugars and scales, and then we look at Ozempic for organ outcomes, that's cardiovascular and renal protection. So, diabetes, as we know, now is combined with obesity, and we say that it's diabesity care. Need to address both the sugars and the weight. The association of type 2 diabetes with obesity, CKD, CVD, peripheral arterial disease, and MASH has been well documented. The management requires a holistic, multifactorial, and person-centric approach. And why are we talking all? Because the burden in India remains massive. 101 million diabetics in India, of whom 70% do not reach the target of less than 7%. And 85% of these die out of cardiovascular disease. 44% suffer from chronic kidney disease. And those who have weight issues along with diabetes account to about 90%. So this is a slide that is very well known and understood, the legacy effect from UKPDS, which showed that yes, conventional versus intensive therapy did cause 24% reduction in microvascular outcomes, 15% reduction in MI, and 13% reduction in all-cause mortality, and the benefit was beyond the point at which the intensive control arm was stopped. So the legacy effect did continue. Weight optimization helps further in improving the legacy effect, disrupts underlying pathophysiology, reverses or slows down disease progression, promotes glycemic control, impacts cardiometabolic risk factors, and prevents micro and macrovascular complications. So why is semaglutide an ideal fit to manage diabesity? Well, if we look at the GLP-1 receptor agonists, they offer multimodal benefits in diabesity: decreased insulin secretion from beta cell, increased hepatic glucose production, increased lipolysis, impaired appetite regulation. This all contributes to diabetes, as we all know. And these 7 pathways out of the ominous octet containing 8 pathways are taken care of by GLP-1 receptor agonists. Semaglutide is a human GLP-1 analog having 94% homology to endogenous GLP. Novo Nordisk's rDNA, recombinant DNA semaglutide, has been extensively studied across randomized controlled trials and real-world evidences, has a half-life of 7 days, and also been co-formulated with SNAC, enabling oral dosing. And it has been endorsed today by all these professional guideline bodies across the globe for use in diabetes, with cardiac issues, with renal issues, as well as ASCVD. It's a potent GLP-1RA created through the quality-driven innovation, and these are the steps. As you know, that the original synthetic original GLP-1 RA has got a backbone which is synthetically manufactured, and the side chains are done by this rDNA technology. These are the steps. The cell line, the biologic medications are made in living organisms by genetically engineered DNA, and then the cell growth is achieved in seed bioreactors to multiply and transformed into larger ones, and then cell culture is done to select the cells to undergo multiple stages of culturing. And then recovery. The cells are harvested from the final bioreactor. Liquid containing the express protein is prepared from cells and cell debris. And then they are separated and purified, and chemical modifications, if any, are carried out. This is the most important part of the process, and after which the protein formulated into a stable therapeutic product and filled into devices for administration. It has got a robust clinical development program. All of you are aware of that, the SUSTAIN group of studies, and 1,250 odd Indian population participated in it. SUSTAIN 6 was the cardiovascular outcome trial. In addition to it, we had the FLOW study, which was a dedicated renal outcome trial. Ozempic for metabolic management, sugars and scales. So this was the SUSTAIN group of trials. So what did we see? In monotherapy, if you see that the blue line is 0.5 milligram of Ozempic and the dark bluish line is for 1 milligram of Ozempic versus placebo versus sitagliptin versus SGLT2 inhibitor, one of the strongest, that's canagliflozin, versus exenatide, dulaglutide, as well as Novo's own product, that's liraglutide. Everywhere semaglutide was superior. As an add-on to SGLT2 inhibitor, also SGLT2, metformin and SU in one arm and added to semaglutide. Everywhere we see that the HbA1c reduction was fantastic, and greater HbA1c reduction was achieved versus all comparators in the SUSTAIN program, including the previous GLP-1 RAs, either daily or weekly ones, which were available. 2.8% proven to be superior, that's the reduction of HbA1c versus other anti-diabetic agents. 4 out of 5 people reached a guideline recommended target of less than 7% in the SUSTAIN program. And if you looked at the weight loss, you would appreciate that it's staggeringly high than all the others taken together. Again, we would focus our attention towards exenatide, 1.9 kg versus 5.6 kg, dulaglutide and metformin, 2.3 versus minus 4.6, liraglutide, minus 1.9 versus minus 5.8. So it fared much better. Another thing that we used to talk about is the canagliflozin 100 and canagliflozin 300. This was obviously with the 300 of canagliflozin, it was minus 4.2 versus minus 5.3. Achieving weight loss in type 2 diabetes is difficult due to multiple factors. However, in the SUSTAIN group of trials, we got about 8 kg weight loss in people with diabetes with high baseline BMI. 2 out of 3 people with diabetes reached a clinically meaningful weight loss target of at least 5% in the SUSTAIN program. And it also reduced the waist circumference. Weight loss with Ozempic was predominantly driven by fat mass loss, thereby increasing overall lean mass proportion. Mean reduction in total fat mass and total lean mass, if we took into account, there was a 1.2% mean increase in lean mass as a proportion of the whole. But we must remember, here is Obelix, who decides on taking semaglutide, but that's not enough. He has to exercise, resistance training, he has to run to catch the boar, which is a protein predominant diet, and then he becomes the slimmer Obelix, and he is transformed. But then when you stop the semaglutide and you get back to your habits of taking large portions, get back to your habits of not exercising, Obelix is back to original, decides on taking semaglutide again. So the resistance training and the other food restrictions have to continue to maintain the weight loss. So optimal nutrition and physical activity are essential to minimize the muscle loss. As I showed, the resistance training, protein intake should be about 1.5 gram per kg per day. Fiber greater than 21 grams per day for women and greater than 30 grams per day with men. Hydration is also very important, about 2 to 3 liters per day. Resistance exercise to maintain and build muscle strength. Physical activity, weekly 150 minutes of moderate intensity physical activity has to be undertaken. Higher weight loss, as my previous speaker Shumita has already told, can be achieved with Wegovy, which is built on the same semaglutide molecule. Metabolic benefits with Ozempic have shown to be durable. Glycemic control and weight loss has been established for 4 years from initiation. In the combo study, so in today's world, we have the best of both worlds. Maybe we can combine Brian Lara and Sachin Tendulkar in one team. Combo study combined the SGLT2 and semaglutide and looked at what happened when it was pitched against SGLT2 inhibitor alone. 49% lower risk of ischemic stroke, 38% lower risk of MI, 94% higher probability of reaching HbA1c targets, 48% lower risk of 3-point MACE, 47% lower risk of 5-point MACE, and 277% higher probability of having a weight loss of greater than 10%. This is the complementary mechanisms of action, and as you all know, it would, when combined, they would satisfy all the 8 arms of the ominous octet. The combination of semaglutide and SGLT2 inhibitor have significant clinical merits with regards to appetite reduction, body weight reduction, reduction of CV events, heart failure events, increased insulin secretion, muscle glucose uptake increase, well, to name but a few. Ozempic also brings down insulin resistance in people with type 2 diabetes, and we see a positive linear association was identified with weight loss and reduction in insulin resistance with semaglutide treatment in the SUSTAIN trials. This could lead to a dose reduction for concomitant insulin therapy. Ozempic for organ outcomes, cardiovascular and renal protections. We would go in brief why type 2 diabetes and diabesity, what are they associated with? Every year of poor glycemic control in type 2 diabetes can result in 67% myocardial infarction, 64% increased risk of heart failure, and 51% increased risk of stroke. The SUSTAIN 6 was a cardiovascular trial, and 83% participants had an established cardiovascular disease or CKD or both. Ozempic reduced by 26%, lowered the risk of 3P MACE. And if you compare the 3P MACEs of Ozempic, that's semaglutide originator, tirzepatide, and dulaglutide, you would see that the non-fatal stroke was the main driver of 3P MACE in the SUSTAIN 6 trial. In the SURPASS CVOT, none of the endpoints reached a superiority. The total superiority which was achieved in SUSTAIN was entirely driven by the reduction of non-fatal stroke. A similar trend was there in the REWIND trial also, where also the non-fatal stroke was the prime driver of reducing the relative risk reduction of 12%. It improved cardiometabolic risk parameters by reduction in free fatty acids by 12%, in serum triglycerides by 14%, reduction in VLDL cholesterol by 12%, and reduction in LDL cholesterol by 8%. The flow, the kidney outcomes, the dedicated kidney outcomes trial with Ozempic, the first signs were there from the post hoc analysis of the leader trial. Then came the REWIND 7, where they had a pointer towards being renal protective. Till that point of time, GLP-1 RAs were not being tried for renal issues. Then came the flow trial, adults with CKD and type 2 diabetes, the primary composite outcome being greater than 50% reduction in kidney failure, cardiovascular death, or death for kidney failure. Key secondary outcomes were annual rate of change in eGFR from randomization to end of trial, major adverse cardiac events, and death from any cause. 24% reduction, lower risk of composite kidney outcome. Well, 32% urine ACR improvement versus placebo, slower eGFR decline with semaglutide versus non-users of semaglutide, and most importantly, additional 5 years without end-stage kidney disease. So it is proven to delay kidney disease by up to 5 years. The mechanism behind renal benefits of Ozempic has been studied in a large trial called REMODEL, and we have come to know that from the flow trial that Ozempic protects the kidneys. But from the REMODEL, we have come to know how Ozempic protects the kidneys. So REMODEL provides mechanistic evidence to explain kidney protective outcomes observed in people with type 2 diabetes and CKD, reducing excess fat within and around the kidneys, improving kidney hemodynamics, stabilizing cortical kidney fibrosis, and downregulation of gene expression associated with metabolic stress and fibroinflammation in glomerular endothelial cells. That improved kidney function, reduced albuminuria, and preserved glomerular infiltration rate as observed in the flow trial. It is recommended by global guidelines across patient phenotypes, by EASD and ADA in type 2 diabetes and ASCVD, and also in type 2 diabetes, by ESC, ASCVD in type 2 diabetes, by Diabetes Canada, diabetes in CKD, ASCVD in type 2 diabetes, in American Diabetes Association, and if you look the KDIGO, it is also approved for diabetes in CKD. The American Heart Association and American Stroke Association also advocates it for stroke prevention in type 2 diabetes. So, the EASL and EASO has also recommended for MASH and type 2 diabetes, and American College of Cardiology, again, CV risk reduction in type 2 diabetes and also in peripheral arterial disease. So we would be happy if Superintendent Sir from Nonte and Fonte could take his Ozempic and become the slimmer Superintendent Sir with the magic bullet that we have in hand now. And Ozempic not only will give him a glycemic management, it will also deliver a weight management, the CVD risk reduction, and CKD risk reduction. So is it a magic bullet? Even professors are perplexed. Thank you so very much for your kind attention.
Thank you, sir, for your insightful talk on the innovator semaglutide. Now the forum is open for discussion. We can take one question and rest of the question can be addressed during the lunch hours. We can take only one question.
So it's all or none, all understood or none. We don't have any questions.
Thank you, sir.
Thank you.
Thank you so much, sir. That was a very insightful and thought-provoking session. I'll request all of the speakers and chairpersons to come over the stage. There will be a photo session, and that will be followed by felicitation. I'll request Dr. Rakesh sir to please felicitate all of the speakers and chairpersons of this session. Following this session, we will be now proceeding towards a session of debate, and the chairperson of this session is Dr. Soumi Goswami sir. Sir,
Thank you. So very good afternoon to all of you. We all have been looking forward to the debate this afternoon, and
so that was our pre-lunch session. Okay. Dr. Akash Panigrahi, are you in the room? Please come to the side dais for felicitation. Okay, so that was our pre-lunch session. We are already running late. So as you already know, there will be no formal lunch break. No scientific conference can achieve its purpose without the generous support of the industry partners who share our vision of advancing diabetes care and education. I take this opportunity to felicitate our esteemed sponsor with a special sponsorship award in recognition of their outstanding support. May I call upon the stage the BDF chairman, Dr. Amitabh Bishas, to distribute the award. The first award, may I call upon the stage Mr. Putul Sarkar and Mr. Ujjwal Mondol from Eli Lilly. Can we have a round of applause? Mr. Putul Sarkar and Ujjwal Mondol. Okay, okay. Sorry, madam. Ms. Putul Sarkar and Ujjwal Mondol from Eli Lilly. It's our pleasure to have you in our sponsorship team. Without your support, this event cannot be a successful one. Thank you, Eli Lilly. The next award goes to Mr. Saurabh Singhorai from Novo Nordisk. Ms. Amrita, please come to the stage. Novo Nordisk always supported research activities throughout the years. Thanks for your support. We would like to invite Mr. Prashant Kumar Mishra from Sun Pharmaceuticals and his whole team. Mr. Prashant Kumar Mishra and his whole team from Sun Pharma. Not only in diabetes, but in all the spectrum of pharmaceuticals, Sun Pharma deserves a special mention in our pharmaceutical range. Thank you, Sun Pharma and team. And last but not the least, I would like to invite Mr. Debashish Sengupta and his team from USV. Mr. Sengupta and his team done a wonderful job on behalf of USB in reshaping diabetes management throughout the years. So we will be back with our educational program, and for our post-lunch program, I would like to invite Shomik Goswami. I would like to invite Shomik Goswami sir to moderate the next session. The next session will be an interesting one. I'll hand over the podium to Dr. Goswami sir.
Thank you, Tarok. A very good afternoon. So finally, it's time for the debate with a very, very, very interesting topic. The topic of this year's debate at BDCON is healthcare systems should prioritize the formulary inclusion of SGLT2 inhibitors over semaglutide for maximizing population level health outcomes. সহজ বাংলায় বললে কি, যেখানে ওষুধ ফ্রি অফ কস্ট দেওয়া হয়, ফর এক্সাম্পল গভর্নমেন্ট হসপিটালস, গভর্নমেন্ট হেলথ স্কিমস, ইন্স্যুরেন্স, সেখানে কোন ওষুধটা ফ্রিতে দেওয়া উচিত? ইফ ইউ হ্যাভ আ চয়েস বিটুইন SGLT2 ইনহিবিটর বা সেমাগ্লুটাইড, কোন ওষুধ জনগণকে ফ্রিতে দেওয়া উচিত টু ইমপ্রুভ population level health outcomes? A very, very interesting topic. To speak for the motion, we have Dr. Anish Kaur, the proponent of the motion, and to speak against the motion as opponent of the motion, we have Dr. Piyash Gorgori. So before Anish starts speaking, as is customary, we'll have a raise of hands. Ke kar kon pokkhe, not Anish ba Piyasher pokkhe noy, ke motioner pokkhe, ke motioner against e. So how many in the audience feel that বিনা পয়সায় দিতে হলে SGLT2 ইনহিবিটর দেওয়া উচিত, সেমাগ্লুটাইড দেওয়া উচিত না? Can you raise your hands? So around 1, 2, 3, 4, 5, 6, 7, 8, 8-9 জন. And how many believe যে ফ্রিতে দিতে হলে সেমাগ্লুটাইড দেওয়া উচিত, SGLT2 ইনহিবিটর দেওয়া উচিত নয়? ওটা গুনবো না। 1, 2, 2, 2, 3, পেছনে একটা দেখতে পাচ্ছি 4. So you begin with an advantage. Anish begins with an advantage, but again disadvantage হওয়ার একটা advantage আছে. So let's see how Anish does. So over to you. Your time starts when you start speaking, I think. Okay.
Good afternoon, everyone. First of all, I thank the organizers, led by Tarokda, for providing me the opportunity to debate on what is a rather important topic, not only from a diabetes perspective at a diabetes conference, but also a health economic perspective, as Shomik sir rightly pointed out. So I will be speaking for the motion that is healthcare systems should prioritize the formulary inclusion of SGLT2 inhibitors over semaglutide to maximize population level outcomes. If you consider diabetes related population level outcomes, you have the apple, the SGLT2, and then you have the snake, or the reptile-mediated GLP-1, or that may be a misnomer. But then how do they fare when they come to a health economics perspective? I would firstly like to point out that what are the principles of clinical ethics as we apply to medical care. So that is beneficence or non-maleficence. We should not have any malified intent to our patients. There should be a respect for the patient's autonomy. There should also be a distributive justice, where there could be ruling out any potential conflicts of interest, which I have none for this topic. I have used AI to help me facilitate this topic, but I have added my own inputs into it as well. And of course, any other research or educational considerations, any conflicts of interest based on religious beliefs, and most importantly, if you see the last line, the problems in allocation of scarce resources. In a country where only 0.5 to 1.5% of the GDP is devoted to healthcare, and where you have so many pieces of one single pie being allotted, it is very important to allocate which pieces of the pie should go where. Now, what about the burden of diabetes? If you see via the IDF Diabetes Atlas standards, by 2024, you had around 588 million, which is extrapolated to grow to around 852 million by 2050, so a 45% increase. In Southeast Asia, that is 106.9 million in 2024, which would be expected to undergo an extrapolated 73% increase to 184.5 million in 2050. The top 5 countries, definitely India is amongst the top in the Southeast Asian region, with around 90 million people living with diabetes in the adult age group at 2024, which is extrapolated to grow to around 157 million in 2050. So India accounts for almost 1 in 7 of all adults living with diabetes worldwide. if you see the total diabetes-related health expenditure, which includes both out-of-pocket expenditures as well as government expenditures, that has been steadily increasing since the IDF has come into being when they started putting in this metric in 2003. And it actually breached the 1 trillion mark in 2024 and can only go up, if not low, which is something we should be addressing as well. In the Southeast Asian region, the total diabetes-related health expenditure is second lowest amongst all the IDF regions at around $12 billion US. So what about the goals of care and outcomes in diabetes mellitus? Our guidelines have been discussing it ad lib. This is taken from the recent ADA EASD consensus statement, which was discussed at the ADA meeting in 2026. You don't just focus on the glycemic management, you address the broader goals of care, the cardio-kidney protection, the well-being, quality of life, weight management, obesity-related complications, physical function. So SGLT2 inhibitors are one of the major cardiovascular advances of the 21st century. In fact, Dr. Braunwald, a venerable person in the field of cardiology and cardiodiabetology in 2021, made this statement in an editorial that they are the statins of the 21st century. We all know about its mechanisms, that it primarily prevents glucose reabsorption at the level of the proximal convoluted tubule, and you have these various other mechanisms that have been elucidated via which it improves renal function, it improves mitochondrial function, it can decrease inflammation as well as cardiac stress, arrhythmia, arterial stiffness, ultimately pointing to salutary benefits on organ protection, lifespan and health span. Now, recently, this is from a recent review in JCM where they are showing that SGLT2 inhibitors have age prolonging effects via various mechanisms. But the point is to be that with all our treatments that we have, we are trying to increase the lifespan of our patients with diabetes. So if we can give a drug which can help improve the lifespan like a senolytic agent, it actually helps benefit my argument as well. It's like the proverbial fountain of youth. This picture was taken from the Pirates of the Caribbean. So then, what are the three questions we are looking at? One is reach. How many patients across a health system can actually access, afford and tolerate this therapy? What is the breadth? That is how many disease states, diabetes, CKD, heart failure does one formulary slot cover regardless of the body weight or A1C? And what is the system's cost? What is the total budget impact per patient year at a national procurement scale, not as per patient willingness to pay? So my argument is that this is not about which drug is better, it is which drug should sit first in the formulary. So now if you see the the two drugs, they actually do work, but they do different jobs. From two recent network analyses, it has been seen that SGLT2 inhibitors have a slight edge, maybe nominal, in terms of major adverse cardiovascular events. It definitely has great effects as far as hospitalization for heart failure is concerned, and it definitely has good effects as far as composite renal outcomes are concerned. Regarding the other two, we know about the role of GLP-1RA, and my opponent will be talking about in details, I presume. So in that regard, the ADA standards of care, there SGLT2 inhibitors are recommended for all adults with type 2 diabetes and heart failure, be it reduced ejection fraction or preserved ejection fraction, irrespective of A1C, which is a grade A recommendation. GLP-1RAs are preferentially reserved for advanced CKD, especially in EGFR less than 45, where the SGLT2 inhibitor glycemic effect wanes. Both are endorsed for ACVD risk reduction with a grade A recommendation. But SGLT2 is the default heart failure or renal impairment anchor where it's indicated. Now, what about the NICE guidelines? The NICE or the UK NHS system has always done cost effectiveness analysis looking at a public health outcomes basis. So there also in the February 2026 update, they said that metformin and SGLT2 inhibitor is the universal first dual therapy for type 2 diabetes and no relevant comorbidity. If metformin is not tolerated or contraindicated, you can offer SGLT2 monotherapy as well. GLP-1RAs and tirzepatide were not found to be or did not have evidence for clinical or cost effectiveness in this population, so were not recommended. However, triple therapy adding subcutaneous semaglutide up to a dose of 1 mg per week was reserved for defined subgroups, that is established ACVD, early onset diabetes less than 40 years of age, and definitely higher doses where you are needing it for obesity. The NICE modeling estimates show that earlier SGLT2 inhibitor uptake could prevent around 17,000 deaths over 3 years UK-wide. So both ADA and NICE have already built this exact tiering. And the pattern is identical in both the respective jurisdictions. Now, what does IDF 2025 say? IDF 2025 guidelines are actually, they have a basic standard of care and what would be an ideal standard of care depending upon a tiered approach. And I think it's very relevant for our country. The guidelines also state that 80% of people with type 2 diabetes are living in low to middle income countries, India foremost among them. The guiding principle is equitable, affordable access to cost-effective care for all people with diabetes, and metformin keeps the global first-line status specifically for its cost-effectiveness and availability. SGLT2 inhibitors and GLP-1 RAs are both endorsed as early add-on for cardiorenal protection, but IDF flags that accessibility remains uneven, particularly in lower resource settings. So why would that favor SGLT2 inhibitors in India? A 67% country LMIC price target micro-simulation done in 2021 found that SGLT2 inhibitors needed a 17.4 price cut to be cost effective, whereas GLP-1 RAs needed a 98.3% price cut from typical pricing prevalent at that time. India's 2026 generic SGLT2 pricings already sits far below that target, and the cheapest new semaglutide generics have also fallen sharply, but the typical brand has not yet caught up. So IDF does not rank SGLT2 inhibitor above GLP-1 RA as far as trial merit is concerned, but it definitely ranks affordability above both. On that test, SGLT2 inhibitor has reached population affordable pricing first and more broadly across the market. In fact, SGLT2 inhibitors entered the essential life-saving medicines pool in 2021, followed by GLP-1 RAs in 2025, as far as the WHO is concerned. So why REACH decides it in India? The scale of the problem we are formalizing for. You have 101 million people living with type 2 diabetes in India as far as the ICMR India studies are concerned, and around 315 million people living with hypertension, the shared driver of kidney and heart disease as per the ICMR India 22 studies. And 57% of India's diabetic population estimated still remains undiagnosed. So how do we deliver at a population scale? Now, an oral tablet would definitely scale differently to a cold chain injectable. So an oral tablet being SGLT2 inhibitor, a cold chain injectable being semaglutide. So as far as SGLT2 inhibitors, you're giving them via an oral once daily route where semaglutide is being given subcutaneous weekly predominantly. Cold chain is not required for SGLT2 inhibitors, whereas it is required for injectable formulations. Device training again is not required for SGLT2 inhibitors, whereas the pen or vial technique and disposal counseling is required for subcutaneous semaglutide. Tolerability at scale, UTI and genital infection risks are there, but it is manageable with proper patient counseling. Whereas semaglutide, nausea and vomiting is definitely there versus placebo, and it also drives real-world discontinuation as is seen in our practice. What about PHCs or Tier 2, 3 hospitals and rollout feasibility? Definitely SGLT2 inhibitors fits that with existing OPD pharmacy workflow, whereas semaglutide is constrained by storage, device supply, and injection anxiety. Again, a 2025 Indian cost utility analysis as far as adding on SGLT2 inhibitors to HFrEF showed that at branded market prices, SGLT2 inhibitors added on to HFrEF was not cost effective under India's willingness to pay threshold at that time. 71% price reduction was required to cross the cost effectiveness threshold determined by Markov modeling estimates. Now, what has happened since then? Generic DAPA and EMPA are now widely available in India at 40 to 150 rupees per 10 tablet strip, and there is a fall of well over 80% from the originator pricing, exceeding the 71% threshold the cost utility model called for. So even after semaglutide's own patent cliff price crash post-March 2026, the gap remains wide. As you can see, 300 for the generic SGLT2 inhibitors. The cheapest generic semaglutide available on the market is at 1,290 rupees. The typical generic semaglutide pen is available at 3,500, and the branded semaglutide, despite a 48% price cut, is available at 5,000 rupees almost. So even at its post-patent crash floor, the generic semaglutide costs at least 4 to 19 times more per month than the generic SGLT2 inhibitors. So this is without adding the device, cold chain and training costs. At national procurement scale, that differential compounds over almost 100 million diabetes patients. So if it walks like a duck and talks like a duck as far as generic semaglutide is concerned, is it a duck? Well, you are drunk, ducks don't talk. So this particular paper analyzed in 2024 16 samples of injectable semaglutide copies, 8 oral semaglutide copies, and 2 liraglutide copies. And the GLP-1 synthetic copies tested versus innovator semaglutide were found to have high levels of impurities, aggregates, oxidation, instability, structural changes, and contamination. So patient outcomes with generic semaglutide are often unpredictable in terms of efficacy, with higher immunogenicity and potential safety concerns. So what has been the NHS blueprint? So with the NICE guidelines, they are doing a live natural experiment kind of with this formulary choice. There's a projected NHS saving of 560 million from generic dapagliflozin alone. 17,000 deaths are prevented over 3 years by an earlier SGLT2 inhibitor uptake, and there could be a 230% projected rise in dapagliflozin prescriptions, almost to 2.4 million patients in the UK once generic. So the savings that you will be able to get putting SGLT2 inhibitors into the formulary could be reinvested into diabetes education and community support, the reinvestment dividend of prioritizing the cheaper, broader-based drug first. Now, as far as the BDCON and NLM is concerned, both of the drugs are not listed. In the generic market, there are multiple established manufacturers for DAPA or EMPA, which has been off patent since 23-24 with stable pricing, whereas for semaglutide, the market is only less than 5 months old and price has still not settled. As far as the Jan Aushadhi availability is concerned, the SGLT2 inhibitors are already listed, whereas semaglutide is not yet available in formulary. And there are no significant legal or supply overhangs for SGLT2 inhibitors, whereas for semaglutide, there is an active Novo Nordisk litigation, as we know, versus the generic entrants. So what is the strongest case, if my opponent would like to say? That would be the SELECT trial as far as obesity is concerned. But the CV benefit in overweight and obese patients without diabetes shows a 10 to 15% mean weight loss unmatched by any oral agent. The real growing relevance is as India's obesity prevalence rises. But again, 79% of CKD patients in a large multinational cohort had no diabetes at all. So SGLT2 inhibitor eligibility would cross BMI, glycemic and injection tolerance boundaries that semaglutide does not. And SGLT2 inhibitor is not gated by GI tolerability, obesity status or willingness to inject. So you have heart failure and renal projection with SGLT2 inhibitors, a reasonable cost per patient month, no delivery infrastructure is needed, and you have India's generic market or NLEM readiness, all satisfied by SGLT2 inhibitors. So this is not an anti-GLP-1 RA statement, it is about sequencing the drugs. SGLT2 inhibitors should be the backbone of population diabetes formularies, oral, generically mature, cardiorenal protective across the widest possible patient base, and now affordable at a true population procurement scale. Whereas semaglutide remains a high-value, targeted second tier for ASCVD, early onset disease, and obesity-driven glycemic burden, exactly as the ADA and NICE have already tied it in 2026. So as Spock said, the needs of the many outweigh the needs of the few. Prioritize reach, prioritize breadth, prioritize sustainable systems cost. SGLT2 inhibitors first is what I would exhort to the House, and then semaglutide as the targeted second tier. Thank you. I forward it to my opponent.
Thank you. Thank you, Anish. You can come and have your seat here. So, using published evidence and logic, you have woven a nice story. We complete Act 1 of this play. Now we are going to see Act 2. For every thesis, there will be an antithesis. Let's see how Dr. Piyash Gorgori takes us as the opponent of the motion.
Thank you. First, let me thank the organizers for inviting me to counter the oversimplification made by Anish, for which I am thankful to my chairperson, Shomik sir, because he has actually made my job easy, and also thanks to Anish. Why? I'll just show later. First of all, how many of you are in favor of Bengali or English soaps? So, if anybody of you are fond of Bengali serial, you know, there happen a thing when the villain comes first and he tells something that sways the entire house away, followed by a short revelation by the hero that makes the house turn again topsy-turvy. So it's actually a thing that what he does or she does, he actually makes the eyes cloudy. He just shifts the vision from the actual viewpoint. Why? Because Anish already told there should be no malified intent. There must be autonomy of the patient. So if Anish, you are telling about autonomy, then including the formulary inclusion of only SGLT2 inhibitor over semaglutide, what autonomy exactly you are achieving? I don't think so. So it's a bit oversimplification. Why? The debate is not between SGLT2 and semaglutide. That's the very first essay that he made wrong. The debate is whether one drug should get priority over individualization of the medicines. Because as Leslie Lewis, a famous Canadian legislator, said, there is no one-size-fits-all response to health crisis. Yes, because if you say there are two patients, patient A on the left-hand panel and the patient B on the right-hand panel, both of them eligible for getting an SGLT2 inhibitor? Is that the motion of the house? If that, the patient B is going to be very sorry. Because what happened in the Kathamala, you tried to offer a plate of soup to the crane got nothing. Exactly what that he is suggesting. Right? So he told about diabetes burden efficacy. He forgot that he also quoted about the guidelines. I am just taking it from the AACE guideline. If you just look at the efficacy, the semaglutide's efficacy is far more than the SGLT2 inhibitors, be it any form. You can see, also, you can see the renal impairment part, there is reduced glycemic efficacy if the eGFR is low. So, what he was screaming to his lungs that it is better for all renal benefits and all, the primary thing that the drugs were recommended was because of diabetes. So you are proposing a drug that is efficaciously lower, that is having a lower efficacy than for getting a higher efficacy one. Why? That's a malified intent, right? I think so. Now regarding cost, if you just look at the cost, look at the cost of both of them are same, right? Now what does the guideline suggest? He told about the first part of the guideline, deliberately shielding you from the fact that for patients who are having atherosclerotic cardiovascular agents, those patients should receive GLP-1 receptor agonist first, not the SGLT2 inhibitors, right? And SGLT2 inhibitors are recommended for those patients who are having a propensity towards cardiac failure or renal failure, for them only. But those patients who are obese, who are atherosclerotically impaired, who are atherosclerotically having cardiovascular disease, these patients are the candidate of GLP-1 inhibitors, GLP-1 receptor agonists, right? And that's the very point that he deliberately kept you shielded out. Now coming towards the AACE guidelines, you can see for the heart failure also, SGLT2 inhibitors as well as GLP-1 is recommended, as well as for the ASCVD, for the, now coming towards the stroke. He deliberately told nothing about stroke. But for stroke, GLP-1 RA is again recommended. For MSALD, GLP-1 RA is again recommended. So if you are talking about population health, are you going to solely consider heart failure and renal impairment? That's the motion of the house. I don't think so. Because if you think about population health, you should think about the population holistically. You should think about the population's health. You should think about population's quality of life. And not just few heart failure data, few renal benefit data. Not that's not the way, right? Now if you look at the glucose-centric data as well, I think the learned audience can see that the GLP-1 RA are having ubiquitous presence, unlike SGLT2 inhibitors. You can see that here. So the guidelines suggest rather than using a uniform pharmacological approach, the clinicians should prioritize coexistence of these conditions to personify or personalize the selection of type 2 diabetes medications. That's the very essence of this debate. Now, as my learned friend has, I believe him entirely. Okay, he is my bosom friend. So I searched Google in favor of the motion, what he told. So I just got this response. Many diabetes guidelines, they do not recommend SGLT2 inhibitors over semaglutide. I don't get in. So Google has failed me. Okay, then I got for a single study. A single study that shows a semaglutide or SGLT2 fared better than semaglutide in terms of glycemic efficacy. So I got it here. This is an article from 2025, the recent most ones. Unlike his data, which was a pretty old one. So this study showed that adults with type 2 diabetes having once weekly semaglutide in the real world had significant decreases in weight, BMI, and of course HbA1c compared to SGLT2 inhibitor. In the similar healthcare resource utilization. So he was screaming his heart out that it was having a healthcare resource utilization is great, but no, that's a false. Because having a same healthcare resource utilization, greater benefits of BMI and HbA1c are produced by this once weekly semaglutide. The evidence lies here. So I'll ask my opponent, I'll concede defeat. Tell me one study where SGLT2 surpasses semaglutide in glycemic efficacy. Again, I think he is going to search the net for rebuttal with a confused anga-banga thing. Now, coming to the next global epidemic, obesity. WHO has called a global epidemic obesity, where every one of 8 people worldwide now lives with obesity. Every one of 8 people. So imagine the burden. Whereas heart failure constitutes, I just searched the Google, 1%. And CKD also, that fraction of diabetes that is recommended for these SGLT2 inhibitors, apart from IgA nephropathy and others are not treated with SGLT2 inhibitor. So that makes its magnitude of treatment very low. Whereas 1 of 8 people worldwide, if lives with obesity, they are automatically eligible for pharmacotherapy, if not managed by lifestyle alone. Now, from the ADA 2026, there is strong and consistent evidence that obesity management can delay the progression of prediabetes and highly beneficial for treating type 2 diabetes. And in patients who are type 2 diabetic with obese, which is going to be a capital of India, these agents can improve glycemia, can reduce the need for glucose lowering medication, greater weight loss, greater benefit. So it is in the long run, it is going to produce less burden on the healthcare expenditure. Right? Now, in people with diabetes and overweight or obesity, preferred pharmacotherapy is what? Is a GLP-1 receptor agonist. Again, semaglutide attacks the disease upstream, whereas his molecule, the SGLT2 inhibitors, largely treat downstream complication. Imagine a scenario. In this bathroom, the tap has been opened, the floor is flooded with water. What should we do next? My friend here is suggesting mop the floor. That's a simple option. But he didn't suggest that close the tap first. Shouldn't we close the tap first? That's the very basic, that the obesity is the mother of all diseases. Should we care to take care of that first? Now I'll ask Anish another simple question. What is population health? It is health outcomes of a group of individuals, including a distribution of such outcomes within the group. So I think he was laughing there. It's time to unsheath my data on severe renal benefit in general population, right? Hold on. Ruko jara, sabar karo. SGLT2 inhibitors produce heart failure risk and produce renal benefit, right? But preventing obesity means nipping those in the bud, right? I think so. Now, he was going to tell about population health is equal to CV benefit, renal benefit and all. Hold on. Actual population benefit means CV benefit, renal benefit, neurological benefit, osteoarthritis benefit, PCOS, cancer risk. All of them are countered by this single agent. If you see, if we can keep pace with the recent guidelines, FDA approves fast treatment to reduce the serious heart problems in obesity is semaglutide. For MASLD, semaglutide. For cardiovascular disease, as he told, selectrial, semaglutide. For osteoarthritis, semaglutide. For cardiovascular high risk population, again semaglutide. And lastly, not the least, to improve fertility in people with PMOS, again semaglutide. So he told about selectrial, I am not going to detail. It improved cardiovascular health in people without diabetes. I am talking about now without diabetes, thinking beyond diabetes, right? Now coming towards chronic coronary syndromes. This molecule has been endorsed by 2024 ESC guideline that these agents should be considered in CCS patients without diabetes where obesity is there to reduce CV mortality, MI and stroke. I think he is going to search the net for the rebuttal, right? Yeah, I would have done so. Now, for the step 1 trial, we all know this data regarding the obesity benefit. I am not going to detail, but this data is uniformly distributed across adolescents as well. So population health is nothing but a holistic approach. We do not exclude the adolescents, we include the adolescents. So again, for the adolescent people with PCOS, for the adolescent people with obesity, it is semaglutide, nothing else. Now, coming towards the neuro part, this semaglutide drug reduces infarct size, apoptosia, normalized neurogenesis in a rat model of stroke. So there is neurologic benefit. So I think I would have quoted this famous line, आज मेरे पास obesity है, reproductive benefits है, neurological outcomes है, skeletal health है, hepatic benefits है, तुम्हारे पास क्या है? तुम्हारे पास घंटा है, right? So my friend here is suggesting choose SGLT2 inhibitors. नहीं तो महंगा पड़ेगा, right? Let's come to a real world scenario. Hold on. Following the latest patent expiration in 2026, the generic semaglutide now costs roughly from 325 to 1050 per weekly dose, while branded options are pretty costly. If we look at the same options of your SGLT2 inhibitors, the cost is almost same, right? So I think the truth doesn't become less true because you don't like it. It is a truth because the price benefit doesn't really hold much of a value after the recent patent expiration. But yes, again, he told about something litigation, right? So again, litigation means competition and nobody likes competition, right? So litigation means competition and competition means the agent is doing better. And this doesn't mean that it should not be included in formulary, right? Now, cost effectiveness of empagliflozin versus weekly semaglutide. Let's look at this trial. For patients with type 2 diabetes and cardiovascular disease, semaglutide is likely to be more cost effective than empagliflozin added to usual treatment. This is a head-to-head trial data and this is a hard-based trial data. You see yourself, I have an army of diseases, obesity, CV risk, renal risk, hepatic problem, neuro problem, high cost, everything. We have only one drug, semaglutide. We have a Hulk, right? So my friend here is explaining inclusion of SGLT2 inhibitor in the formulary. डॉन को भूल गए और आप लोग तो जानते ही है जो डॉन को भूल जाते हैं वो कैसे होता है. Thank you.
So again, Yash regaling us with a lot of nice evidence as well as his cartoons that were included in the presentation. So we are running short of time, just a couple of minutes of rebuttal followed by a couple of minutes of sir rebuttal. Timer ta 2 minute set kore deben, audio visual.
Right.
Just wait Anish, let us set the timer. I have to bhebe nite paro. টাইমারটা 2 মিনিটে সেট করে একটু স্ক্রিনে দেখাতে হবে. হ্যাঁ, টাইম বাঁচাতে গিয়ে বেশি টাইম লাগছে. I'll keep the count, no problem. Ready? Chalo, your time starts now.
I thank my opponent, Dr. Piyash Gorgori, for that wonderful expository discussion with a lot of added theatrics in it. But the problem with theatrics is that the more you go overboard with theatrics, the less of substance you come out with it at the end of the day. So just to harp on that, you first talked about soaps. Again, only a person without a brain in India and Bengal would be going and watching soaps. So that is kind of the wrong comparison to be using again. But again, that's separately, that's a personal observation from my part. So you talked about the glycemic lowering efficacy and especially where semaglutide or GLP-1s win over SGLT2 inhibitors. My point is to Dr. Piyash is, have you ever been in the shoes of a health administrator where you only have possibly 1,000 rupees with you, and for that you'll have to not only allocate treatment to your patient, but also give him education, also give him preventive measures for diabetes, so as to he goes into gainful employment. What we are talking about when we are trying to go first with the SGLT2 first inhibitor approach is that the earlier we start off with a lower cost drug, the more savings that you get, which can be reinvested into the health system, focusing on the patient. You talked about patient ethics principles of autonomy as far as glycemic efficacy is concerned, but you forgot about that one part of distributive justice, equity versus equality. It is so important. If a little boy is standing not able to see the football match from the fence, and a tall senior classman is also standing beside him, it is the duty of the senior classman to get him a tool so that the little boy can see the match as well. So that is where we are talking about equity, not just equality. Everyone should be getting the same therapy in an ideal nation where possibly Dr. Piyash Gorgori does not live. So possibly that is why he has been so in favor of GLP-1 related therapies. And he talked about ADA and ESD, stating that as first-line therapies. But then, principally, they have talked about metformin with SGLT2 and as an add-on GLP-1RA, or where they are actually indicated. So it does not refute my argument. It kind of undercuts it and underlines it.
Quickly.
And lastly, you are talking about litigation being competition. I'm sorry, that is not how the majority of those suffering in India under our odious legal system sees it as. Litigation leads to a waste of resources, unnecessary litigation. We already have, because of the lack of supervision of our drug regulatory authorities, so many people operating in the same space. So I really don't think that argument really matters. We are talking about things which can be given at a low cost, and from that you can get incremental benefits which can be reinvested back into the patient, because we are focusing on the patient at the end of the day. Thank you.
Thank you. So we had a passionate rebuttal. Now we look forward to the sir rebuttal before we go back to our audience and see how they feel after the debate has ended.
Thank you, sir. And thank you, Anish. Actually, you just made my next punchline. You told about theatrical deception, right? But let me remind you of the famous quote from The Dark Knight. The theatricality and deceptions are two very powerful weapons, isn't it? Which should be used judiciously. So, it is theatricality is not nothing but your mumbo-jumbo things. It's actually helps. Now, first one. The second thing is, you told about the NICE guidelines. The NICE guidelines he told about the underlines where the in patients with atherosclerotic cardiovascular disease, the same NICE guidelines suggest adding semaglutide. The same NICE guidelines. Now, the thing is, he told about adding a lower cost drug in the upstream. But where upstream? You start your SGLT inhibitors when there is heart failure has already sets in. You start SGLT inhibitors already when CKD has been set in. There is any data of adding SGLT inhibitors in a de novo patient where it has inhibited the heart failure or renal data? I don't think so. But there is data that semaglutide inhibits the onset of diabetes-related complication. So what should be added first? And he told me about, as a healthcare administrator, you should told about, right? What would you do if you have 1,000 rupees? First of all, a healthcare administrator doesn't have 1,000 rupees. It's larger than that. So that's number one folly from him. Second thing is, the healthcare administrator would have less time to make a patient understand about diabetes education and all. So diabetes education will be less likely if this molecule is upstream, if this molecule is available, because it inhibits the prevalence of diabetes incidence. So it inhibits the conversion of pre-diabetes to diabetes. The second thing. Third thing, regarding you told about something regarding Jana Ushadhi, right? The molecule is recent. It is yet to get in Jana Ushadhi. And he deliberately forgot about one thing. While he was mentioning about cold chain, he deliberately forgot about there is a oral tablet of semaglutide. He deliberately forgot about that. So, aisa kaisa chalega babu, right? So, when you are looking at the picture, look at the picture in entirety, not the part, because half a truth is worse than a lie. Thank you.
Okay, so both of them have very nicely presented their point with or without theatrics, but we now go back to our audience and see how they feel about it. The only problem is that এখানে তো SIR হয়নি, অনেক নতুন লোক ঢুকে গেছে আর কি, যারা প্রথমে ভোট দেয়নি। Anyway, now let us see how it goes about. So at the end of this debate, how many of you in the audience feel that যদি বিনা পয়সায় দিতে হয় তাহলে SGLT2 inhibitor থাকা উচিত? Can you raise your hands by the government? Okay, গোনা মুশকিল, একটা ওই ভয়েস ভোটের মতো চোখ এস্টিমেশন হয়ে গেল। না না, দুজনেই ভালো বলেছে তো। And how many of you feel that বিনা পয়সায় দিতে হলে semaglutide দেওয়া উচিত? Okay, কম হাত, but I feel that turnover যদি দেখি টাই হয়ে গেছে, মানে the number of people who have converted. তো তুমি, both of you have actually done very, very well. Can we have a very big round? তোমরা দুজনে চলে এসো। Very big round of applause, because it was actually a very, very difficult topic. It was because you had to include science, you had to include economics, you had to include some principles of equality, equity, justice, philosophy, everything had to be included in it. Scientifically, it's easy to debate between them, but when you are looking at it from the point of view of a healthcare administrator, things become difficult. So I am the moderator, chairperson. I won't be taking sides. I am not a healthcare administrator either. I don't intend to be one. But if I had the power, I would possibly include both the original ones, increase the health budget. ঝামেলা আমরা এইসব ডিসকাস করছি বাজেটে পয়সা নেই বলে। Include possibly the originator one, why the generic one? Then it would be at the discretion of the treating physician, but as the saying goes, if wishes were horses, then ... Anyway, again a big round of applause to both our debaters. Both of them are winners today.
Thank you, sir. That was truly enriching session. I would request sir to please remain on stage for the group photo, and then I would request Dr. Nilanjan Sengupta sir to felicitate our faculties on the side dais. Pregnancy represents one of the most remarkable examples of physiological adaptation, where endocrine changes orchestrate the delicate balance between maternal health and fetal development. For the next presentation, I would like to call Dr. Shobhik Roy sir as a chairperson to moderate the next session.
Good afternoon. This is probably the last session before the quiz and the valedictory. May I now call upon Dr. Anirban Majumdar, and he'll be speaking on hypothyroidism in pregnancy. Dr. Majumdar, please.
So, good afternoon, and I would like to convey my sincere thanks to the organizer for inviting me. And after this wonderful debate, I think all of you are awake after the lunch, so they have done a beautiful job. And now I start with hypothyroidism in pregnancy. I will discuss few cases so that we can implement the understanding into our day-to-day clinical practice. So first case is a 32-year pregnant lady with symptoms of restlessness, lethargy, edema and enlarged thyroid gland. Pulse 96, blood pressure 110, grade 1 goiter. Thyroid function test was done as a routine antenatal checkup on 12th week, and you can see that the T4 value is slightly on the upper side. Is it not working? So T4 value is on the upper side and TSH is actually suppressed. So this is, so one, it was referred by one gynecologist with the idea that the patient is having some thyroid dysfunction, and how we would like to interpret the result of the thyroid function test result. So we need to understand that when there is a pregnancy, there are few hormonal changes occurs. Number one is a rise in the HCG, which actually suppress the TSH, and there is a rise in the thyroxine binding globulin because the impact of the estrogen, and therefore the total T3 and total T4 goes up. So therefore, in this particular patient, the total T3, total T4 is up and TSH is low, particularly in the first trimester, and therefore in this pregnant woman, if you repeat the test, you will find that it is same, there is no change, 12.8 and 0.22, and it is because of the impact of thyroxine binding globulin and HCG, and you have nothing to do as far as this particular patient is concerned. So this is very important to understand that we are not supposed to do anything. So if you look into the pregnancy specific normal range up to last year, I was using this data, the first trimester, second trimester and third trimester value. It was actually given by American Association of Clinical Endocrinology and ATA. Even though this value was actually debated by many people, that what is justified in American people or American pregnant mother may not be equally justified in other our population. And we now in 2026 the guideline has been changed, and they say no, you take the thyroid function test result value of mothers of your society. So they have given this guideline that the percentile range of a population representative of the healthcare providers patient population. So you look into your own patient's value. Now if you look into trimester specific reference interval in Indian pregnant woman, the value is different than what ATA had suggested. So you can actually keep it in your table or in your mobile, so that you can look into the value when you are evaluating the thyroid function of your patient in pregnant condition. So during pregnancy we diagnose overt hypothyroidism if the TSH value is high and T4 value is low. Subclinical hypothyroid if TSH value is high and T4 is normal, and isolated maternal hypothyroxemia when the T4 value is low and TSH value is normal. So these are the three important differential diagnoses. So when you look into the thyroid function test result during the pregnancy, we need to understand that the HCG is a weak agonist of TSH receptor, so it increases the thyroid hormone production. Thyroxine binding globulin, as I have already said, increases the total T3, total T4. And please remember, gynecologists often prescribe doxinate as an antiemetic. So doxylamine, it itself can raise the value of TSH. So that is also an important point to remember. An alteration of binding protein level during pregnancy, the FT4 estimation has got lot of uncertainty, and therefore free T4 concentration many people believe should not be done during pregnancy. The free T4 which we routinely look in the non-thyroid, non-pregnant people is basically not applicable or at least debated as far as FT4 values are concerned. So therefore, many people believe that it is better to use the total T4 value and take 1.5 times of the non-pregnant level as a normal value. However, again, there is a point against this, that as because more than 99% of the T4 is bound to thyroid hormone binding protein, so only very small fraction actually freely available. How by looking into total T4 you get an idea about free T4. So there is point in favor and point against both, that whether we should do the free T4 or whether we should do the total T4. Now coming to the maternal total T4, and this is the value of maternal total T4 in different trimester, and you can see that the value goes up to 150 times during pregnancy, up to 150 times during pregnancy over the first, second and third trimester. Now coming to the case study 2, with this understanding in your mind, we will look into the other case studies, because we need to understand that during pregnancy there is a lot of alteration of the thyroid function test, and therefore it must be factored when you are looking into thyroid function test result of a pregnant mother. Coming to say the symptoms of the same 32-year-old lady, same, and in the first antenatal checkup, if the value comes like this 1.2 and 0.42 and anti-TPO antibody is positive, both are normal, anti-TPO antibody positive. So whether we should treat or we should not treat, should we give the patient the thyroxine replacement therapy because the anti-TPO antibody is positive? If we look into the data, this is a study done 20 years back and with very robust data, that if somebody have the normal thyroid function but anti-TPO antibody is positive, it is associated with poor outcome as pregnancy outcome, miscarriage and preterm delivery. So therefore, after this trial, many people used thyroxine replacement therapy with patient or pregnant woman with anti-TPO antibody positive but euthyroid. However, if we look into the Endocrine Society guideline, they said there is no point of doing universal screening for antithyroid antibody because it is now questionable that whether the replacement therapy really give benefit as far as pregnancy outcome is concerned. Universal treatment is also not necessary, but if somebody has anti-TPO antibody positive, we should remember they can develop thyroid dysfunction in near future. So we should follow the patient, check for the thyroid function after 4 weeks or during second trimester, during third trimester, even after the postmortem, they should be under close follow-up. So if a patient have the infertility and the patient has got a thyroid autoimmune antibody positive, whether TPO or TG antibody, the levothyroxine therapy should not be offered. So this is 2026 guideline which published very recently. So it means that the patient who is not hypothyroid or euthyroid, anti-TPO antibody positive or thyroxine binding globulin, TG positive and TG antibody positive, they should not be offered the thyroxine replacement therapy even if they have infertility. Case number 3 is 32-year-old lady desires to have a baby, and now on routine follow-up you will find that there is a TSH value 7.42 anti-TPO antibody negative. So should we treat? The answer is, and you have done the repeat test 1.6, 6.42. So repeat test suggests that there is a subclinical hypothyroidism and we should start the therapy. So why I have said, because if you look into the 2026 guideline, the guideline is if there is a TSH level is increased in preconception, they check FT4. If the low T4, start the therapy. If there is a subclinical hypothyroidism, recheck, and again subclinical hypothyroidism, please start the therapy. So irrespective of whether the patient is TPO positive or TPO negative, it means subclinical hypothyroidism and the patient is desiring for pregnancy need to be treated. Case number 4, this patient is pregnant, thyroid function test done as per as routine antenatal checkup, and again the T4 is normal, but TSH is very high, more than 10, TPO positive, and quite naturally this patient should be treated. Coming to the TSH level in pregnancy, not before pregnancy, in pregnancy, increased TSH, if it is more than 10, just treat. You do not have to look for TPO antibody presence or absence. If it is TSH high, low T4, overt hypothyroidism, treat. If it is normal, subclinical hypothyroidism, and then repeat the test and start treatment. So therefore, subclinical hypothyroidism with TPO positive, with TPO negative, TSH more than 10, we should always treat, and if it is TPO positive, definitely we should treat. So if you look into optimal treatment of overt hypothyroidism, treat with oral T4, no question of giving LT3, which is now in their market, and we should normalize the maternal serum TSH value within the trimester specific reference range, and it is better to do not try the lower limit of TSH 0.1, don't go beyond 0.1. So this is the guideline as far as the thyroid guideline is concerned. Coming to case number 5, the 25-year female known hypothyroid pregnant primi gravida. She was on LT4 for the last 3 years. Pre-pregnancy thyroid function test reveals thyroid function is perfectly normal. So therefore, what we are supposed to do, the patient has become pregnant. So 10-week pregnant. So all patients who become pregnant, hypothyroid patient become pregnant, we need to increase the dose. Even if you have not done the test further, we have to increase the dose by 25 to 30% as soon as the patient become pregnant. So I usually ask the patient, whenever you become pregnancy test become positive, just increase the dose by 25%. Requirement gradually increase through 16 to 20 weeks of pregnancy, thereafter plateau, and TSH should be monitored approximately every 4 weeks, and then once at 26 and 32 weeks. You need to remember that during the first and second trimester, the thyroxine replacement is very, very important, because fetus is not producing its own thyroxine hormone. Once after second trimester, fetus is producing its own thyroid hormone, therefore maternal thyroid hormone replacement therapy becomes less important. So increase the dose during pregnancy. Maternal serum TSH concentration less than 2.5 is a very, very reasonable goal. In postpartum period, if you have started the thyroxine replacement therapy with baseline TSH value more than 10, do not stop the drug, continue the drug with same dose. If you have started the LT4 replacement with the TSH value less than 10, then you can stop the drug and recheck and then decide whether to treat or not to treat. Coming to the take-home message, thyroid physiology is modified during normal pregnancy. We need to understand that there is lot of changes happen in pregnancy. There is a rise in HCG, therefore TSH value goes down, and low TSH during first trimester of pregnancy is normal finding. On the other hand, the thyroxine binding globulin goes up because of the effect of the estrogen. So if you measure the total T4 value will be more. It may go up to 150% or at the upper range of the normal, and therefore this changes in thyroid function test should be interpreted very cautiously. At the same time, the laboratory analysis may be questionable, because there is binding proteins are there in pregnancy, and they may alter the measurement of the FT4 concentration by different immunoassay. Now, no universal LT4 treatment for TPO positive euthyroid pregnant woman, whether the patient is desiring for pregnancy, or the patient is planning for pregnancy, or the patient is getting some treatment for the infertility, there is no point of giving thyroid replacement therapy. LT4 treatment is recommended for all TPO positive and negative women who have subclinical hypothyroidism. We should treat overt hypothyroidism should be treated in pregnancy, and women with established hypothyroidism, when become pregnant, the dose must be increased at least 25%, and thyroxine replacement is very important during the first trimester of pregnancy. It is also important in the second trimester of pregnancy. The importance of thyroxine replacement therapy is not as important as it is in first trimester, in third trimester, because the thyroid hormone production by the fetus has already started. But it is very, very important to give adequate replacement during the first trimester and the second trimester of pregnancy. So regular laboratory follow-up is essential to maintain maternal TSH value within the trimester specific reference range, which I have already discussed, and trimester specific reference range should not be influenced by the American data, but we should follow the trimester specific reference range of the local laboratory, or if you have own laboratory, then your reference range of the pregnant woman will be the reference range for you, and then decide that whether and how you should interpret the TSH value and whether you should treat or do not treat the patient. Thank you very much for your patient listening.
Thank you, sir. Thank you very much for your nice presentation. Any questions from the audience? Sir, may I ask you a question?
Yes.
A pregnant woman who is a case of chronic atrial fibrillation not due to thyrotoxicosis, and she develops hypothyroidism, what should we do?
Same treatment modality.
Same treatment.
Same, yes.
Thank you, sir. Thank you.
Thank you.
Thank you, sir. That was a truly enriching talk. So I would request Dr. Devaditya Das, sir, to felicitate our faculties on the side dais. Sir, please. We move on to our next presentation, which is on MASLD and MASH. For this presentation, I would like to call Dr. Chandan Das, sir, to kindly come up on the stage and introduce us to our speaker. Dr. Chandan Das, sir. Okay. So we move on to our final session right now. We will have this session later. So we move on to our final session on endocrinology in pregnancy. To moderate this session, I would like to call Dr. Amata Roy Chaudhary, sir. I would like to call upon Dr. Owen Roy, sir, for the next session. on MASLD and MASH. Thank you, Amurta Roy Chaudhary sir and Devadatha sir for chairing this session.
Good afternoon, everyone. So we will be moving on to the sessions. Continuing with the session, we have Dr. Oyon Roy. He is currently the Associate Professor in the Department of Endocrinology and Metabolism, along with the HOD of the department at AIIMS, Kolani. He'll be speaking on a very pertinent topic as regards type 2 diabetes is concerned and obesity is concerned. Current pharmacotherapy of MASLD and MASH, reality of reversal. Dr. Oyon, the stage is all yours.
Yeah, thank you for the kind introduction, and at the outset I would like to thank the organizers of BDCON for inviting me to discuss a very pertinent topic here. For the last 1 week I am only discussing adipose tissue, either it is subcutaneous or it is visceral, or now I am going to discuss it on the liver. So the thing is that now we know that MSLD is not only a disease as such, I mean it is a part of so many things. If you have obesity, you will have MSLD, and if you have type 2 diabetes, your risk of having MSLD is much more. And why we are worried about MSLD and MASH is that, and why we need to reverse it, because it will lead to cirrhosis of liver, and finally it will decompensate and it will increase the mortality. So as we go along, we see what are the different therapies that are available with us and how it is being done. So first see how much MSLD is prevalent. So if you see, this is the latest prevalence data. So starting from the Africa to Latin America, where it is the highest number, if you see around 44%. And South Asia, if you come, it is around 34%. So almost more than 1/3 of us are actually having MSLD. You test or don't test, doesn't matter. So it will be there. So the same thing we are repeating here, but the most important point is that around 4 to 7% of the global population currently is living with MASH, which is the upper strata of MSLD. That means they are having the inflammation and they are at a very high risk of progression towards cirrhosis. If you see the mortality burden is significantly increased in patients with MASH. It is almost 12.6 per thousand. That is considerably higher than a person who doesn't have a MSLD or MASH. Now, the same thing, if you see the US data, that F4 stage fibrosis, that is the cirrhosis, that is from the only USA, it is almost 1.3 million to now currently it is 3.5 million. So you can imagine what is the burden of MASH along with cirrhosis that is going to happen, and all because of high metabolic influx. And some other very important risk factors, if you see, which is also important for the epidemiological things, like obesity is obviously associated with a 30% risk of MASH and around 12% risk of type 2. So if you are obese, you will have a more chance of MASH, but in East Asian and our Asian, particularly Indians, at a very lean phenotype, BMI less than 23, we can also develop MASH. So we are not immune because we have other more insulin resistance we have discussed early in the morning. So, and it is, there is a significant increase in the younger age, 18 to 34. Recently, we have done a study in less than 35 years onset of diabetes, and we have found almost 18% patients are having clinically significant fibrosis. So you see, neither young nor lean, nobody is protected from MASH. So we need a definite therapy now. This is the recent published study in the Lancet Regional Health, all pan-India spanning. You can see that the LSM, if you take more than 15, which is around probable cirrhosis, the risk is pretty high, which is around 5%. So 5% diabetes population is actually having a clinically significant liver fibrosis and this thing. So here again, the difference between diabetes versus non-diabetic. If you are having diabetes, obviously your risk is high compared to 25 to 33 to 66%. But importantly, once you enter the MASH stage, your chance of going to HCC or cirrhosis is much higher compared to a person who doesn't have diabetes. So obviously, if you have diabetes and MASH, your progression rate will be. Now, what is exactly we are meaning here, saying that we are going to reverse? What we are actually want to reverse? So if you see the natural history here, once your healthy liver means you have less than 5% of cells are laden with fat. Once you have more than 5% hepatocytes having fat, we are calling it just simple steatosis. Your liver is laden with fat. But once this same thing is generating inflammation, you have histological changes. Starting from steatosis, you have inflammation, lobular particularly, you have ballooning of the cells, and you have extracellular matrix deposition, that means fibrosis, then this is MASH. Here problem is that 15 to 20% of the MASH is going to develop cirrhosis, and 5 to 10% will have HCC, and then finally death and hospital admission because of decompensation will occur. So what we are trying to reverse this one. We are trying MASH to go to MSLD or become normal, or some compensated cirrhosis can go back also, that we'll see. But what is the dichotomy of the MASH therapeutics? Whatever therapeutics we are having now practically works in these two scenarios. There are some drugs which will improve your metabolic environment. It will improve your obesity, triglyceride, free fatty acids, diabetes. Like those are GLP-1 analogs, and there are different types of combinations, and FGF21 receptor agonist. But the other group which has a direct action on the hepatocytes, and it will modulate the hepatic adaptation. These are FXR agonist, PPAR alpha, triglyceride synthase inhibitor, and most importantly, FGF21 receptor agonist. So we are basically dealing with these two kind of drugs. Now I'll go to the next one. So what do you mean by reversing? Whenever we are doing a trial on some kind of drugs, there are, from the regulatory requirement, either you go to FDA or EMA, US or European medical associations, you need two things. That means you have to have a resolution of the steatohepatitis, and second one, you have to have no progression of the fibrosis. In the US literature, US regulatory, you need either or, but if you have a European thing, then you have to meet both them. So any drug which is showing both of these endpoints will actually be called that this is reversal. Now, how we are dealing with reversal? We are doing biopsy studies. We are MSLD patients, we are seeing how much in their biopsy, how much is the score, and we are treating with drugs, and later on we are seeing what is the reversal chances. But problem with biopsy, so what is the importance of biopsy is that the fibrosis stage that will predict the mortality best, it is actually required for the regulatory thing, and it has a decades of natural history data. We are doing biopsy for long. But now problem is that if your 1/3 of population is suffering from this disease, you cannot go on doing biopsy for everyone, no? So why? Because now problem with biopsy is that you are taking a small chunk from the liver. That is just 1 in 50,000 part of the liver, and that part may not show anything or may show reversal. So that bias is also there. If you do not have adequate pathologist, or if you do not blind properly, then your chance of reporting bias also will be there. So let's go back to the lifestyle first. What is actually happening? Does only lifestyle actually modify our fibrosis reversal can happen? This is one of the very interesting study done back in 2015, prospectively studied patients around 293. They were given a 52-week intervention for good diet and exercise prescription, simple diet and exercise prescription, and at the end of 1 year, again biopsy was taken. If you see the whole cohort here, the NAS reduction, that is the NFLD activity score, the reduction happened in 47% of patients, But if somebody has lost more than 10% of the weight, 100% of the patient had reversal. So that means still now in this era of huge amount of pharmacotherapeutics, lifestyle itself can have a huge impact in NASH. So it becomes the base or the cornerstone of the therapy, whatever we are going to discuss. But problem with lifestyle is that it has a tendency to come back. Very difficult to maintain a 5 to 7% or 10% weight loss. Okay, so this is what we can see, like very difficult to sustain weight loss. This is seen in very nicely in the STEP and SURMOUNT trial, that is in semaglutide and tirzepatide. If someone starts getting a drug, suppose semaglutide here, goes on taking, he or she will lose weight and remain here. But what happens if he or she stops here, again starts gaining weight? So lifestyle has its own challenges, right? Now, that's why the question is that we need some pharmacotherapy where the lifestyle actually is very difficult to sustain. So now you see who actually enters a MASH trial, who is the patient of MASH. Mostly it is F2 to F3 fibrosis which we see in the biopsy specimen. F0, F1 usually not taken in the trials, and F4, that means somebody who is having compensated cirrhosis. Only one trial is there till date which has shown some possibility, but majority of the large trials doesn't include all these patients. And obviously F4 if it is decompensated. So by design we are actually trying to reverse F2 and F3 and some cases F1B. Now we'll one by one see the major trials. This is the GLP-1 receptor agonist semaglutide ESSENCE trial. If you see 800 patients were actually having F2 to F3 stages, they're randomized for semaglutide or placebo, 2.4 milligram weekly semaglutide here. The first trial has reported up to 72 weeks, but remind you, this is a long trial, it will go on, and after that there is a second also will be coming. So what we have got from this trial, so at 72 weeks, the MASH reduction was, without fibrosis worsening, was 63%. But see, in placebo group also it was 34%. And also on the other hand side, the fibrosis improvement has occurred at least by one stage. That is, F3 has come to F2 or F2 has come to F1, 36% versus 22% in the placebo group. Now so to see the exact effect, actually you have to subtract the placebo from here. So this is what we can gain from this drug. So from ESSENCE trial we can see that 62 versus 34, 36 versus 22, and 32 versus 16. So at least fibrosis improvement 14% we can gain, and MASH resolution at least 28% if we subtract. However, you see the mean change in the body weight around 10.5% that has occurred in SEMA versus 2.0% in the placebo. So if we subtract this, so the placebo regressed fibrosis is actually 22%. That is actually important for all these trials, where you will see a significant proportion of the placebo actually also gets improvement. So this trial has given to the first approval of MASH specific drug, and you can see SEMA can actually reverse our progression. Now once we have a single GLP-1, nowadays we can add one GIP. Why GIP is important? Because GIP will impact directly on the adipocytes, so it will reduce the efflux of different fatty acids to the liver. So that's how it can improve the mass also. So what is the trial here? So in the Synergy NASH, the tirzepatide has been trialed, but mind you, this is a phase 2B trial. Again, 190 participants had a fibrosis of F2, F3. It was a 52-week trial. So 3 group arms were there, tirzepatide 5, 10 and 15 milligram, and the primary outcome was MASH resolution without worsening of the fibrosis. Here again, if you see, the resolution of the fibrosis actually was 44%. in the 56% in the 10 milligram and 62% in the 15 milligram group. So very good chunk, similar to semaglutide, roughly 60 milligram, 60% of reduction. But if you subtract from placebo around 28 to 30% chance of a reversal, that's a pretty good news here. What is the third drug? For large trials, the third drug which actually has received FDA approval, accelerator approval, is resmetirom. That is an THR beta agonist, so which will directly impact on your THR beta cell receptors in the hepatocytes, and that will decrease the de novo lipogenesis. So thus, this is the mechanism. So this is one of the largest trials, that is the MASTRO-NAS trial, which was done with resmetirom, that was published 1 year back. So if you see 966 participants, 3 groups were there, resmetirom 80 versus 100 versus placebo, around 320 patients. But here interesting thing is that the primary endpoint was not a single one. It's a 2 primary endpoint at the 52 week. And here population, they have included not only F2, 3, F1B also. So it has a broader patient profile compared to that one. So this is the result of the resmetirom trial, that is the MAESTRO-NAS. So from 80 milligram, if you see only NASH resolution, 25%, this is almost 30% in the 100 milligram compared to a placebo of only 10%. So the fibrosis improvement is also very significant as 25. But if you subtract, then almost 15 to 20% of fibrosis resolution we are gaining here. But there are certain nuances in resmetirom. Resmetirom doesn't alter body weight or insulin sensitivity. So this changes, reversal of the fibrosis is not dependent on the weight. Okay, and simultaneously it will reduce the LDL levels, so the atherogenic dyslipidemia also goes down. Another interesting thing is that beyond biopsy, now our extension of the MASTRO-NAS is going on for 240 weeks. That is the MASTRO-NAS outcome trial will be coming in few years. So here actually, not only biopsy, we are seeing how the FIB4 and also the VCTE, that is commonly known as FibroScan, is doing. So from biopsy to non-invasive markers also, MASTRO-NAS will give some answer. So can it be a better option for lean patients, those who are obese, not obese? Actually yes, because it is weight neutral and doesn't have any impact on the weight as such. So if you see lean, what I was discussing, lean NASH or lean MASH actually is common whenever where BMI is less than 23, but actually some of the things like patient having central obesity, visceral obesity, and some of the PNPLA3 gene polymorphism if they are having. So here resmetirom can be a very good drug in lean MASH followed by semaglutide. Sorry. So can you add glucagon with GLP-1 and see how is the response? Again, we have one drug called survodutide, where again the same thing. If you add glucagon and GLP-1 receptor compared to placebo, you have a MASH improvement of around 62% compared to placebo. See here also another 30% good reduction, actually reversal can happen. These are some of the just summary of some of the trials. I just want to put a note here on the metabolic surgery also, because all these GLP-1, GIP, everything has come after the metabolic surgery. Once after bariatric surgery, we have seen the GLP-1 levels gone up, then only using them as therapeutics, that idea has come. So if you see, if you do a Roux-en-Y in a RCT of 285 patients, the improvement was significant, 37% more than 1 fibrosis score, and 56% in the MASH resolution has already there. So if someone who is fitting for metabolic surgery criteria, definitely that should be also taken care. This is the summary statistics. If you see a recent meta-analysis published in JCEA, here it is, the first one is all drugs have been combined. That I don't like actually this design. You cannot combine all of this because their mechanism is different. But anyway, nevertheless, we'll go by this evidence. If you see, the factors that favors GLP-1 receptor agonist is strong. So here you have, this is, mind you, this is on liver fat content. So definitely it will reduce the liver fat content. But if you go, only 5 drugs has been used for the liver histology part. Here also different type of things are there. I mean, you have improvement here in the steatosis improvement, but some improvement overall in the hepatocyte ballooning, but other two, there may not be. But there is a problem, inherent problem with this kind of meta-analysis, which I usually don't want to go. So coming back to saroglitazar, which is actually used, the biopsy data of the saroglitazar is actually undergoing, trial is undergoing. So right now we cannot comment on whether it will improve or reverse. So I'll skip the other slides. Only thing I want to show this one also. This is also one of the largest studies that has done in compensated cirrhosis. That is through efruxifermin, that is one FGF21 analog, which actually has shown, actually it failed actually to show the primary endpoint. So right now we do not have enough data from this symmetry trial to show that compensatory cirrhosis actually can be reversed, but future trials. So this is the landscape of the therapy. I'll skip that. So what will be the take home from my talk is currently definitely we are in the pathway to reverse MASH and MSLD with so many good drugs, but lifestyle remain the cornerstone. And there are 2 FDA approved medications right now. We are having semaglutide and resmetirom, and the pharmacotherapy is only for those patients who are having stage 2 or 3 fibrosis, and possibly in future F4 also some therapies will be coming, but we need to consider the metabolic bariatric surgery for the persons who are meeting the BMI criteria and other things. Thank you.
Thank you, Dr. Oyon. That was a very excellent comprehensive talk on MSLD NASH. Just I'll take one or two questions if there are any on this topic. I think it was covered very nicely, all the aspects were covered, but still if anyone has any doubt.
No questions, good.
One question from my side. When we see trials of therapeutics, pharmaceuticals in the field of MSLD or MASH, the improvement in placebo groups is actually very high. So how does that modify the effect size? What would you say? I mean, how should we judge regarding this fact?
Yeah, that's what I'm telling, like very important to see what is the placebo group. Actually in the diabetes or in the other trials, we are not seeing that much of improvement in the placebo group. Even in weight loss trials also, we are seeing only 2 to 3%. But here we are seeing a very nice improvement in the placebo group. So point number 1 is that you should always subtract how much placebo has been improved, and that much should be taken as the absolute improvement. Second point is that possibly in those trials they are monitoring and they are implementing the lifestyle disease much better in the placebo group compared to other trials.
Plus, I think the effect of lifestyle modification also is, I think, the best on liver.
Yeah, definitely. And I feel this is a monitoring issue, because in the other fields also, at least weight loss 2.5 is not expected with sema placebo if you see the trials. But here it is almost, the weight loss is remaining 3 to 4%. But if you see here also, if you lose only 5% weight, your chance of reversal will be much more in here. Liver is, in that way, liver is very forgivable, I'll tell you.
Very flexible. Thank you, Dada.
Thank you.
Any question? Dr. Amartya also has.
Dr. Oyon, very nice presentation.
Thank you.
One question pertaining to the current pharmacotherapy based around GLP-1 receptor agonist. We have seen that this is one drug probably is acts like magic, not just cardiorenal benefits, but definitely improvements in MASH as well. The Essence trial has proven this, and now Wegovy is approved 2.4 milligram for the treatment of MSLD MASH. Now the question is that most of the international guidelines, the ACLD, ESL, do have laid down the FDA approved therapy as resmetirom, no other FDA approved until we had this Essence trial, as the treatment for advanced fibrosis. But when the patient develops cirrhosis, they have said that we don't have any drugs. You control diabetes with the medicines which are approved in diabetes, but they've not also even mentioned GLP-1 if you have seen if you have go through the guidelines. But again, we know that GLP-1 receptor agonists, if you go by their from the safety data we have, that they are approved in patients with mild to moderate liver disease, even compensated cirrhosis. Now, what is your take on this actually, when the patient, if the patient develops cirrhosis, would you like to, if the patient has never been on GLP-1, would you like to initiate GLP-1? Yeah. Or if the patient is already on GLP-1, patient has developed cirrhosis, would you like to continue? And if you continue, how long will you continue?
Here, problem with two fronts. First is the trial data where whatever patients they have taken, that is F2, F3 only. Second problem is that some drugs, they are now being tried. GLP-1, there is trial going on semaglutide on F4 patients actually. So once that trial results comes out, like Mastronas, resmetirom, same thing is going on in a subset of population of F4. So I think another 1 or 2 years, we will have very hard evidence whether semaglutide or resmetirom, they will have impact on the F4 or not. Then we can jollibly use, but as of now it is not recommended. I won't recommend if somebody is developing compensated cirrhosis, because you can see the FGF22 or analog trial, that one also, like it's a negative one. There is no difference in the, there is no reversal as such. So for other indications it may go on, but for reversal purpose it's a no as of now.
Hello.
Thank you.
Actually, to comment on what Owen has said, I continue using semaglutide in compensated cirrhosis, even in decompensated cirrhosis, but because I don't think it is contraindicated in cirrhosis.
No.
What is that you don't, probably you are not sure whether you would get the hepatic benefits with semaglutide. But the other benefits, the glycemic benefits, the body weight benefits, they, maybe the cardiovascular benefits, they persist. So I think because there is some sort of an idea that is, suppose it is contraindicated in cirrhosis, it's not so.
No.
Probably you won't be getting the benefits.
There is no role in reversal, which is the topic, but definitely other things benefit will be, no issues.
Yes. Thank you for your comment, Sengupta sir. I think he has made the right comment. Even in mild to moderate, as the safety data of the semaglutide exists, it is safe to be used in mild to moderate patients with cirrhosis. But you are also absolutely correct. We don't have hard evidence how much hepatic benefit this is going to give in the long-term future. With this, I think we can end the session. And
thank you.
Thank you, Ananda. It was a very good talk. I think he deserves a standing ovation. And with that, we will move on to the next talk. Before we move on, we would like to invite Dr. Arpan Roy Chaudhary, consultant physician, very seasoned physician in the region, to join us as the chairperson as we welcome the next speaker, Dr. Uttiyo Gupta. Dr. Uttiyo is currently working as a consultant in medical super specialty hospitals, and he has done his training from All India Institute of Medical Science in New Delhi, and I hope that we will cherish his deliberation on muscle preservation with weight loss, the existing strategies.
Thank you. Good afternoon, everyone, and thanks for the kind introduction. At the outset, I would like to thank team BDCON for inviting me today. As the topic is introduced, it is a very relevant one, especially in the era of GLP-1. That is muscle preservation with weight loss. What should be the existing strategies? So we will discuss a very brief overview of skeletal muscle changes that occur with obesity. What are the body composition changes that happens with weight loss and incretin based therapy, obviously. Muscle preservation during weight loss therapy, what are the measures that can be taken, followed by conclusion. So we know that skeletal muscle accounts for approximately 40% of the total body mass, and skeletal muscle mass and function both are important for metabolic regulation and cardiovascular health. It is a major insulin dependent tissue that is responsible for glucose disposal, accounting for 70% of the glucose uptake in postprandial state, and obesity and insulin resistance primarily disrupt the skeletal muscle metabolism and function. This is how insulin acts on skeletal muscle. When insulin binds with its receptor, there is translocation of GLUT4 from storage vesicle to membrane. That's why glucose enters into the cell. It is a source of energy. Also, when insulin acts, it acts on mitochondria where lactate and succinate acts as a substrate for Krebs cycle. It generates ATP and that causes insulin-mediated protein synthesis in muscle. Also, by virtue of HIF-1 alpha and nitric oxide, it causes neovascularization. There is more supply of oxygen and nutrients to muscle, which maintains the muscle health, and insulin has an anabolic role on muscle health. The reverse happens with insulin resistance, obviously. And in obesity also, before understanding the mechanism, there are two types of muscle fiber. We know type 1 and type 2 muscle fiber. Type 1 is a slow twitch fiber. It contracts muscle slowly. It is more resistant to fatigue because it's contained mitochondria, more amount of mitochondria is there. And it is also very insulin sensitive and beta oxidation of fatty acids takes place. Whereas type 2X muscle fiber are primarily glycolytic and it prone to fatigue. When you are having obesity, there is alteration of the ratio, less type 1 and more type 2 muscle fiber. So muscle becomes less responsive to insulin, and due to this insulin resistance, there are more accumulation of inflammatory cells, more fats into the muscle that gives rise to muscular dysfunction. From here, if you lose weight, the process reverses, but if you lose weight rapidly, that rapid weight loss causes, along with fat loss, there is loss on muscle also that gives rise to sarcopenia. So, aging, obesity, mitochondrial dysfunction, low physical activity, everything leads to muscle fat accumulation or myosteatosis. There is fat accumulation around the muscle fibers and in the myocytes that causes insulin resistance, inflammation, impaired contractility, giving rise to metabolic syndrome and sarcopenia. This is the current operation definition of sarcopenia. I am not narrating completely, but we need to understand is sarcopenia doesn't mean only loss of muscle mass. Rather, in the current European Working Group definition, loss of muscle strength is given the most priority, which can be measured by either hand grip strength or chair stand time, along with low muscle mass, that is appendicular lean muscle mass by height ratio, and the severity can be assessed by poor physical performance by term of gait speed, time up and go test, short physical performance, battery, etc. Sarcopenic obesity is co-occurrence of sarcopenia plus obesity, so loss of muscle mass with excess adipose tissue, and this synergistic effects leads to greater disability than either condition alone. And prevalence increases with age, and 15% prevalence over 65 years of age. Now what happens if we introduce GLP-1? We know that primary action of GLP-1 is it inhibits gastric emptying and it promotes satiety. Now insulin and IGF-1, it causes, we have seen the mechanism, increased protein synthesis mediated by mTOR signaling pathway. Though GLP-1 causes increased insulin sensitivity, but at energy restricted or in calorie deficit state, this signaling mechanism is impaired, which leads to less protein synthesis. And also by compensatory mechanism, hypercortisolemia can cause increased proteolysis as well, causing loss of muscle fiber. So this is a brief overview what happens with muscle with excess adiposity and in calorie deprived state when we use GLP-1. Now we need to understand briefly what are the body composition changes, because this fat-free mass, lean fat mass or muscle mass, in trials these terms are used interchangeably, but these are not exactly same. Fat mass and fat-free mass, both these constitute the body mass, but lean soft tissue mass is fat-free mass minus the bone content. So fat-free mass and lean soft tissue mass is not the exactly same thing, and muscle constitute roughly 50% of the lean soft tissue. So fat-free mass, lean soft tissue mass and muscle mass, these three things are different. That we need to understand. And what happens during calorie restriction, fat-free muscle loss typically accounts for 20 to 30% of total loss. As fat is lost, definitely proportional amount of fat-free mass also should be reduced, but not all fat-free mass or lean soft tissue mass is attributed to skeletal muscle loss. This is most important, and some reductions may reflect a decline in extracellular fluid and organ size. In incretin-based therapy, it is seen that patients reported improvements rather than deterioration in physical function. So as you see, there is age-related decline in muscle strength and capacity, and when along with 7% weight loss, you introduce some form of exercise, there is preservation of muscle strength. This is a brief overview of different weight loss that is appreciated with different GLP-1 molecules. Semaglutide around 15%, tirzepatide around 21%, and retatrutide around 24% of the weight loss they have achieved. In step 1 trial, that is with semaglutide in obese patients, it is seen that semaglutide 72 weeks, it leads to around whatever the total weight reduction was, 40% worth of the total weight reduction is due to loss of lean tissue mass, and the absolute difference was around 13% from baseline. And in SURMOUNT-1 trial, which included tirzepatide, here also at 52 weeks, the approximate loss of lean tissue mass from baseline was around 10%. Now, if we put this data about the estimated decline over 1 year, this is the picture what we get, around 10 or around 8% loss with semaglutide and tirzepatide about lean mass approximately over a 1 year period, which is significant, which is around a decade of lean tissue mass loss in a normal person with aging. So, and now if we go into the depth of this tirzepatide data, we can see that 23 kgs of weight loss was there, 17 kg due to fat loss, and 6 kgs are due to fat-free mass loss. But if we look into the left-hand side, after tirzepatide, the proportion of fat loss was far more. And if we compare the proportion of fat to non-fat mass, it is increased in tirzepatide group during follow-up. In a SEMA-lean study with semaglutide, where body weight, body composition by DEXA and resting energy expenditure was measured, you can see the body weight declined over time as expected. There was decline in fat mass, visceral fat mass, but the lean mass, after initial decline, it stabilized over time, and there is increased in hand grip strength during follow-up. And so they concluded that with 2.4 milligram semaglutide with weight loss, there was reduction in fat mass, but improvement in muscle function with preserved lean mass and metabolic efficiency. Also, in the post-hoc analysis of SURPASS-3 MRI trial with tirzepatide, where tirzepatide was compared with degludec insulin, here there was decline in muscle volume, but that was at par with change in body weight, whereas decline in fat infiltration was far more in comparison to body weight decline, which suggests adaptive response to weight reduction in muscle volume and potential positive effect on muscle fat infiltration. So the basic is around 40% of the total reduction in body weight is due to reduction in lean mass, which appears proportional to overall weight reduction. Greatest reduction occurs during the initial 3 to 6 months period. Definitely there should be muscle loss, which is accounted of a part of reduced lean muscle mass. But at the same time, incretin-based therapy has beneficial effect on muscle structure and functions, and we need to long-term data also. So understanding this, what are the muscle preservation strategies that we can undertake when we are undergoing weight loss therapy? This is the comprehensive obesity management with incretin mimetic drugs. Our primary goal is to reduce adiposity, to reduce obesity-related complications, at the same time to preserve muscle mass as much as possible, and nutritional therapy and physical activity are the cornerstone of management. But the most important message is whenever we are prescribing any weight loss therapy, just don't blindly prescribe the drug. We should go for a medical and nutritional screening and assessment at the initial visit. This is extremely important. A proper history of what are the onset, what are the pattern of weight gain, whether any issues like any GI disturbance, any eating disorder, suicidal thoughts, any history of any sarcopenia, those things are present or not. A comprehensive physical examination about the baseline muscle mass or whether there is sarcopenia that is existing previously. A detailed dietary history and lifestyle disorder, lifestyle behaviors. This should be undertaken at the initial visit. You can test muscle strength by the simple hand dynamometry or chair stand test as it is mentioned here. Or you can assess physical performance of a patient at baseline by usual gait speed or time up and go test, where a series of functionally relevant tasks is asked to do for the patient, to rising up from chair, to walk a certain distance, turn back and again coming back. Now the key elements of nutritional priorities to support GLP-1 therapy, our approach should be a pragmatic. We should take into account each of component when we are prescribing a weight reduction therapy. And we should, it is very, very important to go for a nutritional assessment and to take help of a proper nutritionist, or you should, in other way, you should counsel your patients about proper diet. We should encourage to consume the nutrient-rich foods, that is fruits, vegetables, lean protein, dairy products, etc., and proper eating habits, that is extremely important. Physical activity will come. Nutrition, most studies have shown the recommended daily allowance of protein intake is around 0.8 to 1 gram per kg per day. But when you are going for weight reduction therapy, we need extra protein. It should be 1.2 to 1.6 gram per kg per day. And this is very, very important because in our context, in Asian or Indian setting, it is predominantly carbohydrate-rich diet and protein content is extremely low. And more so if the person is vegetarian. So you need to ensure protein intake before you are prescribing a GLP-1 molecule for weight loss. This is a very important message, and for that you need to take help of your nutritionist. Diet should contain proper amino acid, essential amino acids should be there like leucine, etc. And the micronutrients should be fulfilled when you are prescribing your diet. Studies have shown that amino acid supplementation may support the maintenance of lean body mass during weight loss, particularly under conditions of low protein intake or in conjunction with exercise. When your patient cannot take proper adequate protein due to GI side effects or aversion of foods, then only you may try protein supplement. Again, take help of your nutritionist. There are studies which have mentioned that gut microbes may have a role in muscle function as well, muscle health as well. Firmicutes, Bacteroides, Acinetobacter, these Actinobacter, these are healthy microbes that is associated with anabolic state of the muscle, vis-a-vis unhealthy microbes are there with catabolic state. Next is exercise. Here also it is very important to know that there are two types of exercise, usually endurance training, by which we mean the aerobic exercise that we prescribe to our diabetic patients. It is predominant the aerobic exercise, swimming, cycling, jogging, or some degree of like squats, push-ups that is there. But these maintain your muscle strength, or this preserve your, this will help you to lose weight. These have positive effect on muscle, no doubt about that. But when you want to improve the muscle strength and want to preserve the muscle mass, we should go for resistance training, what we seldom prescribe to our patients when we are prescribing an incretin molecule. Resistance training, we all know when muscle contracts against a weight or against a resistance, that is called resistance training, that should be there when we want to build up the muscle mass. And as you can see, when a resistance training is incorporated in a calorie restricted state, though the fat mass reduction is comparable, but the difference in lean mass is absolute 1 kg difference in lean mass that is seen in this meta-analysis. when you are discontinuing a GLP-1 molecule, we know there is a chance of 60% weight regain or rebound weight gain. If we are doing resistance training and proper exercise, the regain can be cut down to as low as 10%. And we also know, as Dr. Awan has said, that during muscle weight regain, the predominantly what comes back is fat tissue. Here also you can cut down the fat gain to a significant extent with exercise. And when coming to preserving the lean muscle mass, there is a 15% difference with exercise group versus no exercise group when we are discontinuing an incretin molecule. So this is extremely important. Regarding exercise resistance training, this is a simplified guideline. You should prescribe at least 2 to 3 sessions per week. Each session should be of at least 60 minutes duration. In particular, each session, we can incorporate 6 to 8 exercises per session, which should be divided into upper limb and upper extremity and lower extremity muscles in equally, and approximately in each exercise category, 3 sets should be performed with 6 to 12 repetitions. So this is a brief guideline how we should prescribe or to start resistance training to our patients, and gradually we should build up the frequency, the volume, exercise intensity, both can be increased gradually over time. Regarding the pharmacological part, it is mostly in pipeline. We know that activin or myostatin and activin, these molecules belongs to TGF beta family, acts on activin receptor 2, which has a detrimental effect on the muscle protein content. And this bimagrumab, which is a dual monoclonal antibody against activin receptor 2, they modify body composition alone and during weight loss with GLP-1 agonist therapy. Here it was bimagrumab was compared with semaglutide alone and also in combination, and you can see daily treatment with obese mice with semaglutide decreased body weight. That includes significant decrease in both muscle and fat mass, but bimagrumab induced a 10% increase in lean muscle mass, and when it combined with semaglutide, that is combination of bimagrumab with semaglutide, that led to superior fat mass loss while simultaneously preserving lean mass despite reduced food intake. So it has a definite positive effect on lean mass. These are the pharmacological options mostly under pipeline. Regarding that options that can increase your muscle mass, activin receptor antagonist like bimagrumab, trevogrumab, or myostatin inhibitors, myostatin targeted antibodies, etc. mostly are in the trial phase, yet to be approved, but in future probably we will see some of these medicines in our practice also. So to conclude, obesity adversely impacts musculoskeletal health. The pronounced weight loss induced by GLP-1 receptor agonist or GLP-GIP dual agonist may be accompanied by a proportional reduction in lean muscle mass and skeletal muscle mass. It is not blind loss of skeletal muscle mass. The two key principles still exist for now for preserving muscle mass are definitely number 1, ensuring adequate intake of protein and other nutrients, and 2 is incorporating physical activity, specifically resistance training. So the message is adequate protein intake and proper resistance training that should be incorporated, and emerging supporting pharmacotherapy into treatment protocols may help to preserve muscular integrity and physical function. So thank you everyone for patient hearing. Thank you.
Thank you, Uttaya. I think that was an excellent talk, a very pertinent clinical topic, especially we start on semaglutide but often forgot about the muscle activity. Thanks for clearing that concept. We'll take 1 or 2 questions if anyone has any pertinent to this talk. Any doubts or any questions? I think sir has one. Yeah.
If a obese patient comes to you, how long will you will we give lifestyle modification like exercise and dieting to start GLP-1?
Very good question, sir. Actually, basically what we do in our day-to-day clinical practice, when a patient comes to us with an attempt to reduce weight loss, in the first visit, we assess the number one, we do the clinical assessment. We prescribe at least the necessary medical workup, because I feel a basic metabolic workup should be there. As per the obesity guidelines, the LFT, lipid profile, blood sugar, blood pressure, BMI, waist circumference, these parameters we should record at baseline. Next, we ask them to go for a proper diet exercise first, to have a proper nutritional counseling with adequate protein intake, because we are planning to start something, and to start proper exercise. And in the second visit, if patient ensures all these domain, then we prescribe the molecule, incretin molecule in the second visit. Because otherwise, patients with energetically start the molecule, be it tirzepatide or semaglutide, not very compliant about diet. So ultimately the weight loss is not that fruitful. Or when a patient is vigorously restricting calories and taking some incretin molecules, he or she will end up with losing the muscle content as well, and look cachectic. So it is very important, and that is, I think, the whole idea of this talk is to ensure proper nutrition. Because if we go into our day-to-day clinical diet, for an example, 100 gram of lentils, it contains around 15 gram of protein. Boiled egg, it is around 6 gram. So you appreciate it is very, very difficult to ensure 1.5 to 1.6 gram per kg per day protein, to ensure it in our Indian context. And for that, it is very important to ensure a proper nutritional counseling, and subsequently we ask our patient, gradually encourage them to do resistance training also, because that is also the message. Because when we are attempting weight loss, we try to do the cardio part, which is definitely necessary, but if we are on incretin molecules, you should do some resistance exercise as well.
But our patients are very non-compliant.
Yes, sir, that is the basic problem.
They prefer to take medicines or injections rather than lifestyle modifications.
Yes, sir. That's why we tell them that this is a molecule. You are spending a lot of money practically. You are going to spend a lot of money, so it should be worth. And to make it worth, that is, I counsel them in that way, that to make it worth, you should start with proper lifestyle modification, because otherwise, I think whatever you are paying, that may be wasted, because this is not a magic drug anyway.
Thank you. Thank you. So with that, I think we come to the end of the session. Please give it up for Dr. Utya Gupta. Big round of applause would be appreciated. Thank you. And with that, we come to the end of this session, and we'll move on to the last two topics of the next session, endocrinology and pregnancy. And for that, I think
sir, I would request Utya sir to be on stage and I would also request Arun sir to join him for a group photograph. I would request Rajesh Maji sir to felicitate our Arun sir and Utya sir on the side dais. Moving on to our last session, I would request Amarda sir to moderate our final session and introduce us to our chairperson and speakers.
So we move on to the last session of this wonderful conference, BDCON 2026. For this, I would like to invite the chairperson for the session, Dr. Shobhik Roy sir, retired HOD Medicine in charge and director of Durgapur Steel Plant Hospital. Dr. Vinit Kumar is here. Dr. Vinit, yeah. Dr. Vinit Kumar, physician and diabetologist, Durgapur. And Dr. Abhijit Das, Dr. Chandan Das. I would request Dr. Arpan Chaudhary to please stay on the stage. And it doesn't matter. So I'd now hand it over to the chairperson to invite the speakers for the last session. We have a very interesting session on endocrinology and pregnancy with lot of practical implications. The first talk, I think, will be by Dr. Shayan Ghosh, GDM. Shobita, please.
May I now request Dr. Shayan Ghosh to speak on early gestational diabetes mellitus, to treat or not to treat.
Hello. Good afternoon all, and thanks the BDCON team for inviting me. The topic is very interesting, that is gestational diabetes mellitus, but early gestational diabetes mellitus, whether it's to treat or not to treat. We know that nowadays there is in the era of these metabolic dysfunctions and the changing lifestyle habit, the obesity, overweight and the different metabolic diseases are emerging day by day. So it affects the pregnancy also. So nowadays it is already a time to shift from the focus of a time of a GDM screening from GDM timing, that is a 24 to 28 week of gestation, to the before time from the start of the pregnancy, where also we can screen the patient to detect the early onset of dysglycemia or the earlier stages of glucose intolerance in the pregnancy. So there is a huge epidemiological shift, and the Indian prevalence is also very much significant. We know that 15% of the pregnancy in the urban India are affected by some form of hyperglycemia. Now early versus late GDM, usually the GDM we know that is a 24 to 28 weeks of gestation, but early GDM that is diagnosed before 24 weeks of gestation, in some cases is less than 20 weeks of gestations. Now whether to screen in this particular group, and if it is screened positive, then whether to intervene in this particular stage. That is the area of debate nowadays. There is no hardcore evidences or any proper guideline behind that. So there is a screening gap. So whether to screen during the GDM timing, that is 24 to 28, or to the earlier stage, so that is a major concern. So this gap is very much important from the onset of conception to the standard GDM screening timing. So the most important is the less than 20 weeks. This time is very much important for the early GDM screening, and there is no definitive diagnostic test is there as per the guideline recommendation, because there is no hardcore recommendation with for early GDM, but we can do a fasting plasma glucose level, HbA1c, or early 75 gram oral glucose tolerance test. So fasting as per the standard IAD PSG, the derived criteria, it is more than equals to 95 milligram per DL, or HbA1c is 5.7 to 6.4%, so that is just a pre-diabetes range in the non-pregnant individual, and early 75 gram oral glucose tolerance test is more than 140 as per the non-pregnant the individual. So the unique dilemma is that whether to treat or not. So what's the benefit of treatment? What are the drawback of treatment? So pro-treatment, the key concern is that the detection of the earlier onset dysglycemia can affect the fetal or maternal outcome in short term and in long term. That is very much important. Whether the mild level dysglycemia can affect the fetal macrosomia, the maternal hypertensions and neonatal hypoglycemia, etc. And if it is there, then if we treat this particular the group of the patient, then it can minimize the immediate or long-term morbidity. Or whether to go for a conservative approach, no intervention. So here, because the point behind is that it ultimately increases patient anxiety, leveling as diabetes, more unnecessary insulin usage from very beginning. So to avoid over medicalization of a healthy pregnancy. So what the evidence said, if there is need for a proper RCT validation, but there is very much lack in the proper randomized control trial. So standardized care for the high risk cohort, that is very much important nowadays. So untreated early hyperglycemia, there may be a multiple risks. The congenital anomalies may be increases. There is increased incidence of congenital anomalies is already there. These 2 times higher risks of a structural defect, particularly cardiac and the neural tube dysfunction. Placental dysfunction, the early insulin resistance disrupt the placental vascularization leading to increased incidence of the preeclampsia or the hypertensive disorder. Number 3 is the metabolic priming. That is very much important, that exposure to the high glucose level early in gestation primes the fetal pancreas. The fetal beta cell is very much sensitive to this maternal glucose level from very beginning. It is near about 12 to 16 weeks of gestations. So if the mother blood glucose level is to some extent in the higher level, it is ultimately primes the fetal pancreas, and that ultimately leads to in future the chances of the childhood obesity and the metabolic diseases of the child in future. Next is the legacy effect. If we doesn't treat this particular group, ultimately in the latter half of the pregnancy it will be very much difficult to control the blood glucose level if these early GDM convert to the GDM. Now, as per the HAPO, that is, we know the hyperglycemia in advanced pregnancy outcome, this HAPO study shows a linear relationship that goes in favor of the treatment of a mild, even a mild episode of dysglycemia, because it is a continuous linear relationship. So there is no fixed cutoff that above the cutoff we need treatment, below the cutoff we doesn't need treatment. So there is no such hardcore cutoff. Even there is lower blood glucose level, lower incidence, and higher blood glucose level, higher the adverse incidence. So even a mild dysglycemia can affect. Now, to framing this debate to go for the treatment and against the treatment, we have to keep in our mind different points that in favor of treatment, what are the neonatal outcome, maternal outcome, cost and resource uses, or is there any chances of over-treatment harm or not. But if there is a delayed treatment or conservative approach, there is also any changes in the neonatal outcome, maternal outcome, cost and resource uses, or is there any missed early window risks or not. So the case for the early treatment, whether to treat early, goes in favor, that the HAPO data goes in favor of this early treatment. And also if we treat early, it will give some longer optimization window. If we start any medicine from very beginning, so titration will be very much easier and we can get a time during pregnancy. And NICU resource reduction is also minimizes. So cost of the cost in future, NICU admission cost or NICU cost will be reduced if we treat it from very beginning. And it can also unmask the pre-existing diabetes or pre-diabetes in a patient when the pregnant female was non-pregnant. So even at that point there may be undiagnosed diabetes that can be unmasked if we screen from very beginning. And as per the Indian context, as per the DIPSI guideline, they have also specifically mentioned that even universal screening is mandatory when a pregnant patient comes to us. The first visit we should screen for this particular patient for diabetes or pre-diabetes, and if the patient comes late, then also the single point testing is mandatory. Now, case against early treatment, the goes in favor, that is against the early treatment, is the modest RCT benefit. The TOBO-GM trial, the benefit in the primary endpoint only, there is no benefit shown in the secondary endpoint of the TOBO-GM, I am coming later. So the modest RCT benefit has been shown. There may be chances of the overdiagnosis or over-medicalization. The systemic review, there is no such broad signal, or there is not in support of the early treatment. And guideline also stay cautious because different guidelines said the different things as per the early GDM treatment. Even the ADA 2020-26, they have told that 1/3 of the early GDM spontaneously normalizes with increasing duration of pregnancy. And only the 2/3 portion can convert to the GDM. So if we treat the whole population of the early GDM, the 1/3 population may not need treatment in this particular perspective. So we need to prioritize the scenario, prioritize the cases, that particular cases we should need to treat or particular cases we shouldn't do any intervention. So there is the only RCT, randomized controlled trial, in this early gestational diabetes mellitus group, that is a TOBO-GM, that is treatment of booking gestational diabetes mellitus, that provides the definitive evidence, and it mainly includes the participants of 18 years and above with high risk feature. High risk feature means the patient with the history of prior GDM, the BMI more than 30, first degree relative with diabetes, age 40 years or above, previous macrosomia, polycystic ovarian syndrome, and non-European ancestry, etc. And they have checked for the neonatal respiratory distress, the incidence of the NICU admissions, birth trauma, etc. And as the primary outcome, they have the pregnancy loss or stillbirth, birth trauma, shoulder dystocia, respiratory distress, phototherapy requirement, neonatal death, or birth weight of more than 4,500 gram. So in this regard, they have shown the incidence of the primary endpoint. There is significant difference if we give the treatment from very beginning. But in the other secondary outcome, they have failed to show any significant benefit of early treatment. But in the cost effectiveness trial, the analysis of this TOBO-GM trial, they have shown a significant, the reduction in the cost of the NICU admissions has been shown if we treat from very beginning. But in the other aspect, there is no such differences has been observed as per the TOBO-GM trial. Now going to the Indian scenario where what the DIPSI guideline told us, I'm already told they have told regarding the universal screening, all pregnant females would be screened at the first visit with a 75 gram oral glucose tolerance test. That is a non-fasting, can be done in the non-fasting state also. Single time testing is sufficient. And the repeat testing, if the initial screening is negative, then we should do a repeat testing at 24 to 28 weeks of gestation. If the test is more than 140, then it is diagnosed as patient is having GDM or early GDM. And then the further, the criteria for the doing any interventions. So this is as per the DIPSI criteria. If it is more than 200, then it is diabetes. More than 140, then it is GDM. And more than equals to 120, they have mentioned the term that is decreased gestational glucose tolerance. So the treatment, if to see there is a blood glucose in the post-OGTT, it is more than 140. We obviously do the lifestyle modification in these particular cases because on the side of this medical nutrition therapy and the primary intervention, and also if the medical nutrition therapy fails to control the blood glucose level, then we go for the interventions like the insulin, that is the topmost priority, and the plus minus metformin therapy. So screening stratification. So as there is a debatable situation because the different guidelines was different scenario and the RCTs also doesn't in 100% they recommend any the 100% cases should be treated. So we should prioritize some cases. Some high risk patient we should screen and treat. So according to the risk, the category, the tier 1, the highest priority should be in the history of gestational diabetes mellitus, BMI more than equal 30 or PCOS. Those particular group require immediate treatment or aggressive glycemic management. Tier 2 cases, the moderate priority cases, the family history of diabetes or advanced maternal age. Tier 3, the patient with a borderline initial test and monitor with a periodic SMBG before 24 weeks of this full screen. And this outcome goal, the goal is to prevent the progression to the overt diabetes and reduce the risks of this large for gestational age. The benefit of treating is not only the during pregnancy or the short-term outcome is not only that, it also protects the mother from in future development of type 2 diabetes also. It also reduces the chances of the childhood obesity and the metabolic dysfunction in future, and the postpartum screening should be done in this particular group of the people or the pregnant woman after childbirth, and the lifetime legacy is also there because the pregnancy dietary habit often translate into the permanent healthy family lifestyle habit. So clinical decision making is very much important. As per the Indian, the DIPSI guideline, the universal screening may be done, and if there is any signs of this GDM or early GDM diagnosis means more than 140, then immediate medical nutrition therapy is very much essential. And if it is blood glucose level is not within target, then pharmacotherapy is requirement, and ultrasound screening is obviously necessary to see any fetal macrosomia or not. So this is a systemic review. They have it also failed to show any 100% the proof for pro-treatment of early GDM. In some aspect, it shows some benefit, like in composite neonatal morbidity and in cases of the NICU admission, etc., but in the other cases, they fail to show any benefit. Now, as a whole, the guideline landscape, different guideline, in SEOG guideline, they also prioritize the patient. Only risk factor positive women should be screened and treatment in early GDM stage. WHO already also they have shown the limited specific early GDM guidance, and IRDPSG also proposed only OGDT criteria for the research consideration. Now, as per the recent ADA guideline, the ADA 2020-26, they have specifically mentioned in this year that is before 15 weeks of gestation, screen for abnormal glucose metabolism to detect this early GDM and identify the individual who at a higher risk for adverse pregnancy or neonatal outcome or at a high risk for later gestational diabetes mellitus. So, but they have specifically mentioned therefore the benefits of the early abnormal glucose metabolism remains uncertain, and nutritional counseling, periodic testing is mandatory, and if there is any increment in the blood glucose level, we should go for the treatment, or in very specific high risk group, we can go for the interventions. Now, as per the DIPSI flowchart I have already told, they are mentioning the universal screening. If positive, go for management as per the GDM the criteria, and if it is negative, retesting as per during the GDM recommended period. So prioritizing the early intervention to secure the maternal health, the universal screening, the evidence is clear that treating GDM before 24 weeks protect against the neonatal respiratory distress, but there is a lack of the guideline recommendation. If we intervene, the lifestyle is the first, and then the pharmacotherapy, and long-term vision use GDM diagnosis as a catalyst for lifelong metabolic health improvement for the long term, for both mother and the fetus also. So to conclude that early GDM is increasingly being detected, but the diagnosis is very much controversial because in an early stage, if the blood glucose level is high, it may be a undetected previous diabetes also, or early GDM. This is a very much controversial area, and the rationale for treatment is very much strong. We should treat because theoretically it can give the benefit, and in some RCTs and in the other studies they can prove the benefit in the fetal or near maternal outcome. But evidences for routine early treatment is still mixed. Some says yes, some says no. Potential benefits should not be ignored. We shouldn't miss any chances if we can detect this early GDM. But we should keep in our mind the over-treatment obviously is a concern, and current practical approach is should individualized management as per the risk factor priority. We should separate the patient on this risk basis, and then we should do a treatment goal. So early GDM should not be ignored, but whether early woman diagnosed before 20 weeks requires an intensive therapy remains an area of ongoing debate. So personalized risk-based management is currently the most balanced approach. Thank you. Thank you.
Thank you, Dr. Sayan, for this wonderful presentation. Do we have any questions from the audience?
I think
no questions. Thank you, sir. So we will call upon the next speaker. Okay. Thank you, sir. Next speaker, Dr. Satyam Chakravarti, and the topic is glycemic monitoring in pregnancy. Dr. Satyam Chakravarti is an endocrinologist in Fortis Multi-Speciality Hospital from Kolkata. Sir, all over to you.
So probably I am the guardian of this wonderful conference. So I think I should spend a moment to thank all the organizers of this wonderful BDCON 2026, and please give a round of applause for all the organizers. Thank you. So what Dr. Sayan has just shown us, it is a robust set of data as far as diabetes, early GDM in pregnancy, and it is for us to how to reciprocate and how to bring it down to clinical practice. Probably I will try to be crisp and complete it in time. So glycemic monitoring in pregnancy. So this is the background. Why should we control the blood glucose? So as far as my perspective is concerned, I will be very critical even in the early stages of GDM to keep the sugars under control. Maybe if not by any medications, at least by lifestyle modifications, by dietary recommendations, I need to keep the sugars under control, because we know that we are in a pro-dysmetabolic arena where we are functioning, most of our mothers or would-be mothers are dysmetabolic. And these are the reasons why we should be careful. If probably even prior to pregnancy, all the pregnancies need to be planned, because in today's life, it is not like that we have 5, 10 babies. Each and every pregnancy is extremely precious. So from the start, we need to plan it accordingly, because we know in the early gestational diabetes, if the blood sugars are sky high, there are fetal complications. We know of the valvular heart defects, we know of the renal problems, we know of the craniospinal problems, anomalies, which once developed, we are almost gone. Following that, we have the IUGRs, we have the short for gestational age babies. And as Dr. Shayan rightly pointed out, the problem does not stay within the pregnancy. So if there is IUD, then it is the end of the story. But suppose if there is an IUGR, basically why an IUGR develops? Because of short of nutrition. Why there is short of nutrition in a diabetic or early GDM? The reason being atherosclerosis, there may be placental infarction and the baby will not get the adequate amount of nutrition. And that is why the baby might develop IUGR. Now what happens? How the baby survives with so less nutrition? The baby survives because probably he or she undergoes epigenetic modifications in the fuel expending genes. As a result, she or he can move alongside with very low amount of fuels. But what is the end result? When this baby comes out, there is no scarcity of food. We know the Thakumas and the Thakurdas, Dadus, Didas, are bachchata to choto eke khawao, aro beshi kore khawao. Now these babies who have already have their fuel expending genes, which are modified, which are switched off, when they are in an arena, in a scenario where there is plentiful, what happens? That gives rise to childhood obesity, adolescent obesity, and young onset diabetes. So this is a vicious cycle which goes on, which is far beyond these major complications. So we need to understand that we need to be careful, if not by medications, at least by monitoring, by lifestyle modifications, even in early stage of gestational diabetes or in type 2 babies, we need to be extremely careful. So preconceptional counseling, that should be the first line of defense. Preventing the unplanned accidental pregnancies in dysmetabolic mothers, they should be shunned. Even in patients who are obese, who have high risk of developing gestational diabetes, there has to be preconceptional counseling. What I explain to my patient is something like that. Suppose you have a stretch of land at your disposal and you plan to make a beautiful flower garden. Without removing all the weeds, one fine morning you go and start watering, and then you add fertilizers, and what you do, you plant the flower plants. Will you get the flower garden? You will get only a jungle. So you will not get the desired results. So if a dysmetabolic mother suddenly becomes pregnant, it is a problem, not only for the mother but also for the baby. So a dysmetabolic obese mother, would-be mother, please ask her to lose at least 5 to 10% of body weight before planning conception. And then if the patient happens to be a diabetic, please bring the HbA1cs under at least 6 and lifestyle first. So that is the modification. Need not go for medications at the outright. Now, the overlooked partner, the male glycemic health. So it is not a work of a single hand. We have to understand that obese males, they have very poor quality of sperms also. What happens in repeated cases of miscarriages where the male counterpart is obese? If you bring down the body weight, you will get better results, because obesity and hyperglycemia impairs sperm quality, DNA integrity, and ultimately fertilization outcomes. So in such a social milieu where the female counterpart is always blamed for having bad outcomes of pregnancy, this is a point where we as physicians should come in and say that the male counterpart is equally responsible. So preconceptional counseling must be couple-centered conversation, not only maternal-only intervention. So medical optimization before conception. So we have the obese patients right now who will be on GLP-1 analogs, we know, who will be on GLP, GIPs also, patients of diabetes who are on various agents. So there has to be a washout period, discontinue unsafe agents, I won't say unsafe, which are not tested, SGLT2 inhibitors, sulfonylurea, statins, approved antenatal regimen, metformin and insulin should be initiated in them, and at least GLP, GIPs or GLPs must be stopped at least 2 months prior to attempting conception, but the patient should be advised to keep or continue with your lifestyle modifications so that you do not regain weight in these 2 months of the therapy. Thyroid status, as Dr. Anirban Majumdar rightly has given an elaborate discussion, this is non-negotiable pre-pregnancy check, because it is the maternal thyroid hormone which helps in the brain development in the early weeks of pregnancy, because the fetal thyroid hormone becomes functional after 12 weeks of pregnancy. So this is a usual screening, high-risk women before and during pregnancy. Ideally, it should be preconception. Then it should be at 8 weeks, and if the risk is high, if the patient is only doing home blood glucose and it is going high, please test again at 24 weeks. I think Dr. Shayan has already given the regimen. So dietary modifications during pregnancy, this is absolutely important. I give my patient a dietary protocol, fixed protocol, which is quite individualized depending upon the blood sugars, depending upon the body weight of the patient. And I insist on the patients that I will not tolerate any type of R&D with the diet chart which I have provided. No research development, all research development after 9 months of pregnancy. Please stick to the protocol. Please don't go for any religious fasting during this time, because it will be more dangerous than doing good to your future child. So the food quality principles: low glycemic index food preferred, adequate protein at every meal, control total caloric intake based on gestational weight gain targets, and individualized counseling. So this is a controversial area where we should, when we are checking for the blood glucose, whether we should check for the 1 hour versus what we were doing the 2 hours postprandial. Pre-meals we are always checking. So why timing matters? The postprandial monitoring dilemma. So there is no universal consensus. The postprandial monitoring is central to GDM management, yet no universal conception still exists. Now, 1 hour PPG captures peak glucose excursion, reflecting maximum carbohydrate load impact. The 2 hours reflects the return towards baseline driven by hepatic uptake and peripheral insulin action. So this is the difference. Choice of monitoring timing directly influences treatment targets, insulin initiation rates, dietary counseling, and ultimately fetal growth outcomes. So these are the current guidelines which have the 1 hour targets, which have the 2 hours targets. Now 1 hour targets have been fixed to less than 140 milligram per DL, and the 2 hours less than 120. We all know that as far as the fasting is concerned, pre-meals are concerned, the sugars should be strictly maintained in a range of around 70 to 100, and at times if it goes above 100, okay, but usually it should not pass these targets. Now in your daily clinic, if a patient continuously surpasses these targets, we have to call the patient and speak about the dietary modifications again and adjust the insulin regimen. Now, if there are single high targets, we can ask the patient what was the change which you made on that particular day, and we can make the patient aware that this should not be repeated, otherwise we might land up with complications. So this is the peak 1 hour peak excursion 2 ppg, and this is a study from India from Deep Datta and his group, which showed that if we go for the 1 hour target, there is a significant reduction in the large for gestational age babies, but others they were almost equal. Again, if we go for a stricter 1 hour target, what happens? For less than 120, there the chance of preterm deliveries probably increase. This is the chart which shows the preterm delivery. If we go for a stricter target at 1 hour, that is less than 120. So for 1 hour, it can be less than 140. For 2 hours, it can be less than 120. So practical consideration for the clinician, patient adherence, 1 hour monitoring might be more convenient. The shorter post-meal wait time reduces patient burden and is likely to improve long-term compliance with self-monitoring protocols. 1 hour PPG better guides meal composition adjustments. It more effectively identifies glycemic spikes from high glycemic index food, enabling targeted dietary modification. Insulin initiation, that's another. We need to ask the patient to titrate accordingly. The patient should be educated, and when there needs to be a change in regimen, we need to call upon the patient, because change in regimen should not be done over phone or any video counseling. So, and the resource setting, either method is clinically acceptable. Choose based on local institutional protocol, patient profile and gestational age. So structuring the blood glucose monitoring chart, initial phase, what I do is initial 2 readings per day at rotating times. For example, on the first day, patient does a fasting and 2 hours post-breakfast. The next day, pre-lunch, 2 hours post-lunch. Third day, pre-dinner, 2 hours post-dinner, or 1 hour, anything. Now, when you have stabilized the chart, a single reading every day, but you have to continue with that. So in that way, every fortnight, the patient may send you the chart and you may adjust the insulin regimen. You should not give the onus of adjustment of the insulin regimen on the patient, otherwise the patient might land up with trouble. So when the graph stabilizes, 1 reading per day and fortnightly tweaks, it can be done always. So insulin regimen adjustments during pregnancy, we know as the pregnancy goes forward, there is more of the hormones like human placental lactogen, progesterone. These are anti-insulin hormones which increase the insulin requirement of the mother. So that is why the insulin requirement increases. Initially, if the sugars were maintained with single daily premix insulin, ultimately it will be twice daily premix insulin. And when the initial doses go above 20 or 25, you need to increase the number of pricks to regular premix. And even when the single dose goes above 25 or 30 around, please go for the basal bolus regimen. So this is the review cadence. Glucose charts must be reviewed fortnightly to guide them timely dose regimen. Regimen by diabetes type. Type 1 basal bolus regimen is always preferred, and type 2 you can go for metformin with insulin depending upon the glycemic targets. So CGMS is very important in patients who have fragile diabetes, who are not adherent to lifestyle modifications. At least it may give you a therapeutic scare to the patient that if I do not follow the guidelines, the sugars are rising and it will have bad effects on my baby. So CGMS can be used. So it might reduce HbA1c. We do not do HbA1c in gestational mothers. Hypoglycemic episodes, the CGMS can help us. So fetal surveillance, the obstetric partnership, the patient should always be advised to have regular follow-ups with your obstetric partner, and an integrated care model should be there. A key surveillance tools like fetal growth scans, biophysical profile assessments, Doppler studies, and primary targets. Monitor actively for macrosomia, polyhydramnios, IUGR. These are extremely important. So gestational diabetes diagnosis and initial management, this is the usual, we usually diagnose, and what Shayan has rightly pointed out, initially and then 8 weeks, 24 to 28 weeks, we can go for that. We can go for medical nutrition therapy, that was which I was speaking, and we have studies which have shown that if in dysmetabolic mother metformin is continued, it brings down the risk of IUGRs and also IUD. So postpartum glycemic care, this is very important. Confirming resolution of GDM. GDM resolves in most women after delivery. Confirm normalization with an OGTT at 6 to 12 weeks postpartum. Do not assume resolution without testing. The long-term risk picture, women with prior GDM carry a 50 to 70% lifetime risk of developing type 2 diabetes. Long-term metabolic follow-up is not optional, it is a clinical responsibility. Breastfeeding as should be actively encouraged. It improves postpartum insulin sensitivity and is associated with a measurable reduction in future diabetes risk for the mother. So key takeaways should be, we need to start before conception, hold targets extremely rigidly, deploy CGMS where indicated, and counsel every reproductive age woman, at least, if not for medications, at least for a dietary and lifestyle approach. Thank you so much.
Thank you, sir, for your nice elaboration and nice presentation. We can take any question from the audience. If no, then thank you, sir.
I would request sir to please be on stage along with I would also invite Dr. Shayan Ghosh sir for a group photograph. Okay. So Shubham Das sir, please felicitate our faculty on the side dash. Sir, please go to the side desk for some felicitation. And with this, we come to the close. Come to the close of today's proceedings. It has been a privilege for both of us to be part of this wonderful journey of learning and exchange.
We sincerely thank Bengal Diabetic Foundation for giving us the opportunity to be the host, to be a part of this gathering that brings together such distinguished minds, ideas and experiences has been both an honor and memorable experience for both of us.
Thank you all to our distinguished faculties and delegates for making this session so enriching. From both of us, it has been an absolute pleasure to be your host. Thank you and have a wonderful evening. We have the quiz session after this.
I would like to call Dr. Bodhan Das Munshi sir for the quiz.
Okay, all the teams, please come in front. That's the first thing. So you are the audience, you are the participant. please come. So at the very outset, I would like to thank the organizers of BDCON, especially Amitabh sir, Dr. Shubham, Dr. Tarok, my seniors who have guided me always, Dr. Rakesh da, Dr. Shoshti da, over here, and a few more names are here. I cannot see them. Rajanda and Amartada were also here somewhere. So thank you all. So quickly, all of you, please come in front. Okay, there will be a lottery. We have a lot. Keep the lot here. One team member from every team. Just come up, pick the lot. First, let us get the chairs arranged. Chairs gulo arrange kore. Aage chairs. Dar ekta kagoj. Not us. Not us. আগে চেয়ারগুলো অ্যারেঞ্জ করে নিই একটু হ্যাঁ ঠিক আছে So in the audience for the quiz questions my wife has helped me a lot with some of the preparations and I would also like to thank Shomik Goswami sir whose some of the questions are his directly also so it's a mixed bag of mine and sir's questions. And we have 3 senior faculty members who are also experts, who are quizzers sitting there in the mid row. With one I have quizzed myself, with one I have quizzed against, another I have seen in action in quizzing. So all 3 are here. এইদিকে হ্যাঁ সব গোল করে এইভাবে করো গোল চক্কর করে করিয়ে দাও এগুলো আছে তো এখানে লোক বসে পড়ছে সোফাগুলোতে 5টা আছে তো এখানে 3টে লাগাও এখানে আরো 3টে লাগিয়ে দাও টোটাল 6টা লাগাও এখানে এখানে 1 2 3 লাগিয়ে দাও ক্লোজ করে দাও এটাকে ক্লোজ করো এটাকে হয়ে গেছে 5টা দল এখানে বসে যাবে 3-3 করে একটু গ্যাপ দিয়ে দাও এই 3টে একসঙ্গে ঠিক আছে ওইদিকে করে দাও আরো 9টা টিম তো আছে 5টা হলো হ্যাঁ সোফাগুলো একটু 5টা করে করে দাও সোফাগুলোর মধ্যে জায়গাটা কমিয়ে দাও এই দিকটা এদিক থেকে স্ক্রিনটা দেখতে পারে এমন হলে স্ক্রিনে না দেখতে পারে পাশে বসিয়ে দাও একটা তো একটা টিম এখানে করে দাও আরো 2টো লাগবে আরো 2টো সেট লাগবে হ্যাঁ ক্লোজ করে দেবে জাস্ট করিয়ে দিই একটু গ্যাপ দাও মানে আর এদিকে সামনে করে দেখতে পাবো এখানে আরেকটা টিমের ব্যবস্থা ঠিক আছে না ওটা তো দেখতে পাচ্ছি So I would request Rakesh and Shoshita to please come up on the stage to help me out with who is answering what and Dr. Shubham and Dr. Devaditya with the scoring or even Anish if you are here. Anish is here. Okay. So we can have the lot done. One team member from every team, 9 teams are here. So we'll just follow it randomly. 1, 2, 3, 4, 5, 6, 7, 8, 9. Is it clear? Okay. One member from each team first come. Scoring to court. Okay, one. Team 6. So 1, 2, 3, Okay, 9. So 9 will be the last one. Please come over. Next, please pick up quickly. 8. Come over here. 2, please come there. Can we have all the microphones available as much as possible over here? You can keep one table in front of each. All teams should have something to scribble. 1, কত রে 4 তো 3 4 এই একটা চেয়ার পাওয়া যাবে রিকোয়েস্ট আছে
স্যার অলরেডি গিভেন ওয়ান স্যার
হ্যাঁ
স্যার
রাউন্ড না বলছি বলে দিচ্ছি বলছি So basically all the questions, the clue to all the answers is whatever question you see on the screen will be from a topic or from the slides of the speakers in the last 2.5 days. So nothing outside the syllabus. That's the good news. Okay, so if you have attended this conference, everything will be from those slides. Nothing beyond it. The difficult part is we'll have lots of questions. So just one rule for the entire quiz which you have to remember, that is the quiz master's decision along with my team's decision is final. Anything else you want to protest, not the place for today, right? That's the one and only rule of the quiz. So we have about 42 questions. The first 18 questions will be our bounce round. It's a mixed bag quiz where I have not divided into subtopics this time. I've kept because there are lots of teams. So we'll have a bounce and pounce. For those who don't know the rule of bounce and pounce, pounce in Bengali has the mean khaba dewa, right? So suppose the question is to team 1 and the other team, some of you know the answers and are confident. You can raise your hand immediately within 5 seconds. And you have to scribble your answer. Don't tell the answer. If your written answer is correct, I will come over and check. If it is correct, I will give you the score. But in case it is incorrect, you will get a negative marks. So we'll have 18 questions, 9 teams. So 18 questions in that way. After that, we'll have 24 questions. We have lots of questions, so nothing to worry. Because we have less time, so we'll have a buzzer without a buzzer. How is the buzzer working? By the traditional show of hands. You had the election season few months back, so now is the time to raise your hands, not only because of that, but over the last 2 hours you have heard how important exercise is. So it's important to raise your hands and do some exercise even during the mental exercise which you are going to do over the next 45 to 50 minutes. Scoring for the first round. Let me just come to it. So this is just the outline of the quiz. All questions will keep it clockwise. In case you wanted to be anti-clockwise from question 10, we can do so on your request. No problems with that. First round, the only thing to remember is, suppose the question goes to them, you all pounce. The teams which don't pounce, they get to answer the question on a bounce. That is the normal passing over if the team to which the question goes to does not answer. That means team 1 got the question, they answer on the mic. 2 teams, suppose 8 and 9 have pounced, they answer it incorrectly, question goes to team 2. Then they don't answer it correctly on the mic, question goes to team 3. Suppose team 4 answers it correctly. Okay? So the next question will go to team 5. Is it clear? The second question will not directly go to team 2. The second question will go to the team after which who answers it correctly. Okay? If no one answers it correctly, it again goes back to team 1. Team 8 and 9, because they have pounced, they don't get to answer on the past question. Is it clear? Anyone having doubts with this rule? So without wasting any more time, we will move over. Score হচ্ছে Yes, absolutely. We'll be introducing each other. Mics are ready. So please introduce yourself first.
Dr. Shubham Sinha from Bardhaman Medical College.
Okay, so Bardhaman Medical College, team 1. You can introduce yourself, please. Quick.
MD Sohail Ansari from Bardhaman Medical College.
Okay, wonderful.
Dr.
Whatever the audience, huge round of applause for them, please. Just straight back. Yeah.
Dr. Anushka Bhattacharya from Bardhaman Medical College.
Dr. Tabugna Kumar Pore from IQ City Medical College.
IQ City, team 1. There are multiple IQ City teams.
Dr. Monalisha Sahu, IQ City Medical College.
Dr. Robi Roop from IQ City Medical College.
So this is IQ City 1. Team 2, but IQ City 1. Then?
Dr. Sayok Chatterjee from Health World Hospital.
Dr. Kushal from Health World Hospital.
Dr. Abhinandan from Health World Hospital.
So Health World Hospital 1, first team.
Dr. Swati Singh from Health World Hospital as well.
Dr. Anurag Banerjee from Health World Hospital.
Dr. Ronita Mukherjee from Health World Hospital.
So team 4 is Health World Hospital 2.
Dr. Pranay Srivastav from IQ City.
Dr. Ramandeep Raha from IQ City Medical College.
Dr. Amit Kalkal from IQ City.
So team 5 is IQ City 2.
Dr. Veera Balaji from Health World Hospital. Dr. Raj Mondal from Health World Hospital.
Dr. Prabhas from Health World Hospital.
So team 6 is Health World Hospital 3.
Dr. Shan Mishra from IQ City Medical College.
Dr. Abidlal Mondal, IQ City Medical College.
Dr. Shubham Kamde from IQ City Medical College.
So team 7 is IQ City 3.
Dr. Prashant from AIMS Kalyani.
Dr. Pradyot from AIMS Kalyani.
Dr. Rudrakanti Mojumdar from AIMS Kalyani.
So team 8 is AIMS Kalyani.
Dr. Swarnavar Sarkar from IQ City Medical College.
Dr. Kaushik Chatterjee from IQ City Medical College.
Dr. Obhinav Gopal from IQ City Medical College.
Okay, so team 9 is IQ City 4. So with this, we'll start a huge round of applause for all the teams, for yourselves and for the audience. Just straight back. So we move on to the questions. Ready? Question to team 1. Please check 10 seconds on the clock. Anish, if you can help me out with this. Okay. As soon as 10, you have 10 seconds to raise your hands. And people from there and people from behind will see who have raised their hands for pouncing within 10 seconds. After I finish the question. Okay? After I finish reading the question, 10 seconds. First question, easy. Pioneer to use insulin in India for the first time in 1923. Identify him. So, pounds, quickly write. Time up. So, only one team has pounced. Okay, wait. I'll just see their answer first. Okay, plus 10 to team 3. Okay, please answer on the mic.
Bent, Doctor.
Bent.
Bent.
Berry. No, not Berry. Team 2. Team 4. Team 5. Team 6. Team. On the mic, on the mic. Use the mic. I should hear the answer, so mics should be on. Not Banting and Best. Keep the volume up. On the mic, please. Team 8. Team 9. Okay, so team 3 can answer. Actually, audience. Okay, Dr. Jyoti Prakash Bose. So, though there is a controversy regarding where did he use it first, School of Tropical Medicine versus another institute, but still, he is the pioneer behind the use of insulin in India. Dr. J.P. Bro. Okay, it's a Bengal diabetes conference. So we will have questions related to Bengal. Okay, next coming up,
Identify the personality from Bengal. He is a faculty of endocrinology at IPGMER and a leading researcher. This question is to team, which team answered correctly? So no one answered, right? Team 2. Sorry, team 1. Faculty of endocrinology at IPGMR and a leading researcher. He is the driving force behind the West Bengal type 1 diabetes model. This is his picture. This is his childhood picture taken from him directly. His academic pursuits have taken place in AJC Post Road of Kolkata. Numbers are different: 165, 138, 244, St. James, NRS and SSK. He shares his name with the director of Kahani, who is seen in this picture, who is also from the same school as him. Both the persons are from the same school. Okay, school is mentioned, St. James. So, question to team 1 again. Identify this personality from Bengal. Anyone has raised? Very famous name. You have, right down there. Okay, plus 10 to team 9. You can answer on the mic, please.
Pass.
Pass. Team 3. Actually, I missed meeting him in my own institute few days back when he was there, because I was busy in one program and he came for the other program.
Indranil Bosu.
No, not Indranil Bosu.
Anurag Basu.
Not Anurag Basu. Pass. On the mic. On the mic. Nothing.
Sujoy Bose.
Not Sujoy Ghosh.
Sujoy Ghosh.
Next. Not Sujoy Bose. Yeah, the answer is Dr. Sujoy Ghosh. I'll only take the first answer. So you gave up the clue. It was Dr. Sujoy Ghosh. They picked it up. It was Sujoy Ghosh, but that was your second answer. I'll only take your first answer. So plus 10 to team 8. Where next question goes to team 9. Plus 10 has already gone for this question to team 9 because they pounced and got it correctly. Okay, so next question to team 9. This is actually taken from Sir directly. He messaged me yesterday. I had asked him 2 weeks back, but he messaged me yesterday at night. And that's Dr. Sujoy Ghosh for you, who has pioneered, and Sir is also a teacher of many of the people in this room at this point of time. Okay, third question to team 9. Indian legends in diabetes. I have had the good fortune of working with one. Obesity criteria for Indian population. The first person, the first name you will see, Madras Diabetes Research Foundation. The other, the pioneer of, the second person. Both legends. Identify them both. Now, for pounds, if you know both, then only raise your hands. If you are sure about both the names. Both the names should be written correctly. If one name goes wrong, I'll give a minus then. So, okay. You can answer on the mic. Wait. Any team pouncing? 10 seconds. দুটো ही बोलते হবে। Pounds से দুটো ही बोलते হবে। Pounds से I'll consider giving part marks, but not in pounds. So you have raised your hand. So I'm coming to you. Before you answer on the mic. Okay, I'll give plus 10. I'll give, the half name was there, but I'll give the plus 10 to team 4. You can answer on the mic. On the mic. Pass on the mic always. Okay, pass. Switch it on.
Pass.
Pass. Team 2, team 3. On the mic.
Hello.
Yeah.
Dr. V. Mohan.
Which one?
This left side.
Okay.
Left
I'll
side.
not say yes or correct or incorrect at this point of time.
Dr. Viswanathan, I think.
Okay,
right
not Dr. Vishwanathan. You have answered correctly. Team 5.
Pass.
Pass. Pass. Okay.
Sir, second person, Dr. S.B. Modhu.
And?
B. Mohan and S.B. Modhu.
Okay. So I'll give plus 5 to team 3. because they got one part correctly in the bounce, I'll be liberal. I am in Durgapur, so I will be liberal in the place where I have my first steps of my career. So +5 to team 3. So anyone from the audience? No, expect the teachers who are here, the 3 teachers and the expert quizzers. Apart from them, I'll ask. Anyone from the audience? So the first one is Dr. Anup Mishra. You wrote Dr. Anup, I'll give it right. And Dr. Vishwanathan Mohan sir. I've had the good fortune of working with him in certain things in my life. So those were the 2 names. Since Dr. S.B. Madhu is not the correct answer, so UCMS, that is not the correct answer. Okay? So +5 and +10 to team, +5 to team 3, +10 to team 4. So next question goes to team 4 because you answered something correct. Okay, we'll move on. Okay, image from 1963. Name the person and what is he carrying? Both. Write down the answer. You have pounced. Write down the answer. No, you have to answer on the mic later on. Wait. 4 direct, 3 has to write it down. They have raised their hands. Okay, I'll quickly see. Both the paths have to be correct in a pounce. First part. Okay, -10 to team 3. Answer on the mic. On the quickly give a please lend your mic.
Artificial pancreas.
Okay, and okay, next.
Pass.
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 Pass. Automated insulin delivery system.
Okay, and okay, next.
Pass.
Next.
Pass. Pass.
Okay, that was -10 to them. So anyone from the audience? Yeah, please. On the mic, please. Here's the mic. Please switch on your mics firstly. All of you are keeping it too much switched off. Yeah. Please tell. Yeah, this is the insulin pump. Many of you were near about, and the person. Okay, let's come to the answer. Dr. Arnold Kadisht and the insulin pump. Okay, so let's move on. So question goes, no one answered it correctly. Question goes back to team 4. Okay, this is a Canadian endocrinologist. You have been listening to GLP since last 2 days. All sponsors, GLP. The Canadian endocrinologist renowned for his discoveries of biological actions of GLP-1. Name it. Team 4. Anyone bouncing? No one bouncing? I think no one is bouncing, so we'll go to the team 4. Answer on the mic. Answer on the mic.
Pass.
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 Sir, Dr. John Ian.
Not John Young.
Pass.
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 Anyone from the audience? Dr. Daniel Drucker. So, Dr. Daniel, so you have been listening to GLP-1 for 2.5 days. So you should know some of the names behind the GLP-1s. Okay? So again, question to team 4. Next question. This is the easiest question. The first to receive insulin in the world and in India. Name them both. Right? Whoever is raising, pouncing, one team has pounced. Pounce closes in 2, 3, 2, 1. No one else is pouncing? Okay, so please write. Team 3 has pounced. Let's see. Write it in block letters so that it's easier for me to pull. First. Okay, minus 10 to team 3. Okay, answer on the mic. On the mic. Not Thomas Collip. Next answer. 2 answers you can give. Team 5.
Pass, sir.
Pass.
Thompson.
Full answer. I need the full answer.
First name I forgot. Last name.
I cannot give the marks unless you give the full.
Half month.
And? Yeah, half nerd. No, nothing of that sort.
Pass.
Okay.
Sir, in the world, Leonard Thomas and
Leonard Thompson.
Okay, and
in India.
okay, next.
Pass.
Pass.
Team 3 has got it incorrect. So, no, I won't give them because it was a past question. They gave the correct answer on the second try. I'll be uniform to them. So, anyone from the audience, the 2 names? Yeah, so it is Leonard Thompson, not Edward Thompson, not Thompson just, because then a lot of Thompsons are there. This is more specific. And Kumudini. Okay? So, you did not say Leonard Thompson on the first attempt. Okay? We move on. Okay, the discovery, so no one answered correctly, right? No one answered correctly. So direct question, team 4 again. Discovery of insulin, identify the 2. Right? 2 teams have pounced, write it. Write it. Any other team pouncing? This I expect everyone to pounce actually. Or I expected everyone would pounce. 3, 6, 8 have pounced. Write it quickly. I'll come. Minus 10 to team 3. Minus 10 to team 6. 6, right? Yeah. Minus 10 to team 8. So, question was to, did they pounce? Team 2, did they pounce? No, team 2 did not pounce. So, team 4, please answer on the mic.
So one is J. Colib
Okay.
and one is Charles Best.
One is Charles Best.
Plus 10 to team 4. It is not the 2 people, not the 2 names you usually remember. Everyone wrote the 2 common names you always remember. So it was James Collip and Charles Best. So did not intentionally give the commonest names you know of. Okay, plus 10 to team 4. Next question to team 5. Okay, easy one. He identified the cellular structures within the pancreas while working in Virchow's lab at the Berlin Pathological Institute. Identify him and his discovery. Both sound similar. Okay, so 1 team has pounced, 2 teams have pounced. What are the 3? 6, 8 and 9? You have not pounced? Okay, 4 has pounced. Right, start writing the answer. You have pounced, right? No, 5. Question to 5. They have answered correctly in the last one. This is to question, right, quick. Both the parts. Written? Okay, show. I want answer to both the parts. Okay, plus 10 to team 9. Plus 10 to team 8. Who else pounced? 4. No, spelling is incorrect. Minus 10 to team 4. Okay, this I will be very specific about. Okay, so minus 10, plus 10, plus 10. Team 4 minus 10. Okay, so what's the, okay, let's, team 5, please answer on the mic. On the mic.
Highlight of Langerhans.
islet of Langerhans, and name the person, identify him. You've done the difficult part already. और एक आंसर बोल दो. Nothing? Okay, we'll come back to you. Okay. Pass.
Islet of Langerhans and Langerhans.
Yeah, so common sense answer. It's Dr. Paul Langerhans and islet of Langerhans. So in this question, I'll be a bit lenient. I'll give +5 to team 5, and because they got the second part correctly also, team, this is 7. +5 to team 7 also. So next question will be directly to team 8. Okay? So +5 -10 to team 4. Team 4 only, na? Yeah. So spelling was important for me in this answer. Okay. This question, 1977 Nobel Prize winner in medicine, physiology, often referred to as the mother of endocrinology. Identify her and her discovery. Direct to team, no, 5 answered correctly and 7 answered correctly, right? Yeah, so we'll give to 6 because they got it first. Question to team 6. Others can pounce. Others can pounce. Wait, don't answer on the mic. You have pounced? Any team pouncing? Pounce. Okay, please write down. Team 2 has pounced. Both the parts should be correct for. Okay, first part, second part. You have got the difficult one correct. You get a -10. Try. I'm giving you some more time. No? So -10 to team 2. Team 6, please answer on the mic.
Pass, sir.
Okay, team 7. Team 8.
Pass.
Team 9. Team.
Pass.
You have taken the team 3.
Discover the 3D of insulin. So discover the 3D structure of insulin.
Specifically, what is the discovery?
NP.
Team 5, team 4, sorry.
C-peptide.
No, team 5. Okay, so anyone from the audience, except the 3 in the middle row, we'll come to them last if no one answers from the audience. Yeah, now Dr. Piyash can answer. Absolutely. So, doctor, that was yellow and radioimmunoassay related. So next question goes, no one answered this correctly, right? So question goes back to team 6. Okay. Frances Mary Ashcroft, a British iron physiologist. So the clue is over here. Delivered the Banting lecture 22 on the topic. The exact blanks are indicated. Okay, the number of blanks which you can see are the exact what is written in the so-called medallion or whatever. Topic was dash dash and the metabolic regulation of insulin secretion. The clue is it's related to the mechanism of action of sulfonylureas. So if you know what iron and mechanism of action of sulfonylureas could be, you will probably get your fill in the blanks correct. Okay, so if no one is pouncing, I guess no one is pouncing, you are pouncing, okay. Team 5 is pouncing. Let's see. Here I will be a bit liberal in this question. No. -10 to team 5. Okay, team 6, answer on the mic, please.
Pass.
Pass. Okay, this is a favorite MD level question also. So
Potassium.
yeah, so yeah, expand your answer. If you have to expand it a bit more, I'll be liberal in this. So if you expand it a bit more, I'll be giving you the pass.
So, potassium regulation or metabolism.
Something more?
Physiology.
I want the exact fill in the blank, so that's why I'm asking. Okay, I'll listen to the answers, then come back for the best possible answer. Yeah, please.
Potassium ATP channel blocker.
Okay, you will get your marks actually. So, the topic was potassium ATP channels. That was the fill in the blanks. So, potassium ATP channels, KATP channels was what we wanted and you have got it. So, plus 10 to team 8. Next question to team 9. No. Because they were near, that's why I would have come back if I did not get a better answer, but I got the exact answer correct. So, next question to team 9. Okay, this is the easiest one. Banting lecture 2008 from the triumvirate to the, again the blanks are indicative. It's a continuous word. What you see out there, the blanks, and the 2 blanks here is a continuous word, and then the second word which starts here. A new paradigm for the treatment of type 2 diabetes mellitus. You can see the entire thing being demonstrated. Identify the person and the pathophysiologic mechanism formulated by him. Even if you don't know the blanks, if you know the topic and the person, you will be able to do. Please write down the answer. Team 3 pouncing. Means this is the name in all your diabetes classes, probably this starts, the question starts or write down the answer. 4 is also pouncing. Chalo, dekhao. Let them write it down, don't show them. Okay, spelling here I'll take it correct. Plus 10 to team 3, plus 10 to team 4. So team, who was supposed to answer? Team 9, please answer on the mic.
The omnious octet.
Okay, and?
The omnious octet, another is a person.
Yeah. Okay, so plus 5 I will give to them. Plus 5 to team 9. One part is still left.
Only the mechanism, omnious octet.
That they have answered. You can answer.
Pass.
Okay, team 5.
Pass.
Team 6. Team 7.
Pass.
Team 8.
Omnious octet of D. Fronzo.
Okay, so plus 5 to team 8, plus 5 to team 9. Because it was a direct question to team 9, we'll move on for the next question to team 1. Okay, so Ralph D. Fronzo and the ominous octet. That was required. So part answers we got. Plus 5 and plus 5 to team 8 and 9 and plus 10 and plus 10 to team 3 and 4. Okay, question to team 1. Okay, name the criteria and the condition for which this criteria is used. Age of onset less than 25 years, strong family history, and this has also been discussed yesterday night. Okay, between 7 and 9 o'clock at night, this was discussed. Absence of ketoacidosis, no evidence of ketoacid, fairly well preserved beta cell function. Name the criteria and the condition. Team 1 direct. So write your answer. So criteria has a specific name, write it down. Yeah, 2 teams have pounced. Write down. Write written. Only 2 teams are pouncing? Okay. Okay, this is the one part. The other part, if you are pouncing, you have to get both the parts correct. Yeah, whatever, yeah. No, not the full form of this. That's fine, I'll take that answer. No. Minus 10 to team 9. Minus 10 to, you write down quickly. Write something on the right track. Then I can get ready team 1 to answer them when I tell you. Wait. Done? Minus 10 to team 4, minus 10 to team 9. Answer on the mic.
Sir, condition is LADA, not
LADA and 2
criteria.
parts. Okay, if you are pouncing, you need both the parts to be correct. Team 2, pass. Team 3, on the mic, please. Keep your mics on, please.
Condition is Modi.
Okay, and?
Name of the criteria.
Okay, team 5. Team 6, Team 7, Team 8.
Modi criteria.
Question was to Team 1. So Team 3 gets +5 because they answered a part of it correctly for the first time. Okay, anyone from the audience? Criteria's name, which was depicted. Okay. So Tattersall and Fajans. So it's a book. If you see the book written by Dr. Vishwanathan Mohan, he has referred to Dr. Tattersall and Fajans because he has worked under one of them. So, and criteria for Modi. Okay. So +5 to Team 3, -10 to Team 4 and 9. This is bounce. Bounce, no half. So, next question. You can see a very good cartoon. Name the criteria. If you see understand the cartoon, you can get a clue to it. You have to maybe rule out one word. And what is the condition? You see a score. You see something about blood flow. You see something about sight. You see something about maybe ischemia. You see something about neurological features. You see something, plus clinical infection present. Ulcer size means area something. So what is it? Direct to team, no, they answered it Team 4. The question is Team 4. Team 4, please answer it. There's a picture clue to it. Somehow similar sounding to the, something to do with a childhood days, maybe. You can put something. It's not exactly, but still.
Diabetic neuropathy.
Not diabetic neuropathy. Next.
Diabetic foot ulcer.
There are multiple criteria. You have to just pick and choose one.
Diabetic foot ulcer.
Okay, I'll come back to you. Second. Criteria name. Criteria name. Something which you can relate with this picture. Okay, next team, I'll come back to you. Team 7.
Land criteria.
Not land.
Sir, rocker bottom foot, Charcot's joint, 3 criteria, Eikenhorst criteria, Sanders and Freiberg criteria, and Bott's criteria.
What is this one? Which is being reflected out here?
Rocker bottom foot,
No.
Charcot's joint.
Team 9.
Charcot's joint.
Team 9.
Di
Anything? Yeah, please.
Diabetic foot ulcer.
Okay.
And, CAP.
CAP. No, CAP, not CAP. Okay.
Pass.
Team 2.
Pass.
Team 3 did not attempt. Anything on the mic? This was you are not listening to instructions. Okay, we'll move on. If you're not listening to it, I can't help you further. So, anyone from the audience? Yeah, there is a theme song, or many things are there by that name. Yes. So, can we have some answers? No? Okay, let's go to the criteria. It's Sinbad and diabetic foot ulcer. So, team 5 will get +5. We'll give +5 to team 5 because they got diabetic foot ulcer correct. No, they got it first. Team 6, question to team 6. Okay, the last few questions will be very fast. I'll finish by 6:10 to the organizer, 6:10 to 6:15. Okay, name the clinical scoring system for diabetic polyneuropathy. The scoring probably is, some of the reflections are given and clues are also given in this image. So, team to question 6. If you are careful, you should get your answer. You should get your answer if you look at the entire slide carefully. Entire slide, yes. Team 6. These are some of the questions which you have to, it's a googly. Let's put it, it's a googly. The answer is evident. Team 6, anything? No one pouncing, right? No one is pouncing. Okay, team 6. Team 7. Any answer?
Pass.
Team 8?
Sir, MNSI scoring system, mykigan neuropathy scoring.
No, it's not MNSI scoring system.
I'm sure. So, something related to Toronto.
Yeah, just say something.
Toronto classification.
Okay, plus 10. The answer was on the slide. The Toronto Raptors are shown. Toronto is not very clear. You're just gone, and this is the famous Sahara Cup of the 1990s, which we as a child used to see, where this is the second year in 97 where Saurav Ganguly got the man of and the classification. So it's the Toronto clinical scoring system. So plus 10 to team 9. So the answer was there. I just wanted the name Toronto from your mouth. So question to team 1. Okay. Identify this classification used to stage diabetic foot ulcers according to tissue involvement and gangrene, but not ischemia or infection severity. Pouncing, okay. Please write down the answer. 8 is pouncing. Any other team pouncing? No? Okay, let's come to team 8. Please write down. Plus 10 to team 8. Okay? Team 1, answer on the mic, please.
Pass.
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 CEAP classification.
Not CAB classification.
CEAP.
Not CAB classification.
Pass.
Pass. Pass. Not Charcot's. Team 9. Okay. So team 8 only got it correct on the pounds. Anyone from the audience? Oh. Yeah, so let's go to it. Megid-Wagner classification. And the next question goes to team 1 because no one answered it correctly. So this round is coming to an end. After this it will be buzzer round. Almost 3 more questions left. This product was the first of its kind to be introduced and used in India for the treatment of diabetes mellitus in 1923-24. Okay, let's put it. This product specifically came in 1924. Mention the specific name of the product. So I want the specific name, like if it's Mysore sandalwood soap. So just saying soap won't fetch you the marks. You have to say Mysore sandalwood soap. So answer has to be that specific. It could be some letters also and some products name. Even that would be taken even if you can't get the whole name correct. But those letters have to be correct along with what the product is. Product is, I think, very obvious. So this is question to team 1, right? Anyone pouncing? No? Let's move on. Team 1 on the mic.
NPH insulin.
NPH insulin, no. Next.
Pass.
Next.
Human regular insulin.
Not human regular insulin is the answer I want.
Bovine insulin.
Not
Sir.
bovine insulin is the answer. Next.
Pass.
Pass.
Sir, humulin.
Not humulin.
Human mixture.
Not human mixture. Anyone?
Sheep insulin. Sheep,
From the audience?
Sir, sheep.
No. The answer is AB insulin. If you had given Amitabh Bachchan insulin, AB insulin, not Amitabh Bachchan, AB insulin, that would have been correct. It's Allen and Hansbury Limited and the British drug houses. So insulin, so A, B would have fetched you the answer also of the full names. Okay, so we move on. Second last question of the direct round. What is the term used to describe a fellow, friend, peer support partner with diabetes mellitus who shares the daily journey of managing diabetes? This is one of the logos also sometimes used by certain companies. What is this term called as? Team 1. So a friend of a diabetes patient. What term can he use? Think about the modern generational terms which you can. Anyone pouncing? I think no one is pouncing. Okay, team 1.
Pass.
Pass. Team
Pass.
2. Team 3. Not diabetic.
Diabetic mate.
Not diabetic. Mate. I'll come back to you. I'll come back to you.
Bloodmate.
Not roommate.
Blood.
Not bloodmate. Then Pass.
Diabetic partner.
Not diabetic partner. Not diabetic peer.
Sugar mate.
Not sugar mate. Question was to team. You want to try? Yeah.
Diabesties.
Diabesties. Okay. So there are multiple terms. So actually, if they had answered it when question came to you, diabesties is one of the terms. I have put one answer as diabody, but diabesties was also a correct answer I would have taken. Okay. So no one answers it, but a huge round of applause for them. So that would have fetched you, but you could have answered it a bit before. Okay? No, you don't get the point, sadly. Okay, last question for the direct, then we go to the buzzer. Quick. Okay, question is to team 1, right? No one got it correct. So, name the first drug of this group approved by FDA in March 2013. You can see certain things, sunshine and something, and you can see a mechanism directly taken from Dr. Someone's slides who came to Kolkata and we witnessed it. We heard. Great question to team 1. Team 2. Team 3. Team 4. Team 5. Wait, we're coming to Team 5.
Canagliflozin.
Canagliflozin. Correct answer by team 5. Plus 10 to team 5. So now we'll ask the scorers to quickly sum up this part. We will move on to the buzzers because we don't have much time left. I've already taken a lot of time for this. So we'll move on to the buzzers. Now we would request everyone on stage and everyone off stage, especially the 3 people out there who are helping me out, who raises their hands first. Buzzer, no buzzer is available. Whoever raises their hands first, so raise it properly. If you raise it like this, no one will see from behind. So raise it properly, do all the exercise. Plus 10, minus 10. Okay, plus 10, minus 10. Get ready, questions are easy now. Ready? So the buzzer round is going to start. Quickly we'll go. Plus 10, minus 10. Please raise your hands properly and answer on the mic. If the mic is switched off, I can't hear. You don't get your marks. Minus 10 direct. I will not ask this time anymore. Question. What is the most likely diagnosis? A 83-year-old woman with type 2 diabetes presented with a 6-month-old history of painful rash.
Sir.
Okay, on the mic.
Sir, necrobiasis, erythema migrans in glucogonoma.
So what's your diagnosis?
Glucagonoma.
Okay, plus 10 to team 8. Next, it's glucagonoma. Next, we move on. Name the 2 hypotheses. So this was a new question for even one of my teachers who I shared this question set with. One is something which you well know. One is the scenario 1 where it was more related to famines, and one is a counter to that which has come up recently that is not due to the famines which has caused this. So can you quickly tell? Anyone? No? Anyone from the audience? On the mic? What hypothesis? One is thrifty gene hypothesis, that is scenario A. What is scenario B? It's the drifty gene hypothesis. It's not thrifty and drifty gene. A is thrifty, B is drifty. Okay? Next question. What is the most likely diagnosis in a person who is using insulin?
Lipodystrophy.
Okay, we'll take that answer. Plus 10 to team 3. Insulin induced?
Lipodystrophy.
No, it's a buzzer. You have to raise your hands and they have to see. First. Okay, please help me out. Who raises their hands first? So insulin induced lipohypertrophy. I'll take that for an answer. Plus 10 to them. Okay, next. Name the finding. It has multiple names. Something similar sounding, I'll give the marks. 55-year-old man diagnosed with diabetes mellitus 1 month back. Okay, team 3. Minus 10 to team 3. No, one team only. Minus 10 to team 3. So this is yellow palms and soles in diabetes, or xanthosis diabeticorum. Okay? We move on. -10 to team 3 for this. Name this metric of glycemic control. Okay, team 8.
Sir, it is TIR. It is time in range.
Okay, +10 to team 8. Next. Name this specific device. Please listen, wait. Before you raise your hands. This has a specific name, so company's name becomes important. Just saying soap will not help you. You have to say Mysore sandalwood soap. Right? So now, who is raising your hand? The 3 will wait for them. We'll be liberal in this, because this. So, this is an implantable device which was approved in 2018 for use for 90 days. Later on now, it's approved for 365 days. So, you don't just give me the generic name, you have to give me with the company's name also. You are raising your hand? No? Will audience? You are raised your hand. Okay, they are raising their hand.
Sir, already answer given, sir.
Okay, we'll not take the answer because not discussed, but no one has answered. So answer is from the audience. Ever since continuous glucose. Please don't prompt from the audience. That's my only request. Ever since CGMS. This is type 1 diabetes.
Sir, first.
Wait. Don't answer on the mic till I tell you. Wait. Okay, team 8 has raised, but type 1 DM with toothache. Identify the clinical condition. No. Name the clinical condition. Team 8. Team 8.
Sir,
both parts have to be correct.
Identify the clinical findings and name the clinical.
Quick.
Sir, rhinocerebellar mucormycosis, sir. And we have to answer the MRI findings.
No. Identify the clinical finding which you can see. No?
Sir,
it is black crusted necrotic. It is black crusted necrotic nose.
No.
Angio invasion.
-10 to team 8. So this is, I wanted the word S chart to be there, and mucormycosis, you have got it correct. Okay, next question. Okay, please raise your hands properly. Identify the specific name, the peptide, specific name required and not the generic one. Which team?
Sir.
8.
Sir, this is a Gila monster, sir, hexanatide. The component is hexanatide.
The peptide I wanted.
Hexanatide, sir.
No.
Exentin 4.
I'll only take the first answer. -10 to team 8. Okay, it was Exendin 4. Okay? So, I wanted the specific answer. So, please don't hurry up. Then give your answer. It was Exendin 4. Next, a 49-year-old hotel chef, this was from a Sri Lankan case report, presented with subacute painful weakness and wasting of the left upper arm for 3 months and weight loss. Left upper limb proximal muscles were also wasted with diminished power and reflexes. INCT showed comparative amplitude reduction. I want the name of the syndrome. If you tell me this is the diabetic this, that won't help you. But you have to tell me the name of the syndrome which is there. If I say diabetic retinopathy, won't help you. But you have to tell me the specific name of the complication, the syndrome, what it is called as. Okay, it's used primarily for the lower limbs. Anyone? No? Okay. It's called as the Bruns-Garland syndrome. Okay, diabetic amyotrophy, if you have told, I would have still considered but not given you the marks. Not given you a negative maybe, but not given you the positive marks also. But this was the Bruns-Garland syndrome. Ready for the next question? What is the diagnosis? Team 3.
Bronze diabetes.
+10 to team 3. It's bronze diabetes. Okay, so next question. Get ready. Name the investigation which you can see here, the images of. It's a 60-year-old male, type 2 diabetes of 20 years, tingling over feet, biostachiometry, 45 volts VPT, fundoscopy shows retinopathy. Name the investigation which you can see here. What is it called? I think Rana sir from SSKM has one of the earliest papers on this topic from West Bengal. It is a part of ICMR project once upon a time. Team 9, please.
Fluorescent angiography, FFA.
It's not fundus fluorescent angiography. It is corneal confocal microscopy. Minus 10 to team 9. We move on. Next question. 20-year-old newly detected diabetes mellitus. Blood pressure is raised. Muscular build. Hepatomegaly, hyperuricemia. ALT is raised. Name the broad diagnosis. I want the broad diagnosis. Okay, you have raised your hand on the mic.
Berardinelli-Sheep syndrome.
Okay, it's one of the lipodystrophy syndromes, so I will take it. Plus 10 to team 8. So he has gone more specific. I would have taken lipodystrophy syndromes together. Okay, so it was yesterday discussed in Sir's slide. One of the second last talk of the day yesterday. We move on. Okay, a 42-year-old team 3. Before I mention the specific diagnosis, the specific related to the pictures. On the mic.
Flatbush diabetes.
Okay, what's the problem in keeping the mic on? So it's flatbush diabetes plus 10 to them. Okay, so basically initially had a high blood glucose and initially managed with insulin. Subsequently, it became managed with OHs and all also. Because I have given a specific picture, that's why I wanted the name as Flatbush. Flatbush is a suburb in New York. So that's why the specific picture. Okay? So Flatbush diabetes. Next question, get ready. A 46-year-old female with type 2 diabetes of 12 years on insulin with left renal angle tenderness. 2.
Sir, emphysematous pyelonephritis.
Emphysematous pyelonephritis plus 10 to team 2. Okay? Please some applause for them. Audience, we are rushing now. We have 3 minutes 58. We have to finish on time. Okay, so it's emphysematous pyelonephritis. Next question. Two-part answer, so you have to get both parts correct. What is the clinical diagnosis? What is the name of the anatomical classification system based on the site of involvement?
Sir, it is Charcot's joint.
Okay.
And the anatomical classification system is Sanders and Freiberg classification.
Okay, plus 10 to team 8 is the Sanders and Freiberg classification and Charcot's foot neuroarthropathy. Very good. Next we move on. Identify this characteristic lesion, again discussed in the last talk of yesterday. This lesion found in the patient with type 2 diabetes mellitus, described as focal, lobular, round to oval mesangial lesions with an acellular hyaline matrix score 8. On the mic. On the mic, please.
Amyloidosis.
Minus 10 to team 8.
Islets and amyloidosis.
Minus 10 to team 8. So, no, Akbari minus out. So the correct answer is Kimmel-Style-Wilson lesion. Okay, we move on. KW lesion would have fetched 2 marks also. Identify this diet. Number 3, team 3. Wait. Team 3 or team 4? So we'll go from here. Team
Mediterranean diet.
Mediterranean diet plus 10 to team 3. Okay? So plus 10 to team 3. Again, single time, not double time. Some applause from the audience, please. The audience has to get involved.
Sir, can we have the score, please?
Yeah, can we have the scores? Okay, etar pore. A particular property of a molecule X was pursued by French physician Jean Stern, who first reported the use of the molecule X for the specific property in 1957. It is linked to Galega officinalis. It was rediscovered in search for antimalarials. Team 3? Okay. Metformin is the correct answer. So can you have the scores before we go on to the last 6 questions? Team 3. So what's the score right now? Some applause for the teams, please. Team 1. So they're trying to open their accounts, no problem. Plus 30 to team 3. 10 to team 4. 10 to team 5. Minus 10 to team 6. No problem. Applause for everyone together. Team 7. Plus 5 to team 7. 45 to team 8. 35 to team 9. So if anyone's 6 questions are left, I think. 15. 5. Okay, 5 to team 5 to team 9. Okay, so it's plus 5. So still lot of questions. One team alone can get all the 6 and win the quiz. So it's not yet over. Team 1, team 2, other teams, you can still win the quiz. It's open to all now. Get ready. Next question. Okay, name this trial. It's a multicentric randomized controlled trial where 1,441 patients were taken into to evaluate the effect of intensive glycemic control compared with conventional therapy on long-term complications of type 1 diabetes. So intensive therapy wing and conventional therapy wing, there was a mean HbA1c improvement also along with observations of microvascular complications. So which trial is this? You have raised your hand? Okay. You can sit and answer also. On the mic.
Sir, diabetes in control complications trial.
Okay.
It is
trial.
followed
No,
up with ED.
Not required. Okay. Plus 10 to team 8. So it's a DCGT trial of the diabetes control and complications trial. Next question. Get ready. Please get ready. This can be easy one. Name this trial. A multicenter randomized control placebo-controlled trial to evaluate the cardiovascular morbidity and mortality associated with liraglutide. GLP. Wait. This is the in line with FDA's current recommendation. Okay. So team 8.
Sir, it is a leader trial.
It's the leader trial. So it's the election season. We are in Durgapur. So that's why we brought something related to the election flavor. So it's the leader trial. So liraglutide effect and action in diabetes, evaluation of cardiovascular outcome, results trial. So whoever raises your hand during the question time, even before the completion of the question, their hands will be considered and you can get minus 10 also if you answer it incorrectly, even if you don't know. So be careful. Okay?
Sir,
okay, this is plus 10 you got. Now let's move on. 4 questions. Name this trial where this is related to pregnancy. Just now you got a talk on early gestation, means early gestational diabetes, but this is about the 75 grams glucose tolerance test where a lot of subjects were studied and the effects of diet control versus not on the outcomes related to pregnancy. So there is a specific name. Okay, what can this be? You can give me the short form, you can give me the full form also. In Bengali, something similar we take or sound it off like something, we won't take so much trouble and all, something but not the exact. We won't take so much trouble. It's a colloquial way of saying something similar sounding. Whenever a lot of unwanted things come, we think of like that. It sounds something similar, the short form. It's Jhamela's other forms. Synonyms of Jhamela, which you can remember in Bengali, and similar sounding trial, the short form at least. Okay, no one answering. Is the HAPO trial, hyperglycemia and adverse pregnancy outcomes trial. Okay, so HAPA was the word similar sounding. Last 3 questions. Name this trial. It has something to do with sweetness, which you have done, and how good we have all been, or how good the organizers have been to us. So we thank them, and that's why we have this question in place. It's related to some country's organization, but the way it sounds, it's like everything is going fine. Another synonym of fine maybe. So what's the name of the trial? And add something sweet to it, you will get your answer, which you have had in the afternoon also for lunch. Ready? No one answering from the audience. We'll involve the audience for the last speech. So to the organizers, it was a very nice conference. So thank you, and we had wonderful sugary items. So it's a nice sugar trial, which I was alluding to. Okay? Last two questions.
Sir.
Not Shahid Afridi. Name this concept which is being alluded to.
Sir.
8.
Sir,
okay.
This is Yajnik and Yudkin paradox.
Name the, okay.
YY paradox.
Okay. Name of the concept is the Y and Y paradox. Initially I used to think this is Shahid Afridi, but it is not so. So it's the YY paradox, Dr. Yagnik, Dr. Yudin, and the thin fat Indian phenotype. The last question, plus 10 to team 8. So again, a thank you to all the organizers for allowing me to host this quiz. Thank you to the teams. You have done wonderfully well. Participating in a quiz itself is a big thing. And thank you to all the teams from a personal point of view, and thank you to all the people who have helped me both on and off the stage. Last question. If you know my wife's name, the answer is something related to my wife's name. So it's a dedication to my wife, who has helped me in formulating the quiz questions always, whenever I have quizzed anyone. So this is a hypothesis which is being talked about, which talks about the HbA1c and its relation to fasting and postprandial. What it can be, or the contributions of fasting or postprandial to the HbA1c. What is this hypothesis known as? Anyone? If not, I'll go back to the audience. So no one is answering. Last question of the quiz. Okay, we'll go to the audience. Anyone? Not Shomili. Any other answer? Anyone from the audience? So it's Monnier hypothesis. Okay? It's Monnier hypothesis. So some of the people know my wife's name, so they could have guessed the initial part. They could have got the answer. So it's Monnier's hypothesis. Thank you to all the teams. I hand over to the scorers and the organizers before we end the quiz. But thank you everyone. Thank you everyone. Paul, any doubts with the scoring? He ekbar chole ja. I action ওদের একটু doubt আছে scoring. চলে যা স্যার দাদার কাছে চলে যা একবার. Okay, team 9 will clear off all the doubts. We'll end the quiz without any controversy, so that's why we'll clear off all the doubts. Just like a class. And thank you to everyone, because I have taken the questions inspired by all the speakers over the last 2.5 days. Third.
So the third team is.
So second runners up is
Team 9, which came from IQ City 4.
Okay, IQ City Team 4. Team 9 comes as the second runners up. A huge round of applause for them. IQ City Team 4. Okay, please again tell your name from the mic.
Dr. Swarnav Sarkar.
Dr. Abhinav Pal.
Dr. Kaushik Chatterjee.
Okay, huge round of applause for them again. First runners up.
Congratulations. The first runners up is Team 3 from Health World.
Team 3
1.
from Health World. Team Health World 1, right?
Health World 1.
Cool.
Okay, give them a better mic, please. Give them a better mic. They've struggled with the mic throughout the quiz.
Along with the mic, actually.
Yeah,
Dr.
please.
Sayok.
Dr. Kushal.
Kushal and
Dr. Abhinandan.
Wonderfully, well done.
They did a great job with the bounce and pounce, actually, if you look at the scores.
First runners up. Actually, they are doing very well. I think the negatives took away probable potential first prize from them. Okay, then.
And the winner of today's quiz is Team 8 from AIMS Kollani with a
Team
score of
8 from
75.
AIMS Kalyani score.
Congratulations.
Okay, congratulations, Team 8. Your names, please. On the mic. them a mic.
Sir, Dr. Prashant from AIMS Kalyani.
Dr. Pradyot.
Dr. Rudra from AIMS Kalyani.
Congratulations to all the winners, but congratulations to all the participants. It takes a lot to come onto the stage. So thank you and congratulations to all. Thank you. Thank you. Thank you to all the people who have helped me out. Thank you. তোর মাইকটা কোথায় খুবই খারাপ অবস্থায় ছিল তোরা কোথায় খুব ক্লোজ ছিলিস তোরা একটা কোশ্চেনের জন্য আমি তাই জন্য সময় দিচ্ছি লেখ লেখ হ্যাঁ চলো থ্যাংক ইউ
All participants will also get the participation certificate. So I'll request all our beloved PGTs to please stay back. Participation. No. মানে এইগুলো প্রাইজ ফার্স্ট সেকেন্ড থার্ড এগুলো হ্যাঁ এইটা ফার্স্ট সেকেন্ড থার্ড আর নিচেগুলো পার্টিসিপেশন সবাইকে দেবো এটা কি ফার্স্ট নাম লিখে দাও ফার্স্ট সেকেন্ড থার্ড এটা হচ্ছে সেকেন্ড এই তোমার কাছে ইয়েটা রাখো তো সময় তোমার খামগুলো দেবে পরপর হ্যাঁ
ফার্স্ট প্রাইজ হচ্ছে এমসি
এদিকে রেখে দেবে কি ফার্স্ট প্রাইজ এটা ওরাল এটা কেস প্রাইজ পোস্টার সেকেন্ড ওরাল পেপার সেকেন্ড
ওটা থার্ড আছে
এটা ওরাল পেপার থার্ড আর এই পোস্টারের থার্ড দুটো আছে এটা এই হাতে রাখো এটা এই হাতে রাখো ঠিক আছে আর ওইখানে দিয়ে দাও
কাকে দেবো
তোমার হাতে রাখো এইটা দাও এটা কি
এটা ফার্স্ট যারা হয়েছে তারা এমসি মানে কুইজ
একটু ওয়েট করো দিয়ে দিচ্ছি না ওরা পড়ে নেবে ওগুলো কিছু দিতে হবে ওকে আই উইল রিকোয়েস্ট ডক্টর তারকনাথ চট্টোপাধ্যায় তারক রেজাল্টসগুলো রেজাল্টসের পেজগুলো নামগুলো একটু দেখে দেখে দিতে হবে সার্টিফিকেট
আচ্ছা থার্ড দুটো থার্ড লিখেছেন
জয়েন্ট থার্ড আছে ঠিক আছে এটা ওরাল পেপার আগে কুইজের প্রাইসটা দিয়েছে
একটা ভ্যালিডেটরি ইয়ে বলে দেবো কি
ভ্যালিডেটরি তো আগে প্রাইস ডিস্ট্রিবিউশন করে লাস্টে তো ভোট অফ থ্যাঙ্কস হ্যাঁ এর নামটা
আগে কুইজটা হয়েছে কুইজটা বলে দাও
থার্ড সেকেন্ড ফার্স্ট এরকম করে বলবে কাকে ডাকবে প্রাইজ দেওয়ার জন্য রাকেশ তাকে ডেকে নাও বৌধান তাকে ডেকে দাও ওকে দিয়ে প্রাইজ দেবো
হ্যাঁ কুইজ মাস্টারই প্রাইজ দেবে
কুইজ মাস্টার
May I request Dr. Bodhan Das Munshi, Dr. Rakesh Kumar, and Dr. Vinit Kumar to please come up to distribute the prize for the quiz competition.
I'll announce the team and please come to the dais to receive your prize. The third prize goes to IQ City Medical College, Dr. Swarnabho Sarkar, Dr. Obhinabo Pal, and Dr. Kaushik Chatterjee. Congratulations, IQ City Medical College, for securing the third position in the quiz competition of BDCON 2026. Amongst the PGT participation, IQ City Medical College was the foremost, securing highest number of PGT participation in BDCON 2026. Give a round of applause to the entire IQ City Medical College faculty, all the doctors and all the students. I'd like to invite second position, Health World Hospital, Dr. Shayok Chattopadhyay, Dr. Obhinandan Maiti, and Dr. Kushal Gatai. In terms of PGT participation, Health World Hospital was second. Maximum number of presentation from a non-medical college organization. A round of applause for Health World Hospital and for myself. Now, the first prize, AIMS Kalyani, Dr. Rudra Kanti Mojumdar, Dr. Pradot Kumar Amath, Dr. Gajupalli Prashant Kumar Reddy. They have secured the first position in the quiz competition of BDCON 2026. Congratulations to AIMS Kalyani and their faculty, Dr. Bodhan Das Munshi. Thank you, Bodhan Da, Rakesh Da, and Dr. Vinny. Now I would like to invite Dr. Arpan Roy Chaudhary, Dr. Arindam Hajra, and Dr. Shoshnayan Chakraborty to please come up on the dais. The life of a conference lies in the PGT participation. I believe that. Dr. Niranjan Sengupta told us this morning only. In terms of PGT participation, we categorize as two things, e-poster and podium presentation. We expected none more than 10 for the presentation, but an overwhelming 39 presentation was submitted. We could not give everyone for the podium presentation. Only 6 selected one was presented in the podium. Rest all were e-posters. All of them were fantastic. All of them were intriguing and very enriching to all of us. From them, I would like to invite the e-poster session. The third prize was jointly shared by Dr. Shayok Chatterjee from Health World Hospital, and Dr. Namrata Tantri from IQ City Medical College. This time it's a draw between Namrata and Shayok. Congratulations, Shayok and Namrata. The second prize of the e-poster session Porida. বড় চেকটা পাওয়া যাবে না বাড়িতে নিয়ে যাওয়ার জন্য I will announce the second prize of the e-poster session.
At GoDaddy, we help you take that first
Dr. Ronita Mukherjee, Health World Hospital.
From getting your domain to create.
She also done a fantastic job as a master of ceremony of this whole session, along with Dr. Anurag Banerjee. Dr. Ronita, congratulations for securing the second prize in e-poster session. Coming to the first prize, Dr. Swarnabha Sarkar from IQ City Medical College. Congratulations. All the e-posters were evaluated by the stalwarts of the endocrinology of all over the world. We tried to come up with a beautiful team of judges for the e-poster sessions. As always, podium presentation. As always, the 6 selected ones were presented in the podium, and they were the crux of the presentation altogether. For the podium presentation, third prize goes to Dr. Praveen Kumar Jadhav from Health World Hospital. Congratulations, Dr. Praveen. For second prize, I would like to invite the only case presentation given the podium session, Dr. Riya Pandey from DSP Hospital. The excellent case presentation make the judges give her the podium presentation as well. All other were paper presentation. Excellent work, Dr. Riya. Excellent. She is the only one representing DSP Hospital in this BDCON 2026. Now I would like to invite the first prize, Dr. Prabhas Ranjan from Health World Hospital. Congratulations, Dr. Prabhas. Surely, sir. এখান থেকে না না কাঞ্চি কথা হাসছি তো খুশিতে আসু হ্যাঁ
পার্টিসিপেশন গুলো একটু বলে দাও
কিসে all those who have participated in the quiz competition, e-poster session and all the podium competition, all the judges, they were befuddled that in a such regional conference 39 presentation, it's overwhelming. Congratulations to all of you for taking the sleepless nights, repeatedly sending me abstracts in the last day of conference itself. You can collect your participation certificate from the counter. We have not written the names as we don't know the spellings. You can write it on yourself. As we close the ceremony of BDCON 2026, I would like to thank all the lecturers, all the chairpersons, all the moderators, and specifically, I am thankful to all the BDF working committee members, all the scientific committee members for presenting these excellent scientific sessions, doing the sleepless nights for putting together, and all those members who are working behind the curtain day in, day out to make this program a successful one. I would like to thank all our sponsors for arranging such an event successful. And lastly, I would like to thank Dr. Amita Biswas, BDF chairperson, for bestowing upon us this humongous task of an organizing secretary to me and Dr. Shubham Das. Thank you, sir. Thank you for his vision. I would like to thank Dr. Rakesh Kumar, Dr. Arpan Roy Chaudhuri, Dr. Shoshnayan Chakraborty, Dr. Vinit Kumar, Dr. Arindam Hajra for being there. And I would like to invite Dr. Biswas to say a few more words. Next year. Dr. Shoshri, please come. একটু নাচ করতে হবে আর কিছু না
Thank you. It will be very good if Dr. Biswas say a few words. Finishing touch. Yeah. Thank you, sir.
Thank you, everybody. As a declaration for the next year, 2027 BDCON, it will be on 6th, 7th, and 8th August. 6th, 7th, and 8th August 2027. So I request everybody, please be prepared for that. Next year, we should have another better conference than this year. Thank you. Thank you very much. Absolutely.
I request entire BDF team to come over here. Bodhanda. Stage for a group photo. Pranoy, where are you? Pranoy, Anurag, Ranita. Please come over on the stage. Rajesh da, Arpan sir, Dr. Manosh, ache? Dr. Manosh, Pranoy, Achish. Anybody have PDF now?
Any leftover PDF member there? মাস্টার সাহেব দুটোকে ডেকে নে এই তো আছে তো সবাইকে নিয়েই তুলেছি সুবিনীর পাননি এখানে রাখা দিচ্ছি পেয়ে যাবেন স্যার পরে এনে রেখেছি আপনি পেয়েছেন সার্টিফিকেট তো নিয়ে নেবো ফ্যাকাল্টি এটা নিয়ে নিন একটা তুলে নিন আমারও পাইনি